Hello. Hello.
Yes, sir. Yes, sir.
Yes, sir. Please start. You are audible, sir. Please start, sir.
Okay. Hello. Good morning to all. I welcome everybody to this virtual 49th ISA ODISHA WebCon 2020-21, first of its kind in its history.
So can you please on the camera?
Myself, Dr. Kamalakant Pradhan, as EB member, also moderator for Professor P.K. Tripathi Memorial Scientific Presentation. Now, I invite the judges for this session. The judges are Dr. S. Balabhaskar, he is the first president of ISA and editor-in-chief of IJ. His contribution in popularizing IJ and raising its standards is worth mentioning. Our next judge, Dr. Rakesh Garg, is the additional professor of anesthesiology, critical care, and pain at Dr. B.R. Institute, Rotary Cancer Hospital, AIMS, New Delhi. Also editor of IJ, Journal of Anesthesiology, Clinical Pharmacology, and Journal of Medical Care Reports. So, I request the judges kindly to be online for the session.
Thank you, sir. Thank you so much.
Now, regarding Professor P.K. Tripathi Memorial Scientific Presentation, there are 15 participants. As per the rule, each participant's time allotted is 7 minutes for presentation, 2 minutes for question by the judges. So, one request for every participant that they should strictly adhere to the time schedule. So, can we start now?
Good morning, Dr. Pradhan. One suggestion is, at 6th minute, somebody should be, cautioning the speakers that 6 minutes are over.
Okay, sir. Okay.
Can somebody do 7 minutes? You said is the time. 6th minute, somebody should say 6 minutes is already over, because we cannot allow them to.
Okay.
They will reduce their presentation and finish in 7 minutes. Okay. Thank you. Thank you. We can go ahead, Dr. Rakesh.
Yes, sir.
Please.
We can proceed, sir.
Please go ahead. First presenter.
So our first participant is Dr. Monisha Sahu.
Good morning, sir. Am I audible?
Yeah, please go ahead.
Good morning, all. I'm here
Nisha,
to
can you please
present
on your camera?
yes, sir. Yes, sir. So the camera is on as well.
Not
Good
yet.
morning, all. I'm here to present my topic.
The camera is not on.
Yes, sir. Okay, sir.
Just there is a start video button.
Say now. Hello. On.
Manisha, can we start?
If there is problem with you, you can go to
Hello.
there is risk of technical issues, network related issues. Whoever is ready can start also.
Hello, Manisha, can you start?
Hello.
Yes, yes, you are audible.
Can we go over to the next speaker, please? And we can come back to Manisha later on.
Hello.
Yes, Manisha, you may start now. But if you are having issues, we'll go to the next speaker. Kamala, please go to the next speaker. Don't lose
Sorry, ma'am.
time.
Yes, I am calling the next speaker,
Yes, she can come later on.
Dr. Priyadarshini K.
Manisha, please unmute yourself.
Okay, ma'am.
Please unshare your slide. Manisha, stop sharing your slide. Manisha, please stop sharing your slide. Now let us move to Priyadarshi.
Yes, ma'am. Just a minute.
Finish. Over.
Can I start, ma'am?
No. Priyadarshi can start now. Okay.
Good morning, everyone. I'm Dr. Priyadarshini from AIMS Bhubaneswar. The topic of my paper is comparison of ultrasound-guided transversus abdominis plane block, ilioinguinal iliohypogastric nerve block, and quadratus lumborum block for post-operative analgesia in children undergoing inguinal hernia repair. Inguinal hernia repair, one of the common daycare procedures done in children. Pain following daycare surgeries is associated with behavioral disturbances in children and increased time away from school. Various modalities are available for providing post-operative pain relief. But the current trend in anesthetic care is to use regional anesthetic techniques, thereby reducing the systemic use of opioids and thereby its side effects. Ilioinguinal iliohypogastric block and transversus abdominis plane block are commonly performed regional anesthesia techniques following inguinal hernia surgery and are shown to significantly reduce pain associated with it. Whereas quadratus lumborum block, a novel regional anesthesia technique which provides somatic and visceral analgesia of the abdomen, has not been explored in pediatric inguinal surgeries. Hence, we want to conduct the present study comparing the analgesic efficacy of these three blocks in children undergoing inguinal hernia repair. We hypothesize that the quadratus lumborum block provides longer period of analgesia as compared to ilioinguinal iliohypogastric block and transversus abdominis plane block. The primary objectives of our study is to compare the analgesic efficacy of the three blocks in terms of time to the first demand of rescue analgesia. For the secondary objectives, we have compared the FLAC scores which are recorded at various time points till discharge from hospital. We've also compared the intraoperative fentanyl requirement and total postoperative analgesia requirement. After approval from the Institutional Ethics Committee and CTRA registration, we have started a study at AIIMS Bhubaneswar. The study undertaken is a randomized, controlled, double-blinded trial. We have included pediatric patients aged 2 to 12 years undergoing inguinal hernia repair after getting written informed consent who have agreed to be a part of our study. We also had a few exclusions like refusal to give consent, known allergy to local anesthetics, coagulopathy, and infection at the injection site. For randomization, we had a computer-generated sequence with an allocation ratio of 1:1:1. Allocation concealment was done using sequentially numbered opaque sealed envelopes which were opened prior to the block procedure. On the day of surgery, after getting written informed consent from the parents, the demographic data was recorded. The patient was shifted inside the OT. ASA standards of monitoring were attached. After administration of general anesthesia, children were randomized into 3 groups. TAP group received ultrasound guided TAP block with 0.25% ropivacaine at a dose of 0.4 ml per kg. IAIH group received ultrasound guided ilioinguinal iliohypogastric block with 0.25% ropivacaine dose of 0.2 ml per kg. And QL group received ultrasound guided QL block with 0.25% ropivacaine dose of 0.4 ml per kg. Intraoperatively, if there was a 20% increase in heart rate from the baseline, injection fentanyl was administered at a dose of 1 mg per kg. Post-operative monitoring was done every 2 hours till discharge from the hospital. FLAC scores were recorded by the nursing officers. If the FLAC score was found to be more than 4, then injection paracetamol was administered at a dose of 15 mg per kg IV. If the FLAC score continued to be more than 4 even after paracetamol administration, injection tramadol was administered dose of 1 mg per kg IV. These are the ultrasound images of the 3 blocks which we had given. Coming to the sample size calculation, based on the previous studies, a sample size of 17 in each group was required to achieve a power of 90% to detect a difference of 15 minutes in the time to the demand of first rescue analgesia. Accounting for 10% dropouts, the total sample size was calculated to be around 57. In our study, we have assessed 44 patients for eligibility. All 44 were randomized, 14 in TAP group, 17 in ilioinguinal iliohypogastric group, and 13 in QL group. There were none lost to follow-up, and all patients were analyzed. Coming to the results, the demographic data in the 3 groups were found to be comparable. The median time to the first demand of rescue analgesia was significantly longer in quadratus lumborum group, that is 720 minutes when compared to TAP group and ilioinguinal iliohypogastric group. In terms of intraoperative fentanyl requirement, there was no significant difference between the 3 groups. This chart shows us the FLAC score, median FLAC scores which are recorded at various time points. There was no significant difference between the 3 groups except at 6 hours. There was a reduced requirement of tramadol in the quadratus lumborum group when compared to TAP group and ilioinguinal iliohypogastric group. This is another statistically significant result which we had obtained in our study. The findings of our study favors in performing quadratus lumborum block as it provides a significant longer period of analgesia when compared to TAP block and ilioinguinal iliohypogastric block in inguinal hernia repair. An adequate pain relief after hernia repair allows us for lesser use of opioids and early discharge to home. Moreover, these techniques can easily be performed with ultrasound guidance. Hence, I would like to conclude by saying ultrasound guided quadratus lumborum block provides a clinically significant prolonged duration of pain relief after inguinal hernia surgery in children compared to TAP block and ilioinguinal iliohypogastric block. These are my references.
Thank you, Priyadarshini.
Thank you, sir.
So now I request judges to ask the questions.
I have a few questions, Priyadarshini.
Yes, sir.
One thing is, I would be happy if you should have given the justification of dosing, at least for quadratus lumborum block, because the rest of them have already been used. The TAP block and the ilioinguinal iliohypogastric nerve blocks have been there for a long time now.
Yes, sir.
So we are not questioning the dosing. So whenever
Yes, sir.
you talk about a new drug and new technique, especially
Yes,
now
sir.
in pediatrics, quadratus lumborum, the dose you have used, you must be justifying with a reference or an evidence. Okay, how was the dose arrived at with respect to the quadratus lumborum block, especially? And with respect to the sample size, you have given the statement, good, it's a good statement. All the technical parameters are met. But because you are comparing 3 groups and you have mentioned the effect size to be 50 minutes. So what is this 50 minutes for a comparison of which group to which group?
Between the 3 groups, the time to the rescue or time to the first demand of rescue analgesia, sir. That
No,
is a
sample size. Okay, probably you don't understand. When you have mentioned that some 50 minutes of effect size you have mentioned, right?
yes, sir.
Yeah. What is that effect size? What do you
Effect
mean by
size.
effect size?
So that is the minimum difference of. Sir, my primary outcome is time to the first demand of rescue analgesia. So it requires a minimum difference to.
That's what. See, primary objective must be linked to the sample size calculation.
Yes, sir.
By using time, you should be talking with respect to the time or in the sample size calculation. If you are effect size, what you have mentioned is in terms of minutes. So that indirectly it also represents the duration. So duration of 50 minutes, you are comparing to what quadratus number to iliohypogastric or to the TAP block.
Fuel to the TAP block, sir.
Not what happened to ilioinguinal and iliohypogastric block duration. Okay, we don't have much time, so we should be more clear in that aspect also. And when you are represented the fentanyl requirements, you are given an absolute requirement. It should have been better if you had given in terms of per kg body weight also. Basically, because it's a wide range. I think 2 to 12 years is the age range you have used, right?
Yes, sir. We have
Okay, and
used
you have given
1 mics per kg for all the patients, sir.
No, rescue requirement.
Okay.
You are given a total dose, right?
Yes, sir.
So what I'm suggesting is you could give it as per kg body weight of fentanyl.
Okay.
Because the age range is a pediatric study and age range is a big one. Okay, so it doesn't sample. Right. And last, most important, you have missed out is to cite other evidences. Your study is never complete without talking about other publications or evidences. Because you cannot say doing some 54 cases, 17, 14, 13, something, that my results are valid. Okay, validity will improve when you compare with the other published studies that you have totally not discussed at all. Okay, thank you. Rakesh?
Sir, I just want to ask one thing, sir.
Yeah.
when you said the assessment of rescue analgesia as your primary outcome, right? You want to look for the first rescue analgesia,
Time for
first
the demand.
time for the first rescue analgesia. So what frame of pain assessment were you using? It was pain at rest or pain at movement or pain at spontaneous movement, because these are child. So what were you looking for? Because they may differ in each patient. Especially
See,
with,
we were assessing using FLAC scores, sir, which assess facial expression, leg activity, and cry and consolability. These are the parameters of the FLAC score.
So this is FLAC one, but in case if you ask the child to move around, the pain intensity will increase. The FLAC score describes the spontaneity movement of the child in response to pain. Are you looking for asking the child to move the limbs and then looking for the response also?
No.
Okay. Just remember, when we are looking for the pain, there will be a pain at rest and there will be a pain at movement. So when you are assessing, these are two important components. So that will help you to make it more useful to the patient. Thank you so much. Good study, and just try to incorporate our suggestions for the future also.
Okay.
Thank you,
Thank you,
Priyadashini.
sir. Thank
We'll go to the next speaker, please.
Thank you. Now I want to call next speaker. Next speaker,
Yes, sir.
Madan Mohan Sood.
Yes, sir. Good.
Madan Mohan Sood.
Video. I can share करेंगे. अब video.
He is there, he is going to open.
Yes, sir. Stop video. I
Madam,
guess call this. Yes, sir.
Please share your screen, Madan.
बड़ा खोला. I guess.
Madan, if it is any
Yes.
problem, we can go to next one.
No, sir.
With the permission of the
No,
judge.
ma'am. No. Setting है ना.
Then come
Sir,
next.
हल्ला नहीं sir. Sir, I already share my.
Manas, just check it. Back team, please check it.
I guess share call this.
Relax,
Sir,
relax,
please
Madan,
start
relax.
share screen. Please start share screen. Yes, please start your presentation. Please start slideshow. Yes, please present.
Timer, please.
I'm already.
Hello, sir. Okay, sir.
Ma'am, timer is on.
Start. Please start, Madan.
Yes, ma'am. Very good morning to all. My topic is analgesic efficacy of ultrasound guided bilateral superficial cervical plexus block in thyroid surgery. Let's go for introduction. General anesthesia is a technique of choice for thyroid surgery. Different modalities for pain relief under general anesthesia are opioids, NSAIDs, and local regional anesthesia technique. Bilateral superficial cervical plexus block is a popular regional anesthesia technique because of its feasibility and efficacy. Local anesthesia is deposited under the sternocleidomastoid muscle. The superficial cervical plexus block, when given by anatomical landmark technique, has controversial efficacy with chances of failure. So our study will evaluate the efficacy of ultrasound guided bilateral superficial cervical plexus in thyroid surgery. The aim of study is to evaluate the analgesic efficacy of ultrasound guided bilateral superficial plexus block in thyroid surgery. My objective is comparing the post-operative pain relief through VAS score between the block group and the general anesthesia group. Second, the assessing the post-operative analgesic requirement in the block group in comparison to general anesthesia group. Comparing the side effects, post-operative nausea, vomiting, and pain due to the swallowing between two groups. The research hypothesis: the group of patients with block have better efficacy in comparison to general anesthesia group in terms of post-operative pain and post-operative analgesic requirement. The inclusion criteria includes the patient with American Society of Anesthesia Grade 1 and 2, status of either sex, age between the 25 to 65 years old. Euthyroid patient scheduled for elective thyroid surgery, including goiters, tumor, and cyst. The exclusion criteria includes the patient's refusal, large size of thyroid, anatomically abnormality causing difficulty in visualizing the sternocleidomastoid muscle by ultrasound, infection at puncture site, allergy to local anesthesia, pre-existing peripheral neuropathy, retrosternal thyroid, language barrier causing difficulty in explaining the procedure, previous neck surgery. Next, the methods. All the patients fasted for 6 hours prior to surgery. Pre-medicated with 0.25 mg alprazolam at the night before of surgery. Pre-oxygenation was done for 3 minutes. Induction of anesthesia was carried out by using propofol 2 to 2.5 mg per kg, fentanyl 1 to 2 microgram per kg, and muscle relaxant atracurium 0.5 mg per kg. Intubation was done with a cupped tube of appropriate size, fixed and placement confirmed by auscultation. Then maintenance with repeat doses of atracurium and nitrous oxide with oxygen with the sevoflurane. The bilateral superficial cervical plexus block was performed under anesthesia in a supine position with head turned to the opposite side of the block. The ergonomics regarding the ultrasound guided blocks was followed. Under the complete aseptic technique, a high frequency linear transducer is placed in a transverse plane over the sternocleidomastoid muscle. Then common carotid artery located and the probe traced to upwards to locate the bifurcation of common carotid artery. Then probe traced to laterally to give the block. The goal is to guide the needle 23 gauge spinal needle tip move from the lateral to medial direction under the posterior lateral border of the sternocleidomastoid. After aspiration, 0.3% ropivacaine, 10 ml each side was given and local anesthesia spared visualized under the plane. This is the picture where we inject the local anesthesia below the sternocleidomastoid muscle. Position of the patient. Position of patient was confirmed by the neck, slightly hyperextension of the neck by shoulder roll and neck support. Intraoperatively, blood pressure and heart rate were recorded at the time of pre-incision, incision, end of resection, and extubation. IV paracetamol 1 gram given during intraoperative period after end of resection. Patients were extubated after meeting the extubation criteria, after reversing the effect of neuromuscular blockage with neostigmine 2.5 mg and glycopyrrolate 0.5 mg. Then patients were transferred to post-anesthetic care unit for 2-hour observation. For post-operative rescue analgesia, nalbuphine 10 mg slow IV was used. As my study is not completed till now, this is a pilot study. We observed 16 patients where 8 patients were control group. Control group means only anesthesia group. Other 8 patients were a block group, that is with the anesthesia and bilateral superficial cervical plexus. We observed there is a change in mean atrial pressure at 3 phases, that is at the time of incision, end of resection, and 15 minutes after the extubation. We found that greater than 10% of an increase in mean atrial pressure occurred in less number in the patient with the block group as compared to control group. Similarly, there is change in heart rate in the at the time of 3 incision, at the time of 3 phases, incision, end of resection, and after 15 minutes of post extubation. There is less number of patients increase in heart rate as compared to control group. This is the time required for the fast of analgesia in group A. This is the control group, and in group B, that is the block group. we found that up to 60 minutes, no patient in the block group required any anesthesia. But in 6 out of 8 patients in control group required anesthesia. Coming to results, we observed mean arterial pressure, heart rate during the pre-incision, incision, end of resection, and post-extubation after the 15 minutes. During the post-operative period, we also observed requirement of the fast anesthesia. We observed the reduction in the hemodynamic changes in the group given the block. In group A, 7 out of 8 patients required anesthesia within first 2 hours of the end of the surgery. In group B, 6 out of 8 patients required anesthesia.
Your time is over. Please
2
stop.
hours
Carry on.
2 hours of end of surgery, and among 6 patients, 5% required fast dose anesthesia after 4 hours end of surgery. We conclude that there are changes in mean arterial pressure and heart rate in patients not given in the block, but pain relief was observed in the patient under the block. This is my reference. Thank you.
Thank you, Dr. Madan.
Sir.
Appreciate your efforts. One thing is, all the participants, so whatever I say and Dr. Rakesh are going to tell you are not criticisms, are the ones you should take it in the right sense, because you are all trainees and we want you to improve further later on when you in your academic career. Okay. So overall, it was a good presentation, but there were important technical issues. So in the sense we should, when you talk about ultrasound, very simple is the frequency of the ultrasound that probe that you have used must be mentioned. Okay, you only mentioned the type of the probe. So you always mention the frequency exactly, because it's a superficial structure, and it's always better to put a photograph of the unit itself straight away and say this is this much of frequency, this shape and everything is self-explanatory. And it's an anatomical anything. It's all blocks. Whenever we talk about blocks, you just put an anatomical representation or illustration of superficial cervical plexus block. That's very important.
Yes, sir.
Then one small issue, the one biggest issue was with respect to the small sample size which you have used. So totally only about 16 patients have been studied.
Yes, sir.
And you have not mentioned about the sample size calculation. So this is one which is very important. And at the time of induction, did you use any analgesic agent? Then?
Sir, fentanyl, sir. Okay.
So you have not mentioned, you never talked also. Okay. So that's not mentioned in the slides, and you did not mention during your talk also. And another glaring problem is the duration of analgesia, which is your endpoint, must be a mean value, mean plus or minus standard deviation. You never talked about it at all. You only said this many patients had for less than half an hour, 1 hour, 2 hours and all. That's okay. That can be a secondary discussion, but we should be talking about the mean duration of analgesia in the groups. Okay. And you should always talk about other publications or evidences related to your study, which I told to the previous speaker also. Dr. Rakesh, your comments, please.
Yes, sir, I agree. I think though the concept is looking good for the use of
Okay, Lakshmi, can you please stop sharing your screen?
Yes, sir.
The concept is looking good because the bilateral cervical plexus block is a well-known entity for thyroid surgery. But you also need to mention, because when we are putting up thyroid surgery and you are using ultrasound guided, the brachial plexus will be distorted. So this should come into your technical observation, and it should come into point. And obviously, as Dr. Balabhaskar sir has mentioned, that you should be careful about the timings and all those things. Have you observed any increased amount of bleeding, Dr. Madan, increased bleeding or technical difficulty in localizing using ultrasound? You have not mentioned in your result section.
So till now, we not found any bleeding. As we go through ultrasound, there is no bleeding, sir.
And any technical difficulty in large masses?
Again, sir.
Any technical difficulty in putting up the block in thyroid mass? Because sometimes the thyroid mass may be a goitrous mass, big mass.
Yes, sir.
So
yes,
any difficulty you find there?
Yes, sir. One difficulty, sir, I find.
What difficulty? It should be a part of your results. Okay. So this was not coming into your result section.
Okay, sir.
Chalo, thank you. Thank you so much.
Welcome.
So our next participant is Dr. Bhakyalakshmi M. Bhakyalakshmi.
Yes, sir. Please share your slides. Yes, ma'am. Ma'am, hello.
Yes.
Am I audible, ma'am?
Yes, audible. Your timer starts now. Timer, please.
Yes, ma'am. Good morning, everyone. My topic is extubation strategies in ICU patient and association with outcomes. Next. Aim and background. Extubation is the removal of the endotracheal tube, which is the last step in liberating. Ma'am, extubation is the removal of the endotracheal tube, which is the last step in liberating a patient from the mechanical ventilator. Extubation failure is arguably the most serious complication of weaning and is defined as the need for reintubation within 48 hours of period of initial removal of the patient from mechanical ventilation. Extubation failure is associated with several adverse healthcare related outcomes and thus of great significance of both the healthcare providers and patients. The aim of the study is to assess the exact incidence of the extubation failure in ICU patient and assess the factor associated with extubation failure. Objectives. Primary objectives is to study the incidence of the extubation failure in ICU patient. Secondary objectives are factors associated with the extubation failure, the incidence of tracheostomy, and the cause for tracheostomy. Methodology. Sample size collection. The sample size was calculated based on the studies available in database. It was shown that there were 10 to 20% extubation failure in ICU population. So taking into account power study 80% and 95% confidence interval, sample size was calculated. After the calculation, the result was 45. To minimize any effect of data loss, we have taken 50 patients, assuming 10% dropout rate. Sample size was calculated using Open EPI software. Data was analyzed using SPSS25. The quantitative variables were expressed as median, interquartile range, whereas qualitative variables are expressed in frequency percentage. All the patients admitted to the ICU on mechanical ventilation were studied from the day 1 of intubation to extubation. Parameters that were included: ventilatory management, general ICU complications such as ventilator associated pneumonia, ARDS, tracheobronchitis, delirium, etc. Specific data on extubation, reintubation, and tracheostomy, general ICU outcomes, and in hospital mortality. The demographic and the baseline data were collected from the clinical files from the day of ICU admission to the day of extubation and tracheostomy. Mechanical ventilator parameters and ABG parameters, mainly FiO2 and PaO2, PCO2, and then were collected at the day 1, day 3, and day 7. Description of the weaning process, standardized physical examination on the day of extubation and tracheostomy. Result. Out of 49 patients under study, the maximum were noted in 45 to 67 years of age group, and the male gender has a higher predominance of 62%, and then that of female, which is 38%, and BMI is 21.90 to 26.80. Out of 49 patients, 5 patients underwent reintubation, and then 12 patients underwent tracheostomy. The incidence rate of the extubation failure is 10.2% in my study. The most common cause for extubation failure is poor cough reflex, respiratory failure, and airway failure. Comorbidities: diabetes, which is 32%, chronic hypertension 56%, and COPD 8%, CKD 22.4%. These are the comorbidities are mostly associated with the extubation failure. Duration of the mechanical ventilation is averagely 4 to 7 days. Reintubation percent 10%. Tracheostomy is nearly 24%. Coming to the discussion part, extubation failure is more common in ICU and leads to increased morbidity and higher length of stay and mortality. The incidence of pneumonia, which is 24%, and CKD, which is 18%, was significantly higher in patient needing reintubation. Patient with advanced age and high severity of illness at ICU admission and extubation and pre-existing chronic respiratory and cardiovascular disease are at increased risk of extubation failure. So adequate cough strength, competent airway, minimal secretion, and good respiratory muscle strength and adequate cardiovascular reserve are essential for the successful extubation. So coming to the conclusion part, incidence of the extubation failure is 10.2%, and the most common cause what I have found is extubation failure is poor cough reflex. And the rest are 20% of respiratory failure and 20% for airway failure. The incidence of tracheostomy is 24%, and the most common cause for tracheostomy is prolonged mechanical ventilatory secondary to neurological impairment, it is 50%, and extubation failure is 25%, and airway failure 17%. So optimal management of extubation remains a significant challenge to us and carries a significant weight of mortality and morbidity. So this study will be able to provide a specific data and guidelines in order to help the physician faced with this challenging extubation process. These are my references. Thank you.
Rakesh, you can start. I will follow next.
Right, sir. Thank you so much, Bake. This was interesting study wherein you have to look for the extubation failure. Can I just mention, you mentioned about the concerns related to the airway failure and respiratory failure.
Yes,
were
sir.
you following any standard protocols or what guidelines were you following that what is the time for extubation? That standardization is not mentioned in the suggestion.
Yes, sir. Extubation failure within 48 hours.
No, that I agree. I mean, what
Yes,
were
sir.
the standard protocols or guidelines that you have used for the timing of extubation? That they were.
First, we'll assess the safety of extubation, sir. Stable medical condition and successful weaning trial should be there, and assess the airway protection. That is.
How did you assess all those parameters, Bhakia? Because
Yes,
this is an important outcome, and
Yes,
you
sir.
should be standardizing these protocols. So, which guidelines were you using, or which protocols were you using for assessing that the patient respiratory failure has been resolved? Because you had COPD patients, septic patients also, whether they were indicating of tracheostomy, whether they were having any issues with the difficult airway, and hence they need a strategy for staged extubations. Which protocols were you following for those?
Sir, assess the airway protection for cough strength, reflex, and secretion clearance and mental state.
How you were assessing? Because these were not coming into your method section and neither the results. Which protocol, which process, which method were you doing it for these assessment? Because say, for example, say the cuff reflex. So how were you assessing the cuff reflex with the tube in situ?
Yes, sir. Secretion. So we'll ask the patient to cough after extubation, minimal.
Before extubation. I'm talking before extubation. Because extubation is a planned procedure. So once you extubate and the 10% reintubation rate is pretty high. So how are you doing it?
Sir, first we should see adequate oxygenation and the gas exchange, and then ABG parameters we should check.
Right.
PaO2.
So this should come up into your discussion into your method section very clear and objectively. That when the patient were achieving a tidal volume of more than 6 ml per kg, he was generating an inspiratory pressure of this much. The chest was clear, so TLC count were normal. So whatever the extubation parameters are there, those should be described into a study.
Yes,
right?
sir. Yes,
Sorry.
sir.
Thank you. Thank you. Over to Balabhaskar, sir.
So, Bhagyalakshmi.
Yes, sir.
Plan was good, but
Thank you, sir.
methodology is we call reservation, as Dr. Rakesh was telling. No. So
Yes, sir.
When you want to study about the extubation failure, it's not just the extubation failure definition. So what are factors which constitute extubation failure, which you are using in your study, and how you are going to define each one of them? That's more important.
Okay, sir.
When you say cough reflex, then you should explain how do you assess a cough reflex.
Yes, sir.
And most important, in any ICU, I presume it is an open ICU you are talking about,
Yes,
because there are only 8% of patients with COPD. Okay, only 8%.
Yes, sir.
There are
Sir,
many
actually, sir.
No, there are many patients with CRF also, but what I'm trying to tell and what we are trying to convey is you should be defining everything. Anything related to ventilators, there must have been some respiratory parameters you're talking
Yes,
about.
sir.
There must be some EB parameters you should be talking about. There should be
Yes,
some
sir.
pressure parameter. the patient is on ventilator.
Yes,
So
sir.
those definitions are
Sir,
using in
four
your study.
parameters I have taken, sir. Tidal volume and the respiratory rate, and then
They are not
PEEP.
displayed. That's the problem.
Okay, sir.
Yeah, you should be putting out. You have done the work, you know, but you have not projected it.
Yes, sir.
Let's see, we are already time. So, but you should be clear. And when you have introduction also, you should be talking about some statistics of other studies and
Yes, sir.
comparative studies. Again, has not been mentioned by you also. You are the third speaker. You are not talking about other studies. Okay. Please improve next time. Thank you very much.
Thank you, sir.
Thank you, sir. Then our next participant is Dr. M. Sivamurugan. M. Sivamurugan. Dr. M. Sivamurugan.
Are you present, M. Sivamurga? Are you online? Or we'll move to the next speaker? After last, you will be given the chance. Yes, he's on the line. Siva, please share your slide. Dr. Siva. Dr. Siva, please share your slide.
Is it audible, ma'am?
Yeah, audible. Please share your slide.
Yes.
Yeah.
One second. Ma'am, is the slide visible?
No. Backup team.
Shiva, there's this screen sharing option.
Please share your screen.
Yeah.
I'm not getting the option to share my screen.
There's the participant
See the bottom option, share screen option, green button.
One second. Sir, I'm not getting the.
Sir, you see share screen button?
Now is it visible, sir?
In the lower part
No,
of the
sir.
screen, there will be a share screen option. You have to click on that.
One second.
You go to on Zoom,
Yes, sir.
share screen button, then click on it.
Sir, I'm not getting the share screen button directly, sir. One second. Yeah, got it. Now is it visible, sir?
Yes,
Yeah.
please start
Yes, sir.
slideshow.
Thank you so much. Yes. Good morning. Good morning, respected.
Please make it as a
judges.
slideshow. Please make it as a slideshow.
Okay. Good morning, respected judges. And my topic is a comparative study between TrueView PCT video laryngoscope and Macintosh laryngoscope with respect to intubation quality and hemodynamic changes. I am Dr. M. Shivamurugan from second year anesthesiology from IMSN Sama Hospital. My guide is Dr. Rajiba Lochan Samasa, Associate Professor. Introduction. Glottic view by conventional laryngoscope require proper alignment of the oral, pharyngeal and tracheal accesses. Considerable lifting forces required for the alignment of oral and pharyngeal axis cause much adverse hemodynamic changes. And video laryngoscope resemble traditional laryngoscope, but they have a video chip embedded in the tip of the laryngoscopic blade. This transmits magnified images to a display screen where they can be viewed or recorded. The Trufatec TrueView PCD system is a new video laryngoscope blade system with an optical assembly that eliminates the larynx and with a new blade that provides an optical view around the corner. And our aim of the study is to compare and assess TrueView video laryngoscope with Macintosh laryngoscope for orotracheal intubation in an adult population 18 to 60 years of age with regards to laryngoscopic view grade, ease of intubation and hemodynamic changes. And materials. After the institutional ethical committee approval and written informed consent, this prospective randomized control study was conducted on 60 patients. And inclusion criteria was age grade 1 and 2 of either sex and age 18 to 60 years of 60 years. And the exclusion criteria was anticipated difficult airway and the surgery of the oral cavity, larynx, pharynx, and increased intracranial tension were excluded from the study. Methods: after overnight fasting, all patients in the pre-anesthetic area were cannulated and injection metoclopramide was given IV 1 hour before the anesthesia. After arrival in the operation theatre, monitors were connected and ETCO was attached and kept in standby mode. And all patients pre-medicated with injection glycopyrrolate mid-dose and pre-oxygenation done for 3 minutes. Anesthesia was induced with injection fentanyl and injection propofol with dose titrated to loss of verbal response. For muscle relaxation, we have given rocuronium 0.6 mg per kg IV, and intermittent positive pressure ventilation was given for 3 minutes by 100% oxygen. And all laryngoscopy intubations were carried out by the same anesthetist using the TrueView video laryngoscope and McIntosh laryngoscope. According to the group, the patient was allotted. In group M, the intubations were performed under the guidance of McIntosh laryngoscope without the use of still lead after attaining snipping position using 8 cm non-compressible head ring and extending the head. And an oral cannula with oxygen flow 6 to 8 liters per minute was placed in the patient's mouth during laryngoscopy and intubation. And in group T, which is the TrueView laryngoscope, which was functionally pre-tested with all the components mounted onto the hilt of the laryngoscope, including an oxygen line delivering oxygen at a rate of 6 to 8 liters per minute and digital camera attached to the ocular piece. For better control of the endotracheal tube tip, the stillet was used in this group. And laryngoscopic view was assessed using the modified Comark and Lehan grading. Intubation was done with cuffed endotracheal tube of appropriate size, while ease of intubation was assessed by intubation difficulty scoring, and time just before laryngoscopy will be recorded as time 0. Time to intubation was measured from the time of introducing the laryngoscopic blade in the patient's mouth till the appearance of square wave capnograph. A maximum of 1 minute time was allowed for laryngoscopy. If intubation was not achieved within 1 minute or SpO2 falls below 92%, laryngoscopic blade was to be removed and mask ventilation was given for 30 seconds before second attempt was to be allowed. A maximum of 3 attempts were allowed. Intubation time in such situation was sum of time taken in these steps. If patient could not be intubated in the three attempts, the case was to be recorded as failure and airway to be managed according to the difficult airway protocol. The placement of endotracheal tube was confirmed by auscultation of the chest and presence of square wave capnograph. After endotracheal tube intubation, ventilation was controlled using oxygen and sevoflurane 2 to 2.5%. All the patients were monitored using ECG, pulse ox, capnograph, and NIVB throughout anesthesia procedures. Methods: and this is the monitoring hemodynamic changes were monitored according to the heart rate, NIVP, and SpO2 were recorded at the following times: just before the induction of anesthesia, and T0, which is just before laryngoscopy, and thereafter every 1 minute after intubation till 5 minutes. Anesthesia was maintained as per requirement of surgery. Any injury to lips, teeth, or oral cavity or presence of blood on endotracheal tube were noted and recorded. And coming to the observation and statistical analysis, the table 1 shows the demographic data, and demographic data of both the group T and M were comparable in both groups. It was almost similar. Average age group was 41, and weight was 60 to 61. Height was 161 centimeter. And table 2 shows the time to intubation. And the time to intubation has a p-value of less than 0.001, which is significant. It shows that the mean time to intubation in group T was longer than group M. And modified Comark and Lehan grading shows a statistically significant better CL grading view obtained in group T as compared to group M. Almost 93%, that is 28 patients out of 30 patients had CL grade 1, and while in group M only 20 patients, that is 67% had CL grade 1, which shows the better CL grading obtained in group T. And intubation difficulty scoring was done, and in this group T intubation difficulty scoring was much lower in group T as compared to group M. And coming to the hemodynamic observation, in both the groups T and M, the heart rate, systolic BP, diastolic BP increased from baseline for up to 3 minutes after laryngoscopy, but they were comparable in both the groups all the time. Coming to the discussion, the demographic data were found to be similar in each group. In a study, we found that the time to intubation was more in group T as compared to group M, which was expected because of the decreased expertise in video laryngoscopy, which requires hand-eye coordination. And from our observation, true view laryngoscope provide a better glottis view because patients in group T, 28 patients had CL grade 1 as compared to only 20 patients in group M. The intubation difficulty score was less with group T. Group T had significantly lower mean IDS as compared to group M. There was no statistically significant difference in hemodynamic variables between the two groups. Coming to the conclusion, from our study, we are able to conclude that for laryngoscopy and orotracheal intubation in adults population 18 to 60 years, TrueView PCD laryngoscope provides a better glottis view than McIntosh laryngoscope. Although it requires a longer time to intubate using TrueView, the overall IDS score was lower as compared to McIntosh laryngoscope. Hemodynamic changes remain similar in both the groups. TrueView should be considered as a useful alternative to McIntosh laryngoscope and should be introduced in day-to-day practice for more expertise for orotracheal intubation in adult population. Thank you.
Shivamurgan,
Yes, sir.
good attempt. So we encourage all the to present.
This is a good study. Sir, can I ask or you?
Yeah, please go ahead.
So I was just asking, this is a good study
Yes,
where you compare the equipment. Can you just
Yes,
clarify me that what is the novelty? Because we know that video laryngoscopes are better than the conventional laryngoscopy. So can you just highlight, Dr. Siva, that what was the novelty for this study?
Sir, we found that if we start using the video laryngoscope on a day-to-day practice, the time to intubation will be much lower when we increase the expertise in video laryngoscope, because what we found out was
regarding this aspect, when you mention that the time taken for intubation, you mentioned p-value to be significant. It was less than 0.001. But what was the 95% confidence interval for the two groups for time to intubation? Because I could see in your table, the difference was hardly of 5 to 6 seconds. So when you're using a normal airway, the time taken, I think, was 37 seconds versus 29 seconds. So difference of 8 seconds.
Yes, sir.
Patients who were normal. So do you think clinically they are also significant? Though p-value you mentioned that it is significant and you concluded also.
Yes, sir.
Sir, 95% CI for.
Sir, when we increase the usage of video laryngoscope, I feel that the hemodynamic changes will be much lower than the McIntosh group in the long run, sir.
Okay, so I just want to emphasize that the statistical significance is there, but clinical significance may not be too much. Though you can say the hemodynamic variability can be associated with this. Second thing is, I'm a little concerned that I know that blinding cannot be done for these patients, right? So blinding is an issue. So what other options are there so that you can avoid bias? For example, the person who is using conventional probably deliberately can take more time because you want to prove it. So how can you avoid that bias?
For a conventional,
because blinding is not possible practically for using two different type of equipment.
Yes, sir. Not possible. Yes, sir.
Right. So you should think of, I mean, whatever you are describing, it should be more objectively recorded version, so that you can always say that yes, we have done this objectively and remove the subjectivity, so that where the blinding is not possible, you can take care of it. Right. So I think good study, but we need to add on those things also. Remember, statistical significance is not equivalent to clinical significance. So your discussion section and conclusion also should emphasize those aspects, right, Dr. Siva?
Okay. Yes, sir. Thank you.
Dr. Balabhaskar, sir.
Yes, it's now video laryngoscope for more than 10 years now, and some are facts are facts only. So what is revealed now is always is video laryngoscope will give better laryngoscopic view. So view that is always obtained is for McLehan. Status improves by at least one of the steps there. Okay, but the intubation may not. It may not be easy to intubate with a video laryngoscope as compared to McIntosh laryngoscope. These are some standard outcomes. Number one, but number two, what you have done is you have preloaded the intubation with a stillate with TrueView. Okay, so usage of stillate is generally video laryngoscope, and you have preloaded already.
Yes, sir.
Okay, so that is the way one of the restrictions related to the laryngoscopes, the video laryngoscope. Okay.
Yes, sir.
So methodologically,
Yes, sir.
there is a bit of problem. And overall, again, I come back to the technical aspect. Your fonts were very, very small. I had to search for the material. Okay. PPT fonts.
Okay, sir. Sorry, sir.
Lot
Okay,
of
sir.
crowding was there.
Yes, sir.
Okay. And finally, the sample size
Okay.
must be clearly mentioned. And no comparative studies again for you also.
60. Okay,
You
sir.
have to, no, okay.
Sir,
Comparative
60
study.
patients
No.
are used, sir.
Okay, good. No, we need further details. Sample size, on what basis it was done. And
Okay.
then comparative studies, most
Okay, sir.
important in a discussion. If I do one study, I am not the master. Okay. And you have done this study,
Yes,
you are
sir.
not
Yes,
the
sir.
master. No, we should be comparing with
Yes,
previous
sir.
studies of what they have done
Other
and
studies.
what they have
Yes, sir.
done, what we have done compared to them,
What
better
they
or
have
worse.
found.
Okay. Thank you very much.
Okay.
Thank you.
Thank you, sir. Thank you, sir.
Now, with request to the judges, I would like to call Dr. Monisha Sahu, the next participant. Dr. Monisha Sahu.
Yes, sir. Present, sir.
Start.
Yes, sir. Good morning, all. Sorry for the technical glitches back then. I'm here to present my topic, our topic, an optimal site for holding the endotracheal tube during direct laryngoscopy, a randomized controlled trial. Background: endotracheal intubation is a life-saving skill expected of all the healthcare providers. The guidelines are there for laryngoscopic holding techniques, but not for tube holdings. Hung et al. In their study showed that holding the endotracheal tube differently changes the torque and the time to intubation, especially amongst the trainees. But there are no studies comparing the time to intubation, comparing the sites for tube holding for time to intubation. So the null hypothesis for our study was there will be no difference in time to intubation by trainees while holding the endotracheal tube at two different sites. Here are two images showing the two sides of holding the tube. Image 1 shows the line of vision when the tube is held closer to the tip, and image 2 shows the line of vision when the tube is held further away from the tip. Same is shown by this animation. This is when the tube is held away from the tip, and this is when it is placed closer, held closer to the tip. Outcomes: the primary outcome were difference to the time to intubation between the two common tube holding sites, which were predetermined by a pilot study. Secondary outcome: rate of success of first pass intubation, intubation difficulty score, difference in airway trauma related complications, and ease of laryngoscopy and intubation for the intubator. Methodology: a pilot study was done to select the two sites and the sample size. The pilot study had 54 participants in it, and the mean position of holding by the experienced anesthetist was found to be 21 centimeter with a standard deviation of 2.54 centimeter. So the two sites that we determined were 21 minus 2.5 and 21 plus 2.5, roundabout to the next digit. So we got our two sites, that is 19 centimeter and 24 centimeter. The sample size calculation was also done from this, which I'll discuss in the coming slide. Then prior to the day of surgery, an informed written consent was taken from the patient after they matched our eligibility criteria and were willing to give consent for our study. Randomization was done by computer-generated random codes, and allocation concealment was done by sealed opaque envelopes, which were opened in the OT on the day of surgery. And the tube was marked according to the code. Standard ASA monitors were attached and general anesthesia induction was done, after which the intubator, less than 18 months of experience, were asked to hold at the marked site, and after
they saw a proper CL grade, as CL grade more than 2 was my exclusion, and were asked to intubate holding this site till the ETCO2 graph was marked. That all this process was videographed, out of which one video was displayed over here. The data was collected and were analyzed. From a sample size, our mean time to intubation by the experienced anesthetist, that is from tube holding to removal of laryngoscope, was 8.83 seconds with a standard deviation of 4.07. So taking alpha to 0.05 and applying a power of 0.85, sample size of at least with 149 was required in each group to attain a difference of 20% in the effect size. And accounting for loss of data, we took 180 sample in each group. So the total sample size came about to be 360. For statistical analysis, continuous variables were analyzed by independent t-test and categorical variables were analyzed by chi-square test. 1,026 patients were assessed for eligibility, out of which 532 were recruited because 32 did not give consent for the study and rest did not meet the inclusion criteria. From this, 323 were randomized into both the groups. They did not 117 were excluded because the intubator did not hold at the site, marked site. In 42, adjuvants like bougie or stillets were used. In 13, videos was not properly taken, and 37 had CL grade more than 2. Randomization was a simple randomization. Group A had 149 subjects and Group B had 174. These were subsequently followed up and analyzed. Results: the two groups were similar in age, gender, Mallampati grading, Cormack-Lehane grading, and ASA status. There was no difference between the experience levels of the two groups of trainees. We found significant difference in time to intubation when held at both the sites with a p-value of 0.04 and 95% confidence interval of 0.06 to 2.0. The complications in both the group were also significant and the p-value was less than 0.01. All other parameters, secondary outcomes were comparable. Each procedure was video recorded. These methods were repeatable with a good external validity. But as the sample size is not yet complete, the limitation till now is the wide confidence interval, which we hope will improve as we reach a sample size. Conclusion: from the interim analysis, it was found that holding the tube further away from the tip aided in a faster intubation with lesser complications. This technique might be simple and universally applicable method for faster, safer intubation, especially amongst the trainees who haven't yet achieved the best practice by experience. These are my references. Thank you.
Manisha.
Yes, sir.
Dr. Manisha.
Yes, sir.
Concept is good. That is telling. And in the references, we had put a second one appear to be a similar study.
Yes, sir.
Right?
That was done on a mannequin.
Yeah.
And
so,
they compared the angle of holding.
Time is up, Manisha. Not our discussion.
Okay,
you have not done what was required. Okay, so you should have cited and told what they have done and what you have done. The same thing. I don't know. Somehow all of you have missed out on the discussion of other evidences. Okay, you are not the best persons. I am not Albert Einstein, and you are not Darwin. Okay, so we should be clearly comparing ourselves to other people. And I'm happy that you have used video. I request all, I suggest to all the PGs, use illustrations more judiciously, more. Okay, illustrations speak many things. It cuts the word and the count and also what is entered in the PPT also, whenever it is required. So, but one thing I would have been happy is you have gone a little bit into the physics aspect. Physics aspect means the length of a tube. The more, at least on at a basic level, what I can say is if you hold it more proximally, the control over the distal part won't be that much good. Understand? So as you go nearer, away from the proximal end towards the distal end, the control will get better, basically.
So
Okay,
that
in any
was
structure.
actually, our hypothesis. Holding the tube nearer, we might hit the vocal cords, and holding further, we might control the tube in a better way.
No, don't mistake. I'm not talking about hitting the vocal cords and all. I'm talking about the control over the tube.
Okay, sir.
The control at a ground level, even a layperson, if I have a long tube, if I hold proximally, I will not have much control over the distal part. If I go more nearer, the control would be better. Okay.
Yes, sir.
I want, as a researcher, you should be talking about physics there.
Okay, sir.
Okay, and the type of material. I know that you have used the PVC tubes.
Yes, sir.
So the PVC tubes of different sizes may have different levels of the toughness or strength or non-kinkability even in a normal PVC tube. Okay, that's very important. And one illustration I would have liked is the line of vision entered in a simple illustration. And one major lacuna or lapse which I found in the video also was the table was at a very lower level when the person was trying to intubate. Okay, that all of us know, you should be knowing also, when you are intubating, table should be adequately raised up so that at the level of the sternum, okay, your intubation would be starting. The head is at the level of the sternum. And when I saw in the video, it was very much down. So if that has been done, I would never accept all your results. Okay, Dr. Rakesh? Rakesh, you are there?
Nothing from my side, sir. I think you have covered all the things.
Okay, so please improve upon it.
Okay,
You say it is only preliminary study, interim or interim analysis. You already talked about validity. Such a small study and there are lacunae, it cannot never be validated. There are serious objections. You update yourself and continue the study. Okay, thank you.
Okay, sir. Thank you, sir.
Thank you.
So our next participant, Dr. Aduri Nagaraju. Dr. Aduri Nagaraju.
Yes, sir. Hello. Am I audible, sir?
You can start.
Good morning, all. Sir, am I audible?
Yes.
Yes,
You are
please
audible.
start.
Good morning, all. The topic of my paper presentation is comparative study of dexmedetomidine and dexamethasone as an adjuvant in supraclavicular brain cancer. The dexmedetomidine is highly selective alpha-2 adrenergic agonist and dexamethasone is
Voice is not correct, please. Technical team.
Sir, please louder, little bit louder.
We are not able to hear. Aduri,
now it's audible.
louder, please.
Okay. So dexmedetomidine is highly selective alpha-2 adrenergic agonist and dexamethasone is a glucocorticoid which has analgesic and anti-inflammatory properties. These two
Dr.
drugs
Aduri, can you please use your earphone if you have?
I don't have now.
It's okay.
These two drugs are usually sorry, sir. These two drugs in supraclavicular block they cut short the onset of the sensory and motor blocks and prolong the duration of the sensory and motor block. And very few studies are found on comparison between these two drugs. Then hence my study was planned and designed. Coming to my primary objectives: the time of onset of sensory and motor block, duration of the sensory and motor block. So my secondary objectives are first analytic requirement, mean VASPOR in 24 hours and post-op analytic requirement in 24 hours. The study was conducted in Department of Anesthesiology at Kalinga Institute of Medical Sciences, Bhubaneswar. The duration of the study was 1 year. It was a randomized double-blind prospective study. And after obtaining institutional ethical committee approval, I registered my study in Clinical Trials of India. These are my inclusion criteria and exclusion criteria. And the study sample size was 100, and it was calculated by using 80% of the power and alpha 5%, and it was divided into two groups, Group D and Group X, and 50 patients for each group. After obtaining ethical committee approval and the patients' consent, they randomly allocated into two groups by using computer-generated block randomization list. The Group D patients received 50 micrograms of dexmedetomidine, and Group X people received 8 mg of dexamethasone group. dexamethasone. Both groups received 20 ml of 0.4% bupivacaine, and the total volume was 22 ml. And the ultrasound guided brachial plexus or supraclavicular brachial plexus block was performed, and the drug mixture was deposited. After successful block, the following data was collected. Sensory block was assessed by spirit swab method. Motor block was assessed by Brome score, that is 0, 1, 2, 3. Duration of the first analgesic requirement and VAS score. Total tramadol dose requirement, paracetamol first 24 hours, and number of analgesics given in first 24 hours, hemodynamics and complications. The statistical analysis was analyzed by done using SPSS software version 20.0, and the p-value is less than or equal to 0.05 was considered as statistically significant. Chi-square test of physiological exact test was used to check the association between the two categories of variables, and students t-test was used to test the significance between the two groups. This table shows the demographic profile and ASS status, duration of the surgery. These are not statistically not significant, hence these are comparable in the study. Table showing the onset of sensory and motor block was significantly less in group D than group X, and the duration of the sensory and motor block was significantly prolonged in group D than group X, and first analgesic requirement is prolonged in group D, and number of analgesic requirement mean was in first 24 less in group D than group X. Coming to the discussion, the onset of sensory and motor block was significantly faster in dexmedetomidine group than dexamethasone group. These results were found similar in Power M et al. And Lee M.J. et al. And Singh S. et al. Studies. And duration of the sensory and motor block significantly longer in dexmedetomidine group than dexamethasone group. In Gavosi et al., Niranjan KV et al., they found similar results as I found. And coming first analgesic requirement time in my study was significantly longer in dexmedetomidine group than dexamethasone group. In similar results are found in Hamada M et al. And Kaur M et al. Mean VAS score in first 24 hours was significantly lower in dexmedetomidine group than dexamethasone group. In Niranjan KV et al. Study, they found VAS was significantly lower with dexmedetomidine than dexamethasone. But in Hamada M et al., they used numerical rate scale and they found nothing significant between these two groups. In number of analgesic requirements in first 24 hours is less in dexmedetomidine group than dexamethasone group. In Gavosi et al., they found similar results. But in Yadav RK et al., he compared dexamethasone group to neostigmine and control group. They found less number of analgesic doses received in 12 hours post-operative period in dexamethasone compared to two other groups. The total tramadol requirement in 24 hours is significantly less with dexmedetomidine group than dexamethasone group. The same results were found in Niranjan KV et al. But in Naveen Kumar study, they found no significant difference between these two drugs, and no side effects were found in either groups. And for a limitation of my study is equipotent dose of dexmedetomidine and dexamethasone was not calculated, and the analgesics were given as per the patient perception to the pain. That is VAS score more than or equal to 3. We concluded that addition of dexmedetomidine and dexamethasone group to the 0.5% bupivacaine, we found faster onset of sensory and motor block, prolonged duration of sensory and motor block, less mean VAS score in 24 hours, and less opioid consumption in 24 hours with dexmedetomidine group than dexamethasone group. These are my references, and thank you.
Okay, Dr. Guri, there are some positive things in your presentation. Happy that you mentioned about other studies and their results also.
Thanks.
That's one positive thing I found, and I also discussed about the statistics. And you also mentioned about the software that was used for statistical analysis. So these are some good things, improvements compared to the other presenters. But there are some questions. Basically, you said I have not calculated equipotent doses. So it doesn't matter. But I would have been happy if you had cited evidences which say, yes, I must use 50 mics of dexmedetomidine, or I must be using 8 milligram of dexamethasone. So any study you have done, you must always say that somebody had done like this with good results. That's why I have taken up this dose only. Okay, 50 mics of 8 milligram of dexamethasone, which is the one which. And when you have mentioned about primary and secondary objectives, there was huge list which was mentioned there. Okay, so I saw about 5-6 primary objectives and another 5-6 secondary objectives. Hello, when you are prepared the primary and secondary objectives, so it was a huge list. So you should always have only one major primary outcome, major criteria when you study. Understand? It cannot be a list of 4 to 5.
Okay, okay.
Yeah, so that's a
Okay.
small problem. We have to improve also. Okay, and you should also mention how and why that you are missed. In the sense, how dexmedetomidine acts, how dexamethasone acts, where is the site of action. So those things are also totally missed out. Okay, right, Dr. Rakesh, please.
Yeah, I think, sir, you have already covered the two aspects. The dose of, you say, 50 micrograms and 8 milligrams needs to be justified based on review of literature. And your sample size again needs to be defined based on a one specific objective, which sir is already explaining to you. The other thing that you need to emphasize is, we know that dexmedetomidine has been used for various regional blocks. So what was the novelty of your study? Because it has been used in supraclavicular and other blocks in epidural. So what is the novelty for your study? Was it a different population? Was a different doses? Was something different technique that you are using it? So what other things are there which makes this study novel?
Actually, I'm not comparing any techniques and also, and not other comparing with other drugs. I'm comparing between these two drugs only.
So you need to justify the why are you using it, because there are ample number of studies where these drugs has been found comparable, or they have been used in different studies with different outcomes. So you should always be very clear that what novelty is there into your study. The other aspect is when you report your objectives, apart from mean and standard deviation, it will be good because your p-value was significant in many of the objectives. So it will be good if you can put up the 95% confidence interval. That will show the dispersion of your data. So that will help you to understand whether they are true statistically significant or not there, number one. And many of your parameters were clinically not significant. So when you justify in your discussion section the difference between two, though they were p-value significant in the table that you have shown, they were not of much clinical significance. The difference was not too much in clinical sense. So you should also, when you go to your discussion section, you should also clarify that this difference, those statistical significance may not be of a clinical value. So you should justify and conclude accordingly, right?
Okay.
Thank you so much. Good study.
Thank you. Thank you.
So next participant, Dr. Srinitya Kolu. Srinitya Kolu. Srinitya, are you there?
Can you move to the next one? When somebody doesn't respond, please move to the next person and call him later on.
Dr. Jenny Anjana Baksala. Jenny Anjana Baksala, are you there?
Yeah. Hello.
Yes, yes. Jenny, please.
Yeah, hello. Yeah, am I audible?
Yes, yes, you are audible. You can start.
Jenny, please share your screen.
Yeah.
Okay, we can move over to the next. You can try. Okay.
Sir,
if you're not able to share,
I've already shared my screen. Yeah, I already shared my screen.
Share again. Yes, please open your presentation and start a slideshow.
Please start your time now. Moderator, please start your time now.
Yes, yes. Okay.
Please start, ma'am.
No,
Should
you
I
start your
start?
timer now. Yeah.
Good morning, jury members. I studied two drugs, budesonide and lignocaine nebulization and preventing post-operative sore throat. In post-operative sore throat, post-operative. Should I continue? Hello?
Please change your
Continue,
slide.
please
My
continue.
Continue.
Yeah.
Continue.
Yeah. Post-operative sore throat is a very common problem encountered in patients undergoing general anesthesia with tracheal intubation, having an incidence of around 21 to 71.8%. Even though it's a self-limiting complaint, it is one of the major causes of patient dissatisfaction and delay in the discharges. Hence, prophylactic management of post is recommended for to improve the quality of post-anesthesia care. Among the pharmacological methods used, one is nebulization. Nebulization has been tried with ketamine, lignocaine, magnesium sulfate, budesonide, dexamethasone, etc. My aim was to compare the effect of prophylactic nebulization with budesonide versus lignocaine on the incidence and severity of post-operative sore throat in surgical patients following endotracheal intubation. A prospective randomized study was planned, approval of ethical committee was taken, patient's consent was obtained, and the sample size was fixed at 40, considering a precision of 10%, power 80%, confidence interval of 95%, and also considered a loss of 10% follow-up. My inclusion criteria was age between 18 to 60, ASC grade 1 and 2, Malampati grade 1 and 2. Both genders were taken into account. Elective surgeries were taken lasting less than 2 hours, done under GA with endotracheal intubation. And patients having a BMI of less than 20 or more than 35, mouth opening less than 3 centimeters, requiring more than 2 attempts at intubation, pre-existing sore throat or hoarseness, upper respiratory tract infection, COPD, asthma, upper airway pathology, patients already on analgesics, steroids, smokers, and surgeries done in steep Trendelenburg position were excluded. Patients were randomly allotted to 3 equal groups of 40, group B, L, and S. Group B was nebulized with 2 ml of budesonide, group L was nebulized with 2 ml of lignocaine 4%, and group S with saline 2 ml 10 minutes before induction. The procedure for general anesthesia was followed. Intubation was done with gentle and quick laryngoscopy within 15 seconds. 8 size tube was used in males and 7 size in females. And the cuff pressure was maintained between 20 to 25 centimeters of water using a cuff pressure monitor. Extubation was also done gently with gentle oropharyngeal suctioning. For post-operative analgesia, injection paracetamol 1 gram was given IV 8 hourly, and an additional diclofenac 75 milligram IM was given SOS for a VAS score of more than 3. Post-operative sore throat, cough, and hoarseness of voice was assessed at 1, 12, 24, and 48 hours based on the scales. This is the severity scale. Patients were divided into 4 grades, 0, 1, 2, and 3. Grade 0 denoted no sore throat at any time since the operation. Grade 1 was minimal, where the patient answered in the affirmative when asked about sore throat. Grade 2 is moderate, when the patient complained of sore throat on his own. And grade 3 is severe, where the patient is seen in obvious distress by the observer. Similar grading was followed for cough and hoarseness of voice. When the data were analyzed, this is a table comparing the demographic profile of the patients in all the 3 groups: age, male is to female ratio, age, weight, AAC grading, Malampati grading, attempts at intubation, and use of Buji were all well matched in all the 3 groups. 2 patients in group B, 6 in group L, and 11 in group S required rescue therapy for postoperative sore throat, which was statistically significant. This is a table comparing the incidence of post at different time intervals at 1, 12, 24, and 48 hours. The number of patients who showed symptoms from group B out of a total of 40 were 7, 5, 2, and 1 compared to 13, 9, 6, and 3 in group L. This is a graph showing the graphical representation of the same table. As we can see here, in all the groups there was a general declining trend with maximum number of patients seen in group S and minimum number in group B. This is a severity table graphical representation of the severity of post at different time intervals. As we can see, grade 0, which is no symptoms at all. Group B majority number were from group B, followed by group L, and then followed by group S. And by the end of 48 hours, we can see here the 97.5 patients from group B had recovered compared to 92.5% patients in group L. This is a table comparing incidence of cough. Again, we see here that in group B, a lesser number of patients showed symptoms compared to group L. And at 24 hours, you can see here 3 in group B compared to 9 in group L, compared to 17, which was statistically very significant. And by the end of 48 hours, as we can see here, group B, only 1 patient had symptoms. This is a comparison of the severity of cough. Here in first hour, as we can see here, grade 1, though there was a comparative number of patients in group B and L, group B patients recovered quickly by 24 hours, and by 48 hours, 97.5% had recovered in group B compared to 90% in group L. Comparing hoarseness of voice, also we saw a similar trend. Group B, lesser patients in group B showed symptoms compared to group L. And by 24 hours, no patients in group B had hoarseness of voice, and by 48 hours, only 1 patient from group L showed hoarseness. This is again the comparison of severity of hoarseness of voice at different time intervals. Grade 0, this is the comparison of the patients who remains asymptomatic from the starting. And as we can see here, by 24 hours, 100% recovery rate in group B, and by 48 hours, 97.5% recovery in group L. Hence my result. The incidence and severity of sore throat show downward trend in all groups over time. In group B and group L, the incidence and severity of post was significantly lower than that of group S, and significantly fewer patients had post in group B as compared to group L. And so I can conclude both budesonide and lignocaine nebulization is effective in reducing post-operative sore throat when given pre-operatively, and single prophylactic pre-induction nebulization with budesonide is better than lignocaine in preventing post. Thank you.
Jenny. Again,
yes, sir.
Yeah, a good presentation when you have picked up the 3 drugs for a normal post-operative complication. Again,
sir.
Can you hear me?
Audible, sir. You're audible, sir.
Yes, sir. Yes, sir.
You mentioned 2 ml of saline, except you mentioned 2 ml of lignocaine and 2 ml of budesonide. What is the 2 ml? You should be specifying the drug, the mass which is used in terms of milligrams or micrograms. You said 2 ml each of lignocaine was used, and budesonide was used, and saline was used. Saline, I understand 2 ml, all of us know.
Budesonide,
yeah.
So budesonide 0.5 milligram and lignocaine 4% 2 ml, which will come around 85 milligrams.
So it will be very clear when you are doing it. And as anesthesiologists, we are clinical pharmacologists, so we should be very perfect when you mention the drugs also.
Yes, sir.
That's very important. And then you mentioned about the use of bougie in the table. In what way it is related to your study?
Yes, sir. Sir, initially, sir?
You mentioned that so many patients were, bougie was used with endotracheal tube.
Yes, sir.
Why did you,
1 or 2 patients we used bougie.
Why did you use the data? It is relevant to your study. Endotracheal intubation with bougie, is it relevant to your current study?
Sir, I took cases where we could intubate in first or second attempt. So sometimes it can cause trying directly with the tube. It can cause trauma. So sometimes if preferred using the bougie than attempting to push the tube down to reduce the trauma, which can also cause sore throat later.
Okay, okay. Then we will not take the discussion further. It's not explained properly. Dr. Rakesh, please.
Yeah. It's a good study. Just I want to clarify one thing, Janet.
Yes,
So
sir.
when you are comparing the drugs, you mentioned about the time interval at various points, and you are looking for the outcome parameters. So when we use a drug which has different duration of action or T half, so that justification should come into the discussion section. Because lignocaine is a shorter acting drug, isn't it? And budesonide
Sir, your audio paused.
Am I audible now?
Your audio is paused.
Am I audible?
We are able to hear you.
Yes, we can hear you. Baxler, we can hear him.
Yes, sir.
Yes.
Jenny, I'm just asking, when you use compare two
Yes,
drugs,
sir.
if they have different T half, so when you were observing the various parameters at multiple times, you were looking for the hoarseness of voice or the sore throat, and you mentioned that at this point there were no difference or there were more difference. So you should be very clear that
Yes, sir.
lignocaine is a shorter acting drug. On the other hand, budesonide is a longer acting drug. So you should clarify in the discussion section that this action is just not because of the drug difference, but it may be because of the duration of action of these drugs. So when you clarify the study, you should always document as a primary objective the time frame which is common for the both. And then you can look for the duration of action of these drugs, and then your conclusion should be according to it, right? So this is one thing you should remember when you are quoting your discussion. Right, thank you. We'll move to the next one, please.
Yes, sir. Yes, sir.
Then
Thank you, sir.
our next participant, Dr. Paridhi Mohanty. Dr. Paridhi Mohanty. Dr. Paridhi Mohanty. Are you present? Yes.
Kamala, then move to the next person, please.
No.
You were there?
Yes, sir. Yes, sir. Am I audible?
Yes, you are audible. You can start.
Okay. Respected judges and all assembled delegates, hereby I am going to present a paper on the topic, that is comparative study of hemodynamic effects of intrathecal bupivacaine with butorphanol in normotensive and hypertensive patients. Sorry, ma'am, there's a little bit of disturbance. Can I be given a bit time? Am I audible?
Yes, you are audible.
It's a little bit problem with my slide. Just a minute,
Let us
sir.
move to the next speaker. We can come back to you.
Yes, thank you, ma'am. Thank you, ma'am.
Then Dr. Srinitya Kolu, are you there? Srinitya Kolu. Srinitya Kolu,
Yes, sir.
you can start.
Yes. Good morning. My name is Dr. Srinitya. Am I audible, sir?
Yes, you are audible.
Good morning. My name is Dr. Srinitya. I'm going to talk about randomized double-blind study of dexmedetomidine and tramadol in the treatment of post-spinal anesthesia shivering. Shivering is an involuntary oscillatory muscular activity which augments metabolic heat production. It increases the metabolic oxygen demand, and it is not only uncomfortable for the patient but also for the anesthesiologist. The drugs used in this study are tramadol, which is a weak opioid agonist, and dexmedetomidine, which is an alpha-2 selective agonist. The aim of this study was to compare dexmedetomidine and tramadol for treatment for control of post-spinal anesthesia shivering. The primary objective of this study was to compare the efficacy of dexmedetomidine and tramadol for treatment of post-spinal anesthesia shivering, and secondary outcomes were recurrence and adverse effects of the same. After obtaining ethical committee clearance and registering for CTRI, the study was undertaken over a duration of 12 months. It is a prospective randomized comparative study. After generating a computer-generated randomization list, blinding was done for both the patient as well as the principal investigator. Patients of ASC grade 1, 2, and 3 of age between age 18 to 65 years undergoing spinal anesthesia for lower abdominal surgeries and lower limb general surgeries were included in the study. And patients with allergic history of alcohol or substance abuse, blood transfusion during the surgery, and thyroid disorders, psychiatric disorders, and pregnancy and lactation were excluded out of my study. The total number of 227 patients were included in the study, of which 100 patients developed shivering and were enrolled in the study. At the onset of shivering, a preformed drug was drug infusion was started for a duration of 15 minutes or till the shivering was cessated, whichever was faster. If the shivering was not controlled in 15 minutes, the study drug was considered ineffective and was treated with pethidine. If the shivering was controlled and if there was any recurrence, the rescue dose of the same study drug was given. And in spite of that, if the shivering was not controlled, it was treated with pethidine. So patients were randomly allocated into two groups, 15 each group. So infusion of the study drug was started at 1.5 ml per kg per hour. And the following parameters were recorded: the grade of shivering, onset of shivering, cessation of shivering, recurrence, response rate, and adverse effects were noted. And this was the grading system used. Coming to statistical analysis, a descriptive and inferential statistical analysis was used. SPSS 2.60 software was used. T-square test was used. Chi-square test was used to compare the two groups. And coming to my results, the incidence of shivering in our hospital setup was 45.05%, and incidence among orthopedic and urological patients was higher as compared to gynecological and general surgery patients. And it was the age group and different sexes were comparable. Coming to the results, the mean time taken by dexmedetomidine was 4.56 minutes to control shivering as compared to 6.04 minutes for tramadol. And the recurrence rate was 2 patients out of 50 patients in dexmedetomidine group developed shivering as compared to 11 patients in tramadol group. And there was more bradycardia seen with dexmedetomidine group, but it was not of much significant when statistical analysis was performed. Also, nausea and vomiting was seen more with tramadol group, which was quite significant. The control of shivering was faster in my study with dexmedetomidine as compared to tramadol. Mittal et al. In his study also showed that dexmedetomidine group controlled shivering faster as compared to tramadol group. Limphon et al. Compared tramadol, dexmedetomidine, and pethidine and came to the conclusion that dexmedetomidine was controlling shivering faster as compared to tramadol and pethidine, but it caused higher incidence of bradycardia and hypotension. Niranjan et al. Compared tramadol with dexmedetomidine and clonidine in his study, and he found out that the recurrence was 0 as compared to with tramadol as compared to clonidine and dexmedetomidine. This could have been because of higher dosage used in his study. And Joshi et al. In his study did not find any statistically significant difference among the two groups. Tanveer Singh Kundra in his study observed that dexmedetomidine had shown bradycardia as compared to tramadol group, but it was not statistically significant. And Shukla et al. In his study found that incidence of nausea was high with tramadol, and whereas in Vassin et al. Vassin study, he concluded that there was the incidence of nausea and vomiting with tramadol was not significant. The limitation of my study was hypotension and bradycardia could have also been because of the sympathetic blockade in spinal anesthesia. And another limitation was equipotent doses of the true drugs were not pre-designed. So I had to determine my drug dosage based on the previous study. Coming to conclusion, in my study, Dexmed and Tramadol both were equally effective, but the time taken for complete cessation of shivering was faster with dexmedetomidine, and also dexmedetomidine has lesser adverse effect as compared to Tramadol. Although my conclusion suggests that dexmedetomidine had better results, but there needs to be more studies to be performed to conclude it as an anti-shivering agent. These are my references. Thank you.
Dr. Nitya, congratulations on a good presentation.
Yes, sir.
So we'll have
Thanks.
a set of questions here.
Yes.
The good things you talked about, and I want everybody to take home is you must be stressing on ethical committee approval. We must be informing that CTR registration has been done, and we must always be talking about patient consent. Okay, many of the presenters today did not stress on that. This is very important. One. Number two is you have said dexmedetomidine and tramadol were used, and if they didn't work, pethidine would be the rescue drug. Did you use
Yes.
pethidine in any of the patients?
No, sir.
You never used. Okay.
No, sir.
Anyway, there is technical aspect, and you said you didn't. There was no history of. I mean, bradycardia. No adverse effects were noted. So in the methodology, you should also mention the monitorings that were carried out in the patient. That's again missing from many of the presenters. When you talk about the research, you should say these are the things we monitored. Okay, so primary outcome parameters, the second outcome parameters are there. Apart from that, the hemodynamic parameters and the oxygen saturation. Okay, most important, you never mentioned about oxygen saturation being monitored because you are giving dexmedetomidine. Understand?
Yes, sir.
Tramadol is anyway non-treating, but our it is required that we mention that we monitor SpO2, the heart rate, and BP, and everything. So that should be made as a routine statement. Especially in this case, we need that also.
Yes.
And we only thing is you said 0.5 milligram per kg of tramadol, and some studies have shown 2 milligram per kg to be very useful. Did you use an antiemetic in the beginning of the study?
No, sir.
Why you don't use antiemetic? Because what are the types of
At the
cases?
beginning of the study, I didn't use. Only if the patient developed nausea or vomiting, I gave it as a treatment.
What are the types of the cases you handled? Types of cases, surgical cases.
Yes, sir. Mainly TURP cases, hernia, inguinal hernioplasty, herniorrhaphy, hydrocele cases, vaginal hysterectomy cases.
So anyway, that should have been part of initial slides because especially gynec surgeries, there is more likelihood of MSCs and you should be giving antiemetics.
Yes.
And when you anticipate vomiting with tramadol, we know, all of us know tramadol would precipitate nausea and vomiting. We must be giving an antiemetic. Just to say emetic MSCs is an adverse effect of tramadol, we should not be avoiding an antiemetic for the treatment. So it's not ethical. Okay, Dr. Rakesh, please.
Yeah, I think it's a good study. Nitya, which group you think was a control group for you, standard of care for you?
Sir, I think the tramadol group was the control group because
So do
it
you
is
think
most
it's a
widely
standard of
used.
care? It's a standard of care for control of shivering after the spinal block, which is the standard drug that you compare with?
So pethidine is considered to be the gold standard.
Right. So when you plan a study, you should have one group which is called control group. And then based on this, maybe a standard of care or gold standard, you should go ahead and do it. Dr. Balabhaskar sir has already emphasized on the equivalence of study. So when you put your introduction section, though you have put in limitation, so when you introduction section, you should always look for the review of literature for the best dose that prevents shivering, whatever is available in the literature, or you need to extrapolate them, or maybe from your personal experience, you need to mention. So that clarity should come into the introduction section. The second aspect is You said the group of tramadol has more nausea and vomiting. Why do you think so?
Yes, sir.
Why?
Sir, it has more central action, sir.
So, do you think that nausea and vomiting is primarily because of your primary objective of shivering? More shivering and more nausea, vomiting, or it is inherent effect of the drug itself?
It's the inherent effect of the drug, sir.
So how will you, I mean, if one drug is having nausea, vomiting, it can induce discomfort into the patient and they can have some amount of retching effect, which is similar to shivering. So you should be
Yes.
very clear, at which Dr. Balabhaskar was also mentioned, that you should be very clear that nausea, vomiting itself can create shivering activities in the patient. So you should be very clear because it is a confounder for your primary objective. So you should be very
Yes.
clear when you try to use the drugs which has inherent effect. Similarly, dexmedetomidine causes hemodynamic changes, right? Tramadol does not causes. Tramadol causes some amount of depression. Dexmedetomidine does not causes. So when you compare this outcome, you should be very clear that they are comparable in the two groups and they are not acting as a confounder for your primary outcome, right?
Yes.
And I think it's a good study. All the best.
Thank you, sir.
We can have the next speaker, please.
Thank you, sir. Dr. Paridhi, are you ready now? Dr. Paridhi, are you ready now?
Am I audible, sir?
Yes, you are audible.
Okay, sir, just a minute, sir. Give me a minute. Thank you, sir, for this patient hearing. So, respected judges and all assembled delegates, hereby I am going to present a paper on the topic, that is comparative study of the hemodynamic effects of intrathecal bupivacaine with butorphanol in normotensive and hypertensive patients. Now, undoubtedly, a single shot spinal injection remains the mainstay of anesthesia for intraumbilical surgeries. However, spinal anesthesia is associated with detrimental hemodynamic changes such as hypotension and bradycardia due to sympathetic blockade. Now, earlier studies have proved that this hypotension is more pronounced in case of hypertensive patient and is associated with myocardial ischemia and increased stroke risk. So, prevention of hypotension and maintenance of a good cardiac output is a major challenge in giving spinal anesthesia to hypertensive patients. Now, by reviewing various literature, it was found that use of spinal additives like butorphanol to hyperbaric bupivacaine causes synergism by enhancing sensory blockade, reducing the dose of local anesthetics, minimizing spinal-induced hypotension, producing good hemodynamic stability, and providing a longer duration of intraoperative analgesia. So, keeping all these aspects in mind and with the paucity of data, a hypothesis was formulated that by adding butorphanol to intrathecal bupivacaine will yield good hemodynamic stability and will cause less spinal-induced complications in hypertensive patients, just like that of the normotensive patients. The primary objective of this study was to compare the hemodynamic parameters in both the groups, that is systolic, diastolic, mean arterial pressure and heart rate. The secondary objective were to compare the spinal block characteristics and the incidence of complications like hypotension, that is which is defined as fall of blood pressure more than 20% from baseline, and bradycardia, that is the fall of heart rate less than 60 beats per minute in both the group. The design of this study was a prospective observational analytical study, a cross-sectional study, and after ethical committee clearance and taking of written and informed consent from the patient, the study was being carried out at MKCG Medical College and Hospital. The duration of this study was for over a period of 4 months, that is November 2020 to February 2021. Now, 60 patients were included in my study, belonging to two groups and aged 40 to 60 years. The group N, that is the normotensive patients having a systolic blood pressure less than 139 by 89 millimeter of mercury and a belonging to ASA grade 1, and group H, that is hypertensive patients with systolic less than 179 and diastolic less than 99 and belonging to the ASA grade 2 and 3. Now, just like any other spinal anesthesia technique, the procedure was quite similar. The detailed PAC was done. Patients on AAC and ARBs were advised to skip the morning dose. Patients on other antihypertensives were advised to continue till the day of surgery. NPO status was verified. 18G IV line was secured and preloading was done, and all the baseline vitals were recorded. Now, subarachnoid block was given at L3 and L4 intervertebral space in sitting position through median approach, and the drug that was used was 2.5 ml, that is 12.5 milligram of hyperbaric bupivacaine, 0.5%, along with 25
25 microgram of diluted butorphanol, making it a total volume of 3 ml, and the needle that was 25 gauge Quincke's needle. Now, data was collected statistically using MS Excel sheet at 0, 5, 10, 15 minutes interval, and thereafter in every 15 intervals till the end of the surgery, and it was analyzed statistically with SPSS version 20. All the categorical variables were presented in numbers and percentage, while continuous variables were shown as mean plus minus standard deviation. Chi-square test and student t-test were used, and statistically p-value less than 0.05 was taken significant, while p-value less than 0.05 was taken highly significant. Precision of our estimates were shown as 95% confidence limit. Now, coming to the results and discussion. On comparing the demographic profile in both the groups, it was observed that there was statistically significant difference in relation to age and weight of the patients in hypertensive group, that is p-value less than 0.05, suggesting that our hypertensive patients belong to a higher age group and they tend to be overweight. Rest other demographic characteristics were similar in both the groups. Now, seeing the hemodynamic profile, it was observed that mean systolic, diastolic, mean arterial pressure, and mean heart rate remained high in hypertensive patients at all given intervals of time and was statistically highly significant. That is a p-value of less than 0.001. Now, as it can be clearly seen in the graphs, even though the pressure declined post-spinal in both the groups, but this decline was parallel from their baseline, and in no point of time there was a drastic decline of mean blood pressure and heart rate in hypertensive groups. Now, looking at the complications, there was incidence of complications such as 4 out of 30 patients from hypertensive group and 2 out of 30 from normotensive group developed hypotension. Similarly, 3 out of 30 from hypertensive group and 2 out of 30 from normotensive group developed bradycardia. On testing the significance, it was found that the p-value was more than 0.05, which was statistically non-significant and was similar in both the groups. The spinal block characteristics were absolutely similar in both the groups, having a p-value of more than equal to 0.05. Now, so we can safely consider that the hypothesis that we have formulated in the beginning of our study was found to be correct, and we can safely consider spinal anesthesia with 12.5 milligram of hyperbaric bupivacaine along with 25 microgram of butorphanol in hypertensive patients for intraumbilical surgeries with the advantage of intraoperative hemodynamic stability and adequate intraoperative analgesia. So, finally, I would like to conclude hereby with a message. In anesthesia, a boring day at work is in fact a good day at work where there will be no pain and no panic. That's all from me. Thank you. And here is a glimpse about my MS Excel dataset. That is my master dataset. Thank you, sir.
Dr. Paridi.
Yes, sir.
What should I do with the last slide? You want me to see that?
Yes, sir. Sure, sir. This one, sir?
Not the method. So
Excel sheet, sir, is talking about your master chart.
Yes, sir.
We don't like to see the master chart. This is just a 6 minutes presentation of your big work. I agree, okay. It's a big work.
Okay, sir.
You have done for 7 minutes. Not to be put. You are wasting your time also. Understand? What is novel? We are going to add opioids to intrathecal drugs normally, many times, because of obvious benefits. And it applies to everybody. If you have chosen a patient with hypertension, IHT, or diabetes for spinal anesthesia, if you are adding an opioid, it is for obvious benefit. Okay, so for probably onset related thing or duration related thing, quality of blood. So additives are always added for that purpose. Okay, and when you say that I want to add butorphanol for a hypertensive patient, it is nothing new. But what I would be happy is, yes, when I add butorphanol to an intrathecal compartment, as per the topic of your study, how it is going to help the patient who is hypertensive. Understand? I know it is and other things. That should be part of your presentation. Title is butorphanol is there. I am not going to ask about bupivacaine and 0.5% heavy and all. So butorphanol, how it's a drug you have used, and you are attributing all benefits to butorphanol. Why should I accept that butorphanol is the one which caused all these things? Without butorphanol also it could have happened because, no, please listen. I am pointing out some mistakes. You have said spinal block characteristics are perfectly similar in both the groups. If you show the table, to the second to third digit, you have shown everything to be perfect. So the table is not acceptable for me, definitely, and also for Rakesh. That can never happen in practice. Understand? So you see all the characteristics were similar perfectly to the second, third digit. You have done it right?
Yes, sir. The range varied, but when the p-value was calculated, it came out to be similar, sir.
No, but it's not acceptable. I will discuss. If you want, we'll discuss later because we don't have time. But it's not acceptable. You can never have a scenario where 5 to 6 parameters are exactly similar in both the groups. Okay, that cannot happen. And secondly, when you talk about patients who are hypertensive, and you want to assess the outcomes related to hemodynamics after spinal anesthesia, you have got systolic blood pressure, you have got diastolic blood pressure, you have got mean blood pressure. You should always think which would be probably the best one to basically discuss. Is it the systolic pressure, is it the diastolic pressure, or is it the mean blood pressure?
Mean blood pressure, sir.
Yeah, so we should be talking about that and highlighting that. I will not say comment about that also. Either we pick up systolic blood pressure or majority of the times we pick up the mean arterial blood pressure. So that should have been picked up as a primary BP for discussion in these patients. Third thing is I would have been happy if you had given a breakup of what type of drugs the patients were on. You said all the patients were on drugs. You should be telling us with how many of them were on what class of drugs, whether it was AC inhibitors or ARBs or beta blockers or calcium channel blockers or whatever, because these drugs also have got an influence on the blood pressure depending on the duration of action. Okay, see, for example, why you stopped AC inhibitors and ARBs?
Sir, because they have a longer half-life. They're given a single daily dosing drugs. So if we give them on the day of the surgery, they will likely to have hypotension. So they are asked to skip the morning dose. Yes, sir?
Amlodipine is also given in an OD dose majority of the times. It's also long acting. You stop amlodipine, but
no, sir.
Then why do you stop? Why do you stop AC inhibitors? Hello?
Sir, I've gone through the books where it has been mentioned that AC inhibitors and ARBs should be stopped as a morning dose should be skipped.
Okay, we'll not waste time because it's going to precipitate the hypertension and it is difficult to manage the hypertension when you give CNBs in patients with AC inhibitors and ARBs. These are all your exam questions and this is most basic for your study because you have mentioned clearly in the slide that I stopped AC inhibitors and ARBs. Okay.
Okay, sir.
That's very important when you do that. And I would have been happy. Therefore, just to mention the vasopressors, were you used? These are secondary outcome parameters. I don't say your study was wrong. If you had written that I used this much of vasopressors in this group and that group, I would have been more happy. That will add to the value of your study. Okay.
Yes, so vasopressor ephedrine was used, and for management of bradycardia, atropine was used. A single dose of atropine, 0.5 milligram IV was used.
I said data. Data would have helped your discussion also. Dr. Rakesh?
Yeah, I think sir has discussed many things. Pradhi, you mentioned in your method section in the stats that 95% confidence interval will be mentioned, but none of your result tables have 95% CI. So when you commit something, you should always disclose it into your result section because 95% confidence interval is one of the good aspects, right? Okay. Is it okay?
Yes, sir. Yes,
right?
Sir.
Second thing is you mentioned in your result section, the baseline demographic profile was different among the two groups. So if the baseline demographic profile was different, because the description about the total process of randomization was not shown by you. So in that, how will you take care of those baseline differences? Did you use some different statistical tool to balance those baseline parameters?
No, sir. I have considered patients from age 40 to 60 years, and I have performed this surgery.
Try to understand the question. The baseline parameters of demography were different in two groups.
Yes, sir.
So in case if they are different, and the randomization technique is not very robust, how will you try to balance when you try to compare the primary outcome parameters?
So I have to do a proper age and age matching and weight matching, and I would have considered only those patients.
So I mean, matching is not the right word, but you should be using the appropriate statistical test. Those were absent in your study, so that limits your outcome comparison. Also, you mentioned in the result section the p-value of 0.000, is it?
0.001, that is highly taken as statistically highly significant. No.
In your result section, in the tables, you mentioned about the p-value as 0.000, yes or no?
Sir, for which parameter? For
Many parameters.
For
Many
hemodynamic.
parameters.
So for
Many
hemodynamic
parameters.
profile, it was 0.001.
Paridhi, you just check back to your tables and check that if you have quoted p-value as 0.000. If yes, if no, then it's fine. I must have been confused. But there is nothing called p-value of 0, right? It has to be less than 0.001, right? So you should be careful when you are, just go back on your tables. Yeah, go back, go back, go back. So these are the p-value of 0.000, isn't it?
Yes, sir.
So there is nothing called p-value of 0.
Okay.
So it should be less than 0.001. So this is a wrong way of description of your p-values, right? So you should be careful. And also, as the hypothesis is not very robust, so you should be careful when you're picking up two patients, patient profile. The hypothesis should be clear from your study that what are you looking for? The bupivacaine effect, the buterphenol effect, the controlled versus uncontrolled hypertensive effect versus normotensive. So your hypothesis should be clear, right? Otherwise, this may be of clinical relevance, but once you incorporate all those aspects, it will be good, right? Thank you.
Thank you, sir.
Yes, we'll go to the next participant, please.
Thank you, sir. The next participant is Dr. Pritesh Parijar. Pritesh. Hello, Pritesh. Pritesh.
Can you go to the next one then?
Dr. Shetakar. Dr.
Yes, sir. Yes, sir. Am I audible?
Yes, yes, yes.
Yes, audible.
You can start.
Yes, sir. A very good morning to one and all. A very good morning to one and all. The topic of my paper is evaluation of efficacy of ultrasound-guided erector spiny plane block and oblique subcostal transversus abdominis plane block for post-op analgesia in a patient posted with lap chole. Lap chole is one of the most common minimally invasive surgeries performed in which intra-op access is provided with small keyhole entries on the abdominal wall. Lap chole may cause moderate to severe post-op pain owing to different procedural components like incisional pain from the trocar site and deep abdominal pain, which causes visceral pain. Many patients have also been known to suffer from post-op shoulder pain due to subdiaphragmatic irritation. Our aim was to compare the effectiveness of erector spiny plane block with OSTAP block for post-op analgesia after lap chole. Our primary objective was the comparison of total rescue analgesia consumption at the post-op 24-hour between the two groups. Our secondary objectives were the time of first rescue analgesia request, comparisons of NRS score at different time points, and complications in the first 24 hours. Material and methodology. After IEC approval, the study was designed to be a randomized double-blinded study, and informed and written consent was taken from all patients. 90 patients who were posted for lap chole were randomly divided into 3 equal groups of 30 each. Randomization was done according to a computer-generated random number table, and allocation to treatment was done using sealed envelope technique. Erector spiny plane block was performed in the ESP group, and oblique subcostal tab block was performed in the OSTAP group. IV analgesics were administered in the control group for post-op analgesia. Our inclusion criteria was ASA grade 1 and 2, either sex, patient posted for elective lap chole, and age group of 20 to 60 years. Exclusion criteria had patient who refused enrollment, known allergy to local anesthetics, bleeding diastasis, presence of CKD, a BMI of more than 30, infection at the site of needle puncture, and previous history of abdominal surgeries. Coming to erector spiny plane block, it was performed in left lateral position using a high frequency linear transducer in the in-plane approach. A 20 21 gauge 10 centimeter needle was inserted into the fascial plane after it was identified by the T9 transverse process. And on its anterior aspect, the local anesthetic was deposited. Coming to oblique subcostal tab block, this was performed in the supine position using a high frequency linear probe in the in-plane approach. All the patients were administered general anesthesia after standard monitoring procedures. Once the lap colle was done, pneumoperitoneum was evacuated at the end of surgery and ultrasound-guided blocks were performed. A local anesthetic mixture included 20 ml of bupivacaine 0.5%, 10 ml of lidocaine 2%, and 10 ml of normal saline to make the mixture totaling 40 ml, and 20 ml of this mixture was administered on each side. The patients were extubated and then moved to the post-op recovery room where they were followed up by anesthesiologist who was blinded to the group. Post-op pain was evaluated using the NRS score, and changes in NRS at rest and on movement were recorded at different time intervals. During the first 24 hours post-op, paracetamol 1 gram was given if the NRS score was more than 4. A total consumption of paracetamol in the first 24 hours and time to first rescue analgesia was measured in all groups. Also, NRS pain scores were recorded post-op at various time intervals, both at rest and when at cuffing. Shoulder pain during the first 24 hours or the presence of any post-op nausea vomiting was noted. This is a consort diagram showing that 102 patients were assessed for eligibility, of which 12 were excluded and 90 were randomized and allocated into 3 different groups, later followed up and analyzed. Observation, post-op rescue analgesic consumption, time to first rescue analgesia, NRS score, and any complications in the first 24 hours between the groups were compared. Statistical analysis was done per protocol using statistical package for social sciences version 21. Descriptive stats were expressed as mean plus or minus standard deviation. A p-value of less than 0.05 was considered statistically significant, and a sample size was calculated using the power of 80% and a confidence interval of 95%. The results obtained were that post-op rescue analgesia consumption in the ESP group and the OSTAP group was highly reduced, and the control group had a higher rescue analgesic consumption, which was statistically significant. The time to first rescue analgesia request in the ESP group and OSTAP group was also higher and was 152 plus or minus 37.44 minutes in the control group, which was again statistically significant. The NRS scores were lower in the ESP group in the first 6 hours as compared to all other groups. The demographic parameters showed that they were not significant except for the block performing time, which was statistically significant. This is a table showing the total analgesic consumption within the 24 hours and the time to first rescue analgesia, which was highly significant. Also, the NRS score at rest and with cuffing was significant up till the first 6 hours post-op. Complications, the incidence of post-op nausea and vomiting was considered insignificant. Discussion. Various other studies like Mohammed Ibrahim et al. Showed that ESP block and OSTAP block reduce the analgesic consumption, but Talgar et al. In his study showed that OSTAP block and ESP block performed led to akin analgesia requirement and improved the quality of multimodal analgesia. So the effects were similar. We concluded that ultrasound-guided ESP plane block performed for post-op analgesia and lap colle decreased the consumption of analgesic in the first 24 hours and delayed the time of first analgesia request when compared to OSTAP block and the control group. Also, the NRS scores at rest and after cuffing were significantly lower in the ESP group as compared to that of the OSTAP and control group. Larger number of patients in the OSTAP group and control group required rescue analgesia as compared to ESP group. Thank you.
Dr. Shweta, your presentation, especially methodology, was very good.
Thank you, sir.
In many areas of research and publication, our presentation have been covered, like in terms of the statistics, mention on statistics, and the consort flow, which is also used by other presenters. And illustrations were good. So that's most important. As I told already, whoever is talking about any technique, we must put an illustration there, either a color illustration or what you have done yourself. One thing is that we fail to do. when you have done a block yourself, the image that is put must be the one which was found by you only. Okay, so the block which you conducted and the drug getting deposited and all, I hope it is yours only.
Yes, sir.
But it should never be copied from internet source or textbook. So when you are done, we have to show it that it is done by us only.
Yes.
And again, one thing to again highlight is you talk about NRS. Yes, this is to convey to all the participants that you should talk about numeric rating scale. You should not be talking much about visual analog scale, because we can talk to our patients, we can develop communication with the patient, we can clearly ask them what is the numeric rating scale. So NRS has got a better validity as a research tool also. That's very important. And now I got two questions. Which nerves you have blocked by using the oblique approach?
Sorry, sir.
Which are the nerves? Which are the nerves blocked?
So,
Which nerves you blocked?
With the subcostal tab block, sir, we've blocked the subcostal nerve, the ilioinguinal nerve, the iliohypogastric nerve, and the intercostal nerve, T7 to T11.
So because this is a parietal block.
Yes, sir.
Right. Being a parietal block, does it cover the area of surgery, site of surgery everywhere?
Yes,
all the ports.
because it's deposited in the fascial plane. So when the plane at which we deposit the drug gets distributed 4 segments upwards and
right. Accepted. And
about 4 to 5 segments.
Okay, one last question and suggestion, which even Dr. Rakesh was telling in the first or second presentation.
Yes, sir.
Whenever you talk about a block related to the abdomen or the chest or open surgery or lap surgery also, we should be talking in terms of dynamic pain. For example,
yes,
if there is a lower abdomen,
was with movement, with coughing.
Or with cough, or with deep breathing.
Yes,
so because any that is the one. So pain at rest can be one of the parameters, outcomes, but you should go beyond that also.
Yes.
Okay. Dr. Rakesh?
I think maybe Shweta is getting an advantage of presenting later so that she has incorporated
no,
many
sir,
of the good things.
Not at all,
okay.
Not at all.
Okay. We appreciate you must have prepared well. So we congratulate. I think this was, she has talked about the randomization, the allocation concealment, the sample size, the primary objective. That's a good thing. Congratulations, Shweta, for the same.
Thank you, sir.
Only a couple of things I will just add on. One thing is you mentioned about the use of first rescue analgesia as a total dose, right?
Yes.
When you try to compare it, the total dose may vary because sometimes the weight in one group may be a little higher than this. So when you're comparing, it will be a good idea, as Dr. Balabhaskar was mentioning to the previous speakers, to per kg body weight.
Yes.
That will be more representative of the actual difference,
yes,
right? Second aspect, try to put up 95% confidence interval also, because that will give you a fair idea that how much is the dispersion, especially for the your outcome parameters, right? And in one of your graph, you showed both the table as well as the line diagram. Yes?
Yes, sir.
So if I ask you to choose one out of them, will we choose? So always never try to duplicate your representation of data. It should be either a line diagram or a bar diagram or a table or a text. So which will you choose one? You have mentioned both. I think that was for NRS.
So I'll choose the table.
So this will be your homework. So which will be a better option to see the trends of a particular thing when you are observing over time. So which will be a better option. So this is homework for you.
Okay.
So thank you so much, Shweta. I think good
Thank
presentation. Next, please.
Thank you, sir. Ritesh, are you ready now? Ritesh?
Yes, sir.
You can start. We are able to hear you. Ritesh.
If Shweta is not screen sharing, then I can start, sir. Sorry, Suvarashini. So actually, Suvarashini is sharing the screen. That's why I'm unable to.
Hello.
Suvarashini, actually, I am to present now.
Oh, okay, sorry.
Subardarshini, can you take your slide off the screen?
Yes, ma'am. Yes, ma'am.
Ritesh, you start.
Please come when you are called. Okay. Start. Please.
Yes, sir. I'm starting, ma'am.
Yes, yes. Sir.
Yes, please.
A very good morning to all of you, respected members of the jury, respected teachers, seniors, and my academic colleagues. It's a privilege to be given an opportunity to present my topic today in front of this august audience. Today, I'll be speaking on a comparative study between intravenous polymyxin monotherapy and intravenous polymyxin with inhaled colistin combination therapy in Acinetobacter baumannii infections. So Acinetobacter baumannii are a gram-negative coccobacilli that may cause nosocomial infections in critically ill or debilitated patients, particularly ventilator-associated pneumonia and infections of the bloodstream, urinary tract, and wounds. Now, the treatment of Acinetobacter infection is quite difficult as they're intrinsically resistant to multiple antimicrobial agents and have a remarkable ability to acquire new resistance determinants via mechanisms that include plasmids, transposons, and integrons. Since the 1990s, global resistance to antimicrobials has escalated dramatically among the ABCs, and as such, there is a need for thoughtful antibiotic strategies to limit the spread of MDR ABCs. Now, in this regard, the polymyxins are a novel approach. Polymyxins are a group of cationic polypeptide antibiotics consisting of 5 different groups from polymyxin A to E, which were discovered in 1947, but pharmacologically acting are the B and E groups. The cationic molecules of polymyxin B and colistin compete with the calcium and magnesium ions, which normally stabilize the lipopolysaccharide or molecule of the outer membrane of the gram-negative bacteria. In recent literature, findings regarding the reuse of polymyxins for the treatment of infections caused by MDR pathogens such as Pseudomonas aeruginosa and Acinetobacter baumannii were first reported by Levine and colleagues. Early therapy with inhaled colistimethate sodium, the prodrug of colistin, is being used with good effectiveness in preventing deterioration in patients who have cystic fibrosis and chronic infection. The IDSA 2018 guidelines recommend that patients requiring IV polymyxin therapy for suspected or documented XDR gram-negative hospital-acquired or ventilator-associated pneumonia should receive adjunctive polymyxin aerosol therapy. So keeping this in mind, we started a prospective randomized controlled double-blind study at Central ICU of SC Medical College with a study period of April 1, 2019 till March 31, 2020 with a 60 number of patients who were diagnosed with Acinetobacter infection. Now, the intravenous polymyxin was administered with a loading dose of 2 to 2.5 milligram per kg for polymyxin based on the total body weight that was equivalent to 20 to 25,000 international units per kg over a period of 1 hour, followed by a maintenance dose of 1.25 to 1.5 milligrams per kg that is equivalent of about 15,000 international units per kg total body weight every 12 hours infused over 1 hour. In spontaneously breathing patients, 1 million units of colistin were added to 4 ml of normal saline, and the solution was inhaled with 8 liters per minute of oxygen flow and inhaled via the face mask. In mechanically ventilated patients, the inhaled colistin was delivered by means of a Siemens Servo 2 ventilator. The nebulization was placed at the inspiratory limb of the non-humidified ventilator circuit, and all the patients received sedation and were put on the assisted volume control mode. During nebulization, ventilation was performed at a constant flow, and the respiratory rate was set at about 12 to 14 breaths per minute with a tidal volume of 500 to 600 ml and a peak value of 5 centimeter of H2O. Now, the study group characteristics were analyzed in both the groups, and it was found to be quite similar, as you can see from the data over here, with a mean age group of 59.2 in the adjunctive therapy and a 60.9 in polymyxin therapy. The Apache scores were calculated at the time of admission, and it was 17.4 in the polymyxin adjunctive therapy group and 19.2 in case of the polymyxin IV group. And the duration of previous antibiotic use, the previous hospitalization incidences were calculated, and duration of hospitalization until the first day of colistin treatment, and the duration of ICU stay until the first day of colistin treatment were analyzed, and they were found to be comparable as well. Now we move over to the results of the data, which shows that the days taken for the culture negativity were quite significant in case of polymyxin IV plus the inhaled colistin. The adjunctive therapy. It was 8.8 days in case of the adjunctive therapy and 12.1 days in case of polymyxin IV therapy. The length of hospital stay was found to be 20.5 in case of the combination therapy, whereas in monotherapy, it was 23.8. Also, the cure rate was found in 21 patients in case of the combination therapy and 17 patients in case of the monotherapy. Then the mortality rate was found to be 7 out of 30 patients died in case of the combination therapy, and the mortality was found to be 10 out of the 30 patients in case of the monotherapy. The adverse outcomes of nephrotoxicity was seen in 1 patient in both the cases, whereas bronchoconstriction was observed in 1 patient in case of the combination therapy. Now, the ventilator-associated pneumonia that we defined over this slides, as defined as part of the American Thoracic Society Consensus Conference on VAP, that shows a fever greater than 38 degrees centigrade with or no other recognized cause, leukopenia less than 1,000, more than with purulent tracheal stimulations, and new and persistent chest X-ray, and in patients being on mechanical ventilation support for at least 48 hours. The cure of infection was defined by the normalization of the body and temperature and the tracheal secretions, together with a return to baseline of the WBC count and improvement in chest X by the end of the polymyxin treatment. Now, 2015 meta-analysis has found that clinical response was improved and mortality was lower with adjunctive aerosol CMS. In a systemic review by Corbella et al., the combination of CMS with IV CMS was significantly superior to IV CMS alone.
We lost contact.
Yeah. Of gram negative. Hello. Hello.
Network problem.
Yes, your slides are not being shared, so some issues happen. Can you just?
Sorry, are they being shared now?
It's not being shared.
So just a minute.
I think you were on the last slide, so even if you want, you can just speak also.
So may I put the earlier slides, sir?
So you were on the discussion.
Hello.
You have just crossed the first slide of discussion from where we lost you.
Just a minute. So now is it being shared, sir?
No.
Ritesh, are you able to?
Yes, sir. Just a minute, sir. Sir, now, sir, I can start the sharing. Yes, sir.
Yeah.
So, where was it, sir? The study group. My results are.
I'm on the discussion slide.
Hello.
You were on the second slide of your discussion.
Discussion, sir. The results, right, sir? Yes, sir. Okay. So, what we found is that in case of the.
Come to discussion. This were over. Yeah.
Yes, sir.
Next slide.
Okay. This was my discussion, and then we move over to the conclusions.
Please carry on.
Yes. So, in conclusion, what we found was that the present study demonstrated that the infection outcome of VAP and HAP caused by the MDR strains of gram-negative Acinetobacter was better in patients who received inhaled colistin along with IV polymyxin versus those who received IV polymyxin alone. The use of inhaled colistin was an independent predictor of cure of VAP. The number of days required for culture negativity was also significantly lower in case of the adjuvant therapy when compared to monotherapy with IV polymyxin, and the length of hospital stay as well as the hospital mortality rates were lower in case of the adjuvant chemotherapy. Thank you for patient hearing, sir.
I have two observations and questions before I pass on to Dr. Rakesh. Pritesh, otherwise it's purely an ICU topic, so we have taken it. That's not a problem. But you should be telling us about the physiological status of the patients also who were treated.
So that is
table,
regarded in the Apache criteria, sir. So because
one table.
Yes, sir.
Just listen. In the sense, when you put demographics and the type of patients, they are the materials. This is a set of population are used in the study. So we would have been happy that in this group and in this in monotherapy group and in the combination therapy, this was the distribution of the cases. Have you done that in terms of their other system involvement?
So actually, most of the cases were that of ventilator associated pneumonia or hospital acquired pneumonia.
What I'm trying. Yes, it is. You are talking about VAP, but were there not any associated system involved? Were there patients, diabetes, patients with renal dysfunction?
Yes, sir. Yes, sir. Yes, sir.
With hypemia, those would make difference. And susceptibility, patients are probably have got low some background is.
Yes, actually,
so renal
I have
function
that
is
data.
one which is also very important. Yeah.
Yes, sir.
When you talk about polymyxin,
yes, sir.
Yeah, it is supposed to be more useful when you have patients with some renal dysfunction as compared to cholesterol alone. So we would have been happy if you had included those data as part of methodology and highlighted that part also.
Actually, sir, I have this data, but because of
Okay. No.
Yes, sir.
Right, Dr. Rakesh will take it up. But what I'm trying to tell, they are going to have, they are confounders also.
Yes,
understand? If somebody has got renal dysfunction and if you are administering colistin for the patient as compared to polymyxin, which is more safer here, or patient who has got immune suppression already. Yes, we are talking about ventilator-associated pneumonia, but the background of the patient's condition is also important.
Yes, sir. Yes, sir.
Okay. Even in terms
Yes,
of
sir.
response to the drugs.
Yes, sir. Yes, sir.
Dr. Rakesh?
Yeah, thank you, sir. Dr. Parijat, I think good study, clinically relevant study, but what Sharaj mentioned are important. So I'll add on to certain couple of things for you. Was baseline antibiogram available to you prior to start of the monotherapy or combination therapy, or the initial was empirical and then it was de-escalated?
So because if you see, so the study is done, I mean, after within 5 to 6 days of the hospital stay and within 3 days of this ICU stay. So initially there was this empirical study only, and as soon as the first reports of this, I mean, the first culture reports came, we started with the colistin therapy, sir.
I'm sure you must have started with your institutional infection control committee and antibiotic protocols. I'm sure about it. The second aspect is when for the study purpose, usually for clinical purpose, you provide the range of the drugs. But for study purpose, you mentioned that you will be using polymyxin from bolus of 2 to 2.5 milligram per kg. So which are the patient where you will give 2 and which are the patient where will you use 2.5?
Sir, actually, we used, I mean, weight wise, total body weight wise, we used the available combinations were about from 40 to 60, I mean, 5 million units in case of polymyxin. So what we did was for 40 to 60 kgs, we made this combination of about 20,000, I mean, 20,000 international.
This is what was not clear from your method section. So you mentioned you should be very clear. You said that because when you give a range, so which will be the population where you will start give polymyxin 2 milligram per kg and which are the patient where we will give 2.5. So you should be very clear about it that these combinations are available. So based on 2 milligram per kg and with nearest this, depending upon the weight, this dose should be given. So this should be very clear so that ambiguity is not there. Though you have used the fixed dose of colistin for all patients, but for polymyxin, it was weight based. So anything, you need to clarify in the introduction section that this much of the colistin is the standard doses for a VAP and all those procedures. So you should be clarifying into your introduction section.
Yes, sir.
Right. And we were looking for the length of hospital stay and mortality in a bar diagram, but I could not see the statistical comparison whether the data was having some statistical significance or not. We are not very sure about it.
So I showed that in the initial table, sir. I mean, for the length of hospital stay, it was sir, it was insignificant. Whereas I mean, 0.2, the p-value was 0.2. Whereas in case of mortality,
so they should come into your bar diagrams also, so that the statistical significance should be there, and you should not be then repeating data multiple times, right? I think it's a good study of clinical relevance, and I hope the baseline parameters that could be confounders for both the groups should also be disclosed in the demographic profile itself, right? Thank you.
Yes, sir. Thank you, sir. Thank you, sir. Thank you, sir.
Yes, sir. Our next participant is Dr. Subhadarshini Tripathi.
Sir. Sir, am I audible, sir?
Yes, you are audible. You can proceed.
Respected judges, all the panelists, and my dear colleague, a very good morning to all of you. Today, I am here to present my topic, a study on critically ill COVID-19 patients to demonstrate the association between disease severity, inflammation, and angiopoietins. Coming to the background of study, based on the current evidence on coronavirus disease, it was found that the most severely affected persons tend to have a very higher cytokine level, especially interleukin-6, due to the development of a phenomena known as cytokine storm. Also, there is a potential role of endothelial injury for the development of pulmonary manifestation, extrapulmonary symptom, and vascular thrombosis in this COVID-19 patient. So, in our study, we analyzed inflammation and endothelial injury biomarkers that are TNF-alpha, interleukin-6, angiopoietin-1, and angiopoietin-2 with regards to disease severity of critically ill COVID-19 patient. So after obtaining ethical committee clearance and informed written consent, the study was performed in the COVID ICU of SCB Medical College from a duration of September 2020 to January 2021. The study population was divided into two groups, that is Group A, which was COVID positive severe group, and Group B, COVID positive critical group. So the severe group of the patients are the patients who are positive for COVID-19 and having a respiratory rate more than equals to 30, or saturation is less than 92% in room air, or having more than 50% of lung involvement in chest X-ray or CT scan. Whereas the critical group of patients, they are the patients who are having respiratory failure that need mechanical ventilation, or patients having multi-organ failure, or the patients having vasopressor support that due to the presence of shock. So each of the group consisted of 32 number of patients. Inclusion criteria was elderly patient of age group 50 to 75 years who are positive for COVID-19 RT-PCR in the nasopharyngeal swab. The following diagram depicts the demographic data that was comparable. My primary objective was to assess the level of inflammatory markers, that is TNF-alpha and interleukin-6. And second, the next objective was to assess the level of vascular injury biomarkers, that is angiopoietin-1, angiopoietin-2, and the ratio of angiopoietin-2 is to 1. Whereas the secondary objective was to know the severity of organ involvement that can be assessed based on the requirement of ICU, renal replacement therapy, and vasopressor. So now coming to the procedure, peripheral blood samples were collected on ICU admission on EDTA containing tube, and they were centrifuged within 10 minutes of collection for 30 minutes. Cytokine level were analyzed in two-fold diluted plasma using microfluidic ELISA technique. The inter-assay and intra-assay coefficient of variance for this inflammatory markers was less than 9%. Whereas the level of angiopoietin-1 and 2 was determined in 5-fold diluted plasma using commercially available ELISA kit, and the inter-assay intra-assay coefficient of variance for them was less than 12%. Power analysis was performed using chi-square test for independent samples on the frequency of the patient having severe or critical disease. That was the main outcome of the study. Taking power of the study of 0.8 and alpha error of 0.05, a minimum sample size of 32 was calculated for each group. Data analysis was done using SSPE software. taking p-value of less than 0.05 as statistically significant. The following results were obtained. So from this table, we can see the creatinine level in either group A and B was increased, but the comparison was insignificant, whereas the level of inflammatory biomarkers, that is TNF-alpha and interleukin-6, was significantly higher in the critical group as compared to the severe group. The level of vascular endothelial injury biomarkers, that is angiopoietin-1, was elevated in both the group, but the comparison was insignificant. And angiopoietin-2, as well as the ratio of angiopoietin-2 is to 1, was increased in the critical group significantly as compared to the severe group. So based on this, the injury markers, that is duration of stay in the ICU, requirement for renal replacement therapy, and requirement of vasopressor support was significantly higher in the critical group B as compared to the severe group. This bar diagram depicts the level of interleukin-6 and TNF-alpha, where the blue bar represents the level of interleukin-6 and TNF-alpha is represented by the red bar. That clearly shows the levels are significantly higher in group B as compared to group A. This bar diagram represents the level of vascular injury biomarkers, with the blue bar representing group A and red bar representing group B. So from here, we can see the level of angiopoietin-1 is equal in either group, whereas the level of angiopoietin-2 and the ratio of angiopoietin-2 is to 1 was significantly higher in the group B, that is the critical group, as compared to the severe group. Now, concluding my topic, COVID-19 is at least partially a vascular disease with endothelial damage, angiopoiesis, and thrombosis. Angiopoietin-2 expression is promoted by different stimulus like inflammation and hypoxia. And also there is a positive correlation between angiopoietin-2, TNF-alpha, suggesting endothelial activation induced by inflammation. Also, TNF-alpha-2 level correlates with the requirement of ICU and associated mortality in the patient. Critically ill patients tend to have a higher cytokine level as compared to the severe group. Angiopoietin-2 production can be promoted by different stimuli like inflammation, hypoxia, that promotes endothelial permeability and lead to the development of pulmonary edema and hence disease severity. Pertaining to the review of literature, Daniel et al. Also performed a study in COVID patient, ARDS due to non-COVID reason, and sepsis patient, where he found a higher level of cytokine in the non-COVID associated ARDS as compared to the COVID infection. Pratik Sharma et al. Also performed a study in 5 cohort patients, each consisting of 100 patients, where they found a high level of interleukin-6 cytokine in the non-COVID associated hyperinflammatory type of ARDS as compared to the COVID type. These are my references. Thank you.
Rakesh, you can take first.
Yeah, sure, sir. Thank you, Shubhadarshini. It was a good study where you were looking for the various parameters in COVID-19 patient. So one thing is, what about the sample size? You mentioned that you took the frequency of severity of patients. So what was the source of this data? This was not clear from your sample size calculation.
Sir, I took a power of the study as 0.8 and confidential interval of 95% was taken. From that, I obtained the sample size of 34.
So you cannot obtain the sample size from just power and confidence interval.
So there is a formula from which I can derive. That is.
So can you just describe? To my knowledge, there is no formula based on which you just using the 95% confidence interval of 95% and power of 80%, you can have sample size. You need to put some data into it, the severity of score or something. Then only you can calculate those things.
Yes, sir.
Any idea about it?
Sir, there is a formula that is U into S divided
Okay,
by...
no issues. No issues. From formula, you cannot. In formula, you have to give your data. You have to put up your values. So I'm asking those values. What was the severity of patient's number that you put up into this to get the outcome sample size?
Sir, I first selected total 90 number of patients. From there, I divided who are critical and who are
I think just Subhadarshini, I'll suggest you just go back and look for that. What are the inputs for calculating a sample size, right? So there are certain things that you need to look and feed into the sample size calculation. Second aspect is when we are talking about the inflammatory markers, they would be influenced by the therapy. For example, patient may be on steroids, patient may be on certain other drugs. So we need to have the comparison of baseline parameters also for those things, which were not clear into a result section. So if a patient is having, say, has been started on high dose pulse therapy of steroids, the inflammatory levels will go down. So we need to have the comparison of these data also before we come up to a conclusion. So was it there into your study?
Yes, sir. That was excluded. The patient who are like having inflammatory disease, rheumatoid arthritis, and all, they were excluded from the study.
No, I am talking, try to understand the judge's question before you answer them.
Yes,
so I am asking something, you're answering something different. So be very clear what I am asking. I'm just saying that steroid is one of the important therapy that has been started for COVID-19 patients.
Yes, sir.
So there are variable forms of steroids. Some uses pulse therapy, some uses higher dosages, some uses lower dosages. So your result section was not mentioning about those things. Steroids can affect the inflammatory things. So how will you look for the confounder of steroids into your patient vis-a-vis outcome parameter? So, any reply to it?
No, sir, sorry.
Okay, so you just go back and look for those things. So when you plan a study, look for the factors, or we say them confounders, which can affect your primary outcome parameters. And they should be comparable in two groups. They should be standardized in two groups. So you should say that all patients will be receiving this dose of steroids for all the patients, and then look for other parameters which is of your interest, right? So this is from my side. This will help you to have better understanding of the study. Over to sir, Dr. Balabhaskar, sir.
So just to discuss, in the sense, both of us, I was in the thick of COVID management, so was Dr. Rakesh. So this is, yes, you are trying to correlate, but it is very difficult to take out results and the final take home from this. Because we have found levels, quite lower levels associated with significant mortality, and extremely high levels, sometimes patient escaping. Okay, I have seen even 300, 400, 500 levels, values of IL-6, and IL-6 of even just around 20. So patients dying at 20 or surviving at 300 or 400. These things have happened. And there has been further progress and development. Of course, those markers maybe we are not able to get in our laboratories. For example, IL-33. IL-33 is supposed to be another one which is supposed to be very good and more focused upon the lungs and the lower respiratory tract.
Yes, sir.
So what only thing, as Dr. Rakesh was telling, all of them are on steroids, which we definitely use for these patients. Sometimes high dose steroid used for the patient, methylprednisolone versus which are used,
Dexamethasone,
which is very frequently used. And with respect to possible correlation with the ventilatory parameters for the particular patient, the type of ventilation of the patient, definitely they will be on invasive ventilation only. Okay? But the amount of support, the duration of ventilatory support for the patient, the improvements in with respect to the blood gases, because it has been always hypoxia which was referred to and talked to throughout the COVID period. Okay, we have never seen that much of hypoxia throughout our services, but we have seen them, and some of them have come out also. So the timing of administration of, checking the IL-6, you said severe cases and critical cases, and a sample was taken and IL-6 was assessed. So one thing in future it will be useful to correlate is the duration of the disease per se before the patient came to the ICU, how long the patient was already bad in terms of the other markers and clinically in terms of hypoxia. Okay, in terms of again hematological disturbances that the patient has got and relate to the outcomes. So these are confounders. Patient could be on culture sensitivity would have been done, and we would have given antibiotic which is different in each other patient. So these are the confounders. So when we decide to publish, suggestion for you is you have to add all these things because they will be the ones which will be questioned by the reviewers also. Okay. So it's a good attempt. Thank you very much.
Thank you.
Thank you, sir. Our next participant is Dr. Sunayana Mahapatra.
Good afternoon to one and all present over here. So can I start?
Yes, yes.
Yeah. Good afternoon to one. I'll be speaking on the topic prediction of propofol-induced hypotension based on ultrasound-guided IVC collapsibility index. As we all know that hypotension is a very common side effect of general anesthesia post-induction. And whenever it is severe, it is related to various adverse outcomes. Rich et al. Has identified various predictors of significant hypotension post-induction of general anesthesia. They can be divided into modifiable and non-modifiable risk factors. Coming to non-modifiable risk factors, these are the age of the patient, comorbidities, and utilization of various anesthetic drugs. And coming to non-modifiable risk factor, it is the volume status of the patient. Since ages, we have been utilizing the central venous pressure monitoring to monitor the volume status of the patient. But because of its invasiveness and because of lack of reliability, it has been seriously criticized. Hence, in today's era, with increased utilization of ultrasound and in the OT setup, it was a need of a time to identify an easily modifiable risk factor, such as the impaired preload in the OT setup, which will help to predict the patient who will develop hypertension post-induction. Different literatures have given that around 140 definitions to define hypotension. And we have chosen the following criteria, like the mean arterial pressure of less than 60 millimeter of mercury, systolic blood pressure of less than 90, more than 30% drop in the initial blood pressure reading, and a patient who require the bolus dose or infusion of vasopressor as a rescue measure to who develop significant hypotension as our criteria to define hypotension. After obtaining approval from the Institutional Ethical Committee, the study was conducted at SCB Medical College and Hospital. It was for a period of 12 months and 20 days. It is a prospective observational study. There were various inclusion criteria in my study, like age of the patient being 18 to 70 years of age, belonging to physical status 1 and 2, patient requiring general anesthesia, that is induction with propofol, followed by tracheal intubation, and patient who gave written informed consent who are willing to participate in the study. And there were various exclusion criteria like patient diffusion, ASS status more than 3, patient with anticipated difficult airway, IVC non-visualization, blood pressure of more than equal to 180 by 110, or systolic blood pressure of less than 90 were some of the exclusion criteria. One day prior to the study, the PSC was done to ensure that the patient is fit to undergo the study. The written informed consent was taken from the patient, and all the demographic data like the name, the age, sex, height, weight, and ASA grading was collected, and the type of surgery was also mentioned. On the day of surgery, the patient was shifted to the OT prior to the surgery. Patient was made to lie down while breathing spontaneously for 5 minutes. Then, an ultrasonography scan was performed by an adequately trained anesthesiologist using a curvilinear transducer. The IVC was visualized by using a subcostal approach, that is a paramedian long axis view, 2 to 3 centimeter caudal to the right atrial junction. And the variation with respiration was also mentioned using AIM mode was performed. And various reading like the IVC maximum diameter during expiration and IVC minimum diameter during inspiration was recorded. And the IVC collapsibility index, that is IVC maximum minus minimum divided by IVC maximum, was calculated and was expressed as a percentage. Then all the standard monitors were attached and the patient were induced as per standard protocol. The patient was given pre-medication by giving injection glycopyrrolate, injection fentanyl, injection midazolam. Then injection propofol was given in a dose of 2 milligram per kg till there was a loss of response to verbal command. Then the patient was intubated and surgery started. The data collected. The hemodynamic parameters like the systolic, diastolic blood pressure, mean arterial pressure, the heart rate were measured at baseline. Then it was measured immediately post-induction, thereafter every 2 minutes for a span of 10 minutes. A pilot study was conducted prior to the start of the study to maintain the power of the study at 80%, alpha value of 0.05 and confidence interval of 95%. The sample size was calculated to be 8 to 2 patients. In order to maintain the adequate power, additional 25% were also screened. Hence, a total of 104 patients were enrolled in the study. The numerical data were presented using mean and standard deviation. The ROC curve was also used to find an ideal cutoff value for the variable like development of significant hypotension and IVC collapsibility index. The chi-square test was used to find the statistical significance, and various diagnostic parameters like the sensitivity, specificity, positive and negative predictive values were calculated. This is my result. I have enrolled 110 patients, total 110 patients were recruited in the study. From those 6 patients were excluded, 4 because of inadequate visualization of IVC and 2 because of change in the anesthesiological plan. Hence, a total of 104 patients were enrolled. Out of this 104 patients, we found that 32 patients developed hypotension and 72 patients did not develop hypotension. This is an ROC curve. The ROC curve analysis was done to find the relationship between the significant hypotension and IVC collapsibility index by taking the sensitivity and 1 minus specificity. And we found a minimal cutoff value of 0.43, that is 43%, that was found to be statistically significant, and the area under the curve was found to be 95%. Depending upon that, as I've already said, that 43%, if the patient has a collapsibility index of more than 43%, they were divided into collapsibility index positive group, and the patient with less than equal to 43% of collapsibility index, they were divided into collapsibility index negative group, and various baseline population characteristics were studied, like the age, the sex, BMI, hypertension, baseline systolic blood pressure, mean arterial pressure, and propofol requirement. From both the group, we can see that only the age that was statistically significant. Apart from that, none of the baseline population characteristics was significant. Here we can see that the median age in the collapsibility index positive group was 8 years older as compared to the patient in which the collapsibility index was negative. Then this is both a graphical as well as tabular representation of the result that I've already shown. Here we can see that 32 patients have developed hypotension. From this 32 patients who developed hypotension, we found that 28 patients has a collapsibility index of more than 0.43. That is accounting to about 87.5%. And 4 patients developed hypotension, but they had a collapsibility index of less than 0.43. That was accounting to about 12.5%. Similarly, in about out of 72 patients, 67 patients had a collapsibility index of less than 0.43 who didn't develop hypotension. And various diagnostic parameters were calculated from the data as shown before, like the sensitivity, specificity, positive and negative predictive value. The sensitivity was 87.50, specificity 93.05, positive and negative predictive value was also on the higher side. And the accuracy of the test was calculated to be 91.3%. In the study undertaken, an optimal cutoff value of 43% was calculated, and this was found to be statistically significant to predict hypotension following induction. The accuracy of the test undertaken was 91.3%, together with a high positive and negative predictive value. Our finding was supposed to be superior when it was compared to the study done by Sasbo et al. Using the universal cutoff value of 50%, which show an accuracy of 86%. Limitation of my study, the sample size could have been bigger. It was difficult to standardize spontaneous breathing in all the patients. Since all the measurements were done by single anesthesiologist, inter-observer variability can be questioned. And some of the patients were also having systemic hypertension who were on antihypertensive medication. So the drug would have affected the degree of hypotension post-induction. Hence, I could like to conclude IVC collapsibility index of more than 43% as measured by ultrasonography are more likely to develop hypotension post-propofol induction. Thank you.
So a good study is Sunena, basically.
Thank you, sir.
Very basic test, which would be useful in the perioperative period for us also. Again, technical aspects, you should be explaining more. You should be also mentioning the frequency of the probe.
So it was a curvilinear probe, abdominal curvilinear probe with a frequency of 2.5 to 7 megahertz.
2.6. Okay. So when you mention here, the same thing should be mentioned in the presentation also, along with a photograph of the machine itself.
Okay,
this is
sir.
important. The particular brand and the model of the particular machine, along with the shape of the probe or the probe which you are using, along with the frequency. So all these things must be shown in one of the slides. That's very important.
Okay, sir.
So that's one aspect. And second thing is there is a basic problem which I have talked to many of the presenters. You should also be picking up the other evidences.
Okay,
understand? So you only talked about one evidence where that 0.5% was taken as a break or the limit, and there was assessment done. So definitely there are more studies because this is not a new study per se. It's good one for us in Indian setup, but it
Yes,
has been there in the field for last few years already. So we should be able to compare with other studies, okay, based upon not just the demographics, the types of the study and the patients. Yeah, put some of them in the limitations I accept, but
Yes, sir.
as you take it forward, you should also improve upon the methodology here also.
Okay, sir.
The position of the patient, then the pre-existing
So it was
evidence.
totally done. The patient was there in the supine position, sir. In the supine position, the ultrasonography scan was done, sir.
Methodology and overall, when I say that it is about propofol, we accept this for short duration. But
Yes,
these
sir.
are some of the confounding factors overall.
Okay, sir.
Dr. Rakesh, please.
Yeah, I think this is clinically relevant study, but you have to make the method section more robust. Say, for example, the technique of propofol administration itself predicts the incidence of hypotension. So
Yes,
if
sir.
you give a bolus of propofol over say 5 seconds, the chances of hypotension will be much higher. If you give it over 60 seconds, the chances will be of little lesser. Same thing again, if you give fentanyl, I'll wait for 3 to 5 minutes and then give propofol, the requirement of propofol will be less. So when you take these factors, because these are called confounders, they will affect the hypotension. So they are not just related to the collapsibility index as per the ultrasound guided finding of the IVC. They are the confounders. So you should standardize it. That propofol 2 milligram per kg will be given over 60 seconds after the administration of fentanyl 2 mics and waiting for 3 to 5 minutes, right? And
Yes, sir.
secondly, the IVC collapsibility index changes with the whether patient is spontaneously breathing or in apnea, isn't it?
Yes, sir.
So same dose of patient will have different effect. So that is again other confounder that you should be very, very cautious into these things. The other aspect is again, which was I was mentioning to Sunena, the previous speaker also, the sample size calculation includes some primary outcome variable, like for example, the incidence of hypotension or the effect size or the change in the collapsibility index. Again, your the sample size calculation just mentioned about the power, confidence interval, and there was nothing mentioned about what
Sir,
other input.
So it was based on a previous study where there was 50 patients taken in the study.
So you
So
need to mention the data which you have used from the previous study when you say about sample size, right?
Okay, sir. Okay, sir.
And also there was a lot of discrepancy regarding the failure. You mentioned you mentioned about the failure rate, which was not matching with the actual failure rate, and the final inclusion of the patient into the analysis was absolutely different. So a sample size was not correlating with the actual number of patients you have studied. Right?
Yes, sir.
So have you, yeah.
Actually, 104 patients I have studied 104 patients, but total 110 patient was taken. But since 6 of the patients were excluded from my study, so I didn't include in the study itself, sir.
So these all things should be coming to you into sample size calculation because those two readings were not matching each other. So then your study becomes underpowered, right? So you
Okay,
should
sir.
be cautious when you are interpreting. And I think rest of the things are good. So you should be expanding on the method section more robustly, and they are repeatable in the same format so that you can say your outcome variable is very, very true, right?
Okay, sir. Thank you,
Thank
sir.
you. Good study.
Thank you.
Go ahead.
Thank you, sir.
Thank you.
Thank you, sir.
Thank you, sir. Our next participant, Panchanan Sethi, Dr. Panchanan Sethi.
Good afternoon.
Panchanan, yes.
Am I audible? Am I
Yes,
audible?
yes.
Good afternoon, all. Myself, Dr. Panchanan Sethi, second year postgraduate resident in Department of Anesthesiology and Critical Care, Bhimsar, Bulla. Now I am going to present my topic, Walking Epidural, a comparative study between levobupivacaine 0.1% and ropivacaine 0.1% with fentanyl in labor analgesia. Coming to background, joy of childbirth is always accompanied with the fear of pain. Painless labor is every mother's right. Walking epidural is a popular method of enhancement of bupivacaine having less or minimally is preferred for labor analgesia. Hypothesis: we hypothesize that intermittent bolus administration of levobupivacaine with fentanyl provides better analgesia than ropivacaine with fentanyl without affecting maternal and fetal outcomes. We have compared 0.1% levobupivacaine plus to microgram per ml fentanyl with 0.1% ropivacaine plus 2 microgram per ml fentanyl during epidural analgesia. Am I audible?
Your sound is
Am I
breaking,
audible?
Panchanan. Yes, now you are audible.
Am I audible?
Yes, you are now audible.
Sir. Not audible, sir. Okay, sir. Okay.
Yes, sorry.
Objective epidural labor analgesia using intermediate bolus technique. Primary objective is onset, duration, quality of analgesia, and degree of motor blockade. And secondary objective is maternal outcome in the mode of delivery, maternal
can I MP प्रथम क्वेश्चन के बोलते फ्रीक्वेंसी पर नर्व को जी एक गोटी क्वेश्चन तो पचार ले हम तो कॉल कर
at 1 minute and 5 minutes. Then material and method, place of study, room of department, Bulla.
Panchanan, you are not audible at all.
September 2020.
Kamala, you can shift him to next. Tell him to come to
Panchanan, sorry to intervene. Panchanan, sorry to intervene. Your sound is not clear.
Let him log out and again log in, please.
No, next other speaker speak and tell him.
Finished. Last speaker.
Then let him log in and this thing and go to a night at least better networking zone or make some mobile hotspot on.
Let him log out and log in.
Am I audible?
Yes.
You are not audible.
Yes, sir.
Start from the beginning.
Yeah. Working epidural, a comparative study between levoviacan 0.1% and ropivacaine 0.1% with fentanyl in labor analgesia. Background: joy of childbirth is always accompanied with a fear of pain. Painless labor is every mother's right. Working epidural is a popular method of practicing labor analgesia. Levoviacan or ropivacaine are enantiomers of bupivacaine having lesser or minimal blockade and toxic effect. Hence, it is preferred for labor analgesia. Hypothesis: we hypothesize that intermittent bolus administration of levoviacan with fentanyl provides better analgesia than ropivacaine with fentanyl without affecting maternal and fetal outcomes. We have compared 0.1% levoviacan plus 2 microgram per ml fentanyl with 0.1% ropivacaine plus 2 microgram per ml fentanyl during epidural labor analgesia. Then coming to objective, the aim of this study is to compare levoviacan and ropivacaine in epidural analgesia during using intermittent bolus technique. The primary objective is onset, duration, quality of analgesia, and degree of motor blockade. And secondary objective, maternal outcomes in terms of mode of delivery, maternal satisfaction score, and neonatal outcome, Upgar score at 1 minute and 5 minutes. And coming to materials and method, place of study, labor room, OG department, Bhimsar Bulla, period of study, October 2019 to September 2020, and study design, prospective randomized double-blinded study. And study population is 60 priming gravida with uncomplicated singleton pregnancy, and a sampling technique, simple randomized sampling, and study tool includes epidural kit, VAS score, modified Bromage scale, and Apgar score. Am I audible? Am I audible?
Yes, Panchanan, you are
Yes, you are
audible. You can
audible.
proceed. Proceed, Panchanan.
Audible, sir? No, sir.
Proceed,
Yes.
you are audible.
Sir. Then selection criteria, inclusion criteria, full term pregnancy, full term priming gravida 37 to 42 weeks, ASA grade 1 and 2, singleton pregnancy, cephalic presentation, cervical dilatation 4 to 5 centimeter, age 18 to 35 years, and exclusion includes high risk pregnancy, twin molar breach, concomitant disease like tuberculosis, hypertension, and diabetes, and non-allergy to steroid drugs, patients who have received other analgesics, and contraindicated to epidural like kyphosis, scoliosis, local infection, and bleeding diathesis. Am I audible?
Yes, you are audible.
Yes, sir. So my slide is not.
You proceed. You are audible.
Yeah.
Next slide, please. Panchanan.
No, sir. Sir.
I think he cannot see the slide. That is what he said. Somebody guide him how to share the slide. It is being seen, but he cannot see.
Sir.
Yes.
Methodology following approval from. Sir, methodology following approval from Institutional Ethical Committee. 60 primary gravida fulfilling inclusion criteria were enrolled into a study. Written informed consent was obtained from all participants. Participants were randomly divided into two groups of 30 each, Group L and Group R. During active stage of labor, epidural catheter was given in L2, L3 space. Group L received 15 ml of 0.1% levodopa with 2 microgram per ml fentanyl. Group R received 15 ml of 0.1% ropivacaine with 2 microgram per ml fentanyl. Epidural top-up we are given participants complaint of pain. The VAS score more than 4 with 10 ml of drug solution. Then onset of analgesia and pain assessed by VAS scale. Quality of analgesia was assessed by verbal scoring system. 0 for no pain, no awareness. 1 for aware of contraction but not pain. 2 score 2 aware of pressure but tolerable. 3 distressing pain. And motor vehicle was assessed using modified Bromage scale. Participants were encouraged to ambulate for 5 minutes in every 15 minutes. During second stage of labor, top up of with 10 ml same drug solution was given in sitting position. Heart rate, BP were monitored every 10 minutes interval. And statistical analysis, all data were recorded in Microsoft Office Excel sheet. Statistical analysis was carried out using SPSS version 19.0. Demographic data, onset of analgesia, duration of analgesia, and duration of labor was analyzed by on-paired student T-test. Quality of analgesia, degree of motor blockade were assessed with chest square test. Blood pressure, heart rate was assessed using paired student T-test. Mode of delivery, fetal Apgar score, and maternal satisfaction score was assessed by percentage. These are showing demographic data, and onset of analgesia in group L is 21.43 plus minus 4.3 minutes, whereas in group R it is 23.57 plus minus 2.8, and p value is 0.026. Duration of analgesia in case of group L is 68.17 plus minus 4.9 minutes, and group R is 65.77 plus minus 4.1, where p value is 0.0044. And duration of labor in case of group L is 480 plus minus 19.1 minute, where in case of group R it is 493 plus minus 21.7 minute, and p value is 0.016. And quality of analgesia, both group L only procession of contraction but not pain. In case of group L is 79%, whereas in group R it is 71%. Then coming to Apgar score at 1 minute, both group L and group R have excellent Apgar score. That is Apgar score in group L in 1 minute having Upward score 8 having 83%, whereas in group R it is Upward score having 97%, and in group Upward score 5 minutes in group L it is 90%, where group R it is 87%. Then motor vocal assessment by modified Brome scale, score was 0 in total 55 patients, but in group R 5% are showing score 1 modified Brome. And maternal satisfaction score assessment was excellent in both groups. And mode of delivery having non-vaginal delivery 23% in each group, and 77% in each group having cesarean section delivery. Coming to discussion, equipotent concentration of ropivacaine and bupivacaine in labor anesthesia claimed that both are effective and safe at 0.1%. However, Bowman et al. Found levopivacaine to be 19% more potent than ropivacaine in labor anesthesia. Robinson et al. Proved that adding fentanyl provided effective anesthesia with minimum local anesthetic dose. Following successful studies from Kaina and Shankar et al., Kapuna et al., we prefer to provide anesthesia by intermittent bolus technique. In our study, the onset of anesthesia was in minute, that is 21.43 plus minus 1.7 in group L, whereas in group R it is 23.57 plus minus 2.8, which is comparable to studies by Gotter et al. And Pudi et al. The mean duration of analgesia was 68.17 plus minus 4.9 in group L, whereas in group R it is 65.77 plus minus 4.1. Our results are not comparable to Puri et al.
Your voice is again breaking.
Both groups did not have significant difference in duration of analgesia. In our study, very few participants had mild degree of motor blockade. All we are allowed to mobilize, work under supervision. Quality of analgesia during peak uterine contraction was excellent in both groups. 79% in group L and 71% in group R. Yeah. Okay.
Dr. Panchan, I think you have overshooted your times much beyond the assigned to you. But however, can you just put up what was the novelty of the study?
It's not online.
Dr. Panchanan, you respond, please. Dr.
He's
Panchanan.
It's not disconnected.
Hello, Dr. Panchanan. Are you able to hear?
He's disconnected. Meanwhile, we can have the next speaker ready. If he comes back,
Okay, sir. Now we are having our last participant, Dr. P. Aishwarya. P. Aishwarya is our last participant. P. Aishwarya.
She's online. She's there.
P. Aishwarya, are you there?
Yes,
Aishwarya.
yes, she's there. Manos, please help her.
Okay, let her prepare the screen. Meanwhile, Dr. Panchanan is there. Panchanan, you are there?
Good afternoon, sir. Am I audible?
Panchanan has started, yes.
Okay. Just hold on, Dr. Shipri or Panchanan, you are online. We don't want your screen. You please remove the screen sharing.
Panchanan.
Yes, sir. Yes.
Remove the screen. That's enough. We have just a few questions. Rakesh, you can ask him.
Yes, sir.
Yes, sir.
Panchanan, are you able to hear?
You just unshare your screen and listen to the question and try to answer them.
Sir. Sir.
So can you just say me two questions
Yes,
for
sir. Yes,
you?
sir. Sir.
Just
Sir.
listen first.
Sir.
What is the
Sir.
novelty of the study?
Sir.
Number one. Number two, how did you calculate the sample size? Two questions for you.
Sir, we are using a previous study and to calculate the SI, sir, sample size.
So what all data that you have seen, what you have seen as a primary outcome variable in this that you use for the sample size calculation? Previous studies are so many about from this topic.
Sir.
So can you just express that what novelty was studied from this study so that you can say that previous study was lacking into this feature and you have done something new and there is something new which you have observed?
Sir.
Okay. Okay, Panchanan.
Sir.
Which nerve roots you block for labor analgesia?
Sir, in second stage of labor, we are using S2 to S4, sir. S2 to S4, sir, nerve root we should block.
See, there is a basic confusion for you, Panchanan. Okay, you are going to block. You are not stopping. T10, T11, T12, L1 is blocked, followed by several roots.
Sir.
Understand? So that and then you should know what you should all give definitions. What is the definition of when you say onset of analgesia means what?
Sir, that is, sir, starting up. These are subsiding pain, sir.
Okay, right. Thank you, Panchanan. Thank you very much. We'll go to the next speaker, please. We'll have the next speaker.
Dr. Aishwarya. Dr. Aishwarya.
Sir, am I audible?
Yes.
Good afternoon, sir. Am I audible?
Yes, you can start.
Can you able to see my screen, sir?
No. You share your
Hello?
You
Open your
share
My
PPT,
screen is
please.
not yet shared, sir. Yes, sir.
PPT is not visible.
You open the PPT or not open the PPT yet.
Hello, sir. Can you able to see my slide?
We are able to hear, but not able to see your slides.
Start sharing the
I
screen.
already started sharing the slide.
Share screen.
Ma'am, firstly open your PPT, then there is a share screen option.
Yes, sir. My slide is.
There is a share screen option.
Screen button, and then you start your screen sharing.
Hello.
Hello.
Hit the green button, share screen button. Hello.
Aishwarya, what happens? Hello.
Yes, sir.
Hello, sir. I already shared the screen.
You do
The
it once
sheet
more.
is not shared.
Once more, it's not coming. Just unshare it and then share it again.
So, okay, sir. So now it's
I think network problem.
Ashwarat? Yeah. Please double click on
yes, sir.
screen.
Yes.
Yeah.
Yes,
Your PPT is
yes.
visible now.
Now it's visible, sir.
Yes, it's visible.
Hello?
Yes, you can proceed now.
Yes.
Yes.
Good afternoon, everybody. Today I'm going to talk about comparison of short sedation between dextromethorphan and propofol for post-operative mechanical ventilated patient in ICU, a prospective randomized study. Introduction. Critically ill patients requiring mechanical ventilation frequently needed sedatives and analgesics to facilitate their care. The concept of analgesia and sedation in intensive care medicine have changed constantly over the last decade. Deep sedation is no longer the standard practice as it prolongs weaning from mechanical ventilation and length of ICU stay. Inadequate sedation can result in anxiety, agitation, and recall of stressful experience in the post-ICU phase. Propofol has number of properties which makes it potentially superior choice for ICU intubated patients, such as rapid onset and offset, even after prolonged administration. Dextromethorphan is a sedative with high affinity for alpha-2 adrenoreceptor. It does not interfere with respiratory rate, arterial oxygenation, and carbon dioxide pressure. Aims. The aim of the study was to investigate and evaluate the efficacy and safety of dextromethorphan in comparison to propofol in the management of sedation for post-operative intensive care unit patients as sedative agents. Criteria and methods. This is a prospective randomized comparative study. It was conducted on the patients admitted to ICU after a surgery after obtaining patient informed consent. 60 mechanically ventilated patients aged between 20 to 50 years were included in the study. They were randomly allocated into two groups of each 30. Group D received dextromethorphan loading dose of 1 microgram per kg over 10 minutes, followed by maintenance of 0.2 to 0.7 microgram per kg. Group P received propofol loading dose of 5 microgram per kg. The infusion rate was increased by increments of 5 to 10 microgram per kg until the desired level of sedation was achieved. Inclusion criteria are aged between 20 to 50 years, elective general surgical procedures, ASA grade 1 and 2, and visual analog sake greater than 4, and Ramsay sedation score less than 2. Exclusion criteria are allergic to the study drug, pregnancy, severe respiratory, cardiovascular, or neurological disorders, prolonged sedation requirement. Parameters compared are pulse rate, respiratory rate, blood pressure, both systolic and diastolic, mean arterial pressure, saturation, Ramsay sedation scale, visual analog sake, recovery time from sedation, and analgesic requirement. Sample size is determined by the formula, where delta is the size of difference of 0.28, and alpha accepted as alpha error of 5%, and beta is the power of the study, assuming 80% of power, and standard deviation of data of previous study was 0.086. Results, demography, in both the patient number of both the patient group D and group P were 30 each, and age between the both group were comparable, and p-value of greater than 0.05 is non-significant. And cardiorespiratory variables, parameters, pulse rate, respiratory rate, blood pressures, and mean arterial pressure were comparable between the both groups, group D and group P, both pre-operatively and post-operatively, and the p-value of greater than 0.05 is non-significant. Ramsay sedation scale,
in a time 20 minutes till 24 hours were compared between both the dexam group and propofol group, and the p-value of 0.05 is non-significant between the groups. Visual analog score between the two groups, Group D and Group P, at 20 minute and the different hours till 24 hours were calculated, and between the dexam group and propofol group, that it was calculated that p-value was 0.0015, which is highly significant. Discussion: this observational study is investigating the effect of dexmedetomidine versus propofol in patients requiring sedation in intensive care unit. Dexmedetomidine is an effective as propofol for reducing and maintaining adequate short-term sedation of critically ill mechanically ventilated patients. Cardiovascular stability and respiratory function were both well maintained with dexmedetomidine and propofol. The benefits of dexmedetomidine over currently available sedative agents include its shorter half-life, lack of respiratory depression, and its ability to decrease the need for opioid analgesic. The administration of bolus 1 microgram per kg dexmedetomidine initially results in a transient increase of blood pressure and a reflex decrease in heart rate, especially in younger patients due to peripheral alpha-2 adrenoreceptor stimulation. Can be at a slow infusion over 10 or more minutes. The initial response lasts for 5 to 10 minutes and is followed by a decrease in blood pressure of approximately 10 to 20% below baseline values and a stabilization of the heart rate. Both of these effects are caused by the inhibition of the central sympathetic outflow or stimulation of presympathetic alpha-2 adrenoreceptor, leading to a decreased norepinephrine release. Conclusion: in the present study, dexmedetomidine is safe and effective agent for sedation of mechanically ventilated patients admitted to the ICU after general surgeries. Depth of sedation is similar to that given by propofol, and extubation time is equally rapid. The cardiorespiratory variables of patients sedated with dexmedetomidine are similar to that of patients sedated with equipotent doses of propofol. These properties, combined with the analgesic qualities and lack of respiratory depression seen with dexmedetomidine. Dexmedetomidine could be used safely and effectively in the postoperative ICU as a sedative and analgesic agent. And these are my references. Thank you.
Good study, Aishwarya. Just one point from your side. You said that the endpoint for sedation in the two groups, dexmedetomidine and propofol, you were looking for the Ramsay sedation score.
Yes, sir.
So how were you titrating? Were you looking for the fixed dose of dexmedetomidine and propofol, or you were looking for the Ramsay sedation score? Because in one of your table, we could see that the Ramsay sedation score at multiple times was much higher.
Yes, sir. Depending upon the sedation level, propofol doses were increased to reach the adequate sedation. And dexmedetomidine dose has been fixed with the 0.2 to 0.7. In that, we have been titrating the doses level.
So, so why this confusion was there that one dose was fixed and the other dose was not fixed, irrespective of the other outcome parameter?
For dexmedetomidine, we had a range of 0.2 to 0.7 for maintenance dose, and for propofol also we had a range of 5 to 10.
So this is what I mean. In the method section, how are you increasing the dose based on Ramsay sedation score? Because if we say in your one of the table, even after many hours, the Ramsay sedation score was more than 3.
Yes, sir. Yeah, so, with a constant rate of even after the constant did not decrease or increase, the patient having this maintaining the sedation in some patients, so that that outcome was similar.
So did you find any patient wherein you think that a particular drug was not giving good sedation and you need to look for other rescue sedative drugs for these patients while they were on post-operative mechanical ventilation?
Can't get you, sir.
Rescue sedation. Any patient require rescue sedation to achieve the targeted Ramsay sedation score?
No, sir. No, sir. We were just increasing the dose, but the patient required a rescue.
And how did you reach the sample size calculation?
So,
sample size. How did you selected your sample size that this number of patients are required for this study?
from the previous study, sir.
Any data from that?
And I didn't add in this slide, sir, but I am having it.
Okay, no issues, no issues. Dr. Bala Bhaskar, sir. Dr. Bala Bhaskar, sir, is here. So no issues. Thank you, Aishwarya, for a good study. So just a couple of points which we have shared, just try to elaborate into your.
Sure, sir, sure.
To make them more clear so that the things becomes much better. Thank you, Aishwarya.
Thank you so much, sir.
And thank you, Chairperson. I think if Dr. Bala Bhaskar sir is here, I would request him to just summarize, because we have seen 15 interesting cases. So what all things we should be careful? I think these are all good cases. We have just given our input so that you can just add on to it so that the study becomes much better. So when we do these type of RCTs, be very clear that if it is an RCT, randomization process, allocation consideration should be clear. In the introduction section, your research question or a hypothesis should be very clear. You should must mention the sample size, because sample size is based on some effect size. So those data must be disclosed into your method section, and try to include your results so as to include, try to have idea about the statistical significance versus clinical significance, and that should come into your discussion section. So these are a couple of things that we have observed. Otherwise, majority of you have done wonderfully, but we would like whatever the points we have given was not to criticize you, but to just provide you critique so that you can incorporate into your future studies and you become a better researcher. So thanks you once again. If Dr. Bala Bhaskar sir is here, can I request him to put a concluding remarks if he's here? So I think some network issues. So thank you so much. Thank you all the participants, and over to the organizers, Dr. Nivedita Pani, Dr. Rekha Das for the conclusion.
Thank you, Dr. Rakesh, for you have given such a valuable time of yours on this Sunday, you and Bala sir, and we are grateful to you. And competition is a competition, and the thing is that the students have learned a lot thing from you, and the basics and whatever. We are grateful to you, Dr. Rakesh, and hope to see you in real form as a judge in the next future to ODISHA.
Thank you so much.
Over to you, Kamala.
Thank you, ma'am.
Thank you.
Thank you, sir.
Thank you all.
Manas, move to next session.
Hello. Dr. Swain and Dr. Nivedita. So there was.
I think Dr. Bala Bhaskar want to say a word.
Yeah. I think there was some problem. He was not allowed inside. I mean, technical issue, not otherwise. Technical issue. Thank you very much for the opportunity. We enjoyed the session. Of course, the boys have to grow. I mean, the students have to grow further. At least they have learned a lot, I think, from.
Thank you, Bala. Bala, are you audible? Bala? Dr. Bala?
Madam, I think he has left the session.
No, I think because of the internet. Anyway, we can move. We can.
Some internet issue, technical issue.
Okay. Okay, move to next session.
Good afternoon. Welcome to this Professor S. Satpathy Memorial Exhibition Award. Initially, this this competition award was commissioned to encourage research among the practicing anesthesiologists in the periphery. Fortunately, due to the paucity of these papers, the faculty in the medical colleges were also included in it. So today, we have 3 papers for the competition, and to judge them are 2 eminent faculties from Chandigarh and Mumbai. Dr. Nidhi Vidut Panda, she is the professor and head of division of neuroanesthesia at PGI Chandigarh. With her, Dr. Litika Swain, she is the professor at Topiwala National Medical College and BYL Nair Charitable Hospital at Mumbai. At present, she is also the president of ISA Mumbai branch. Now, over to judges for starting of the session. So, first speaker is Dr. Karjamriti Parida.
Please start a slideshow.
Yes, sir. Am I audible? Good morning.
Right.
Yes, ma'am. Please start a slideshow.
Yes.
Ma'am, right side in the bottom. Right side in the bottom.
There's a slideshow button.
Slide slow.
Yeah.
Yes. Just a minute, sir. Okay now?
Okay.
Yes, ma'am. Please start.
Okay. It's very with warm regards to all. Coming to my topic, anesthetic challenges in hyperthermic intraperitoneal chemotherapy. It's a case report. Let's know what is HIPEC. It is a hyperthermic. This is a type of chemotherapy where we give the warm fluid with the cytotoxic drugs circulated intraperitoneally for 1 hour, resulting the tumor lysis. Having the principle synergistically with warm fluid and cytotoxic drugs increase the penetration to the tumor cells up to 5 millimeter with the cytotoxic drugs and causing the acidic environment around the tumor cells, causing the tumor cells lysis. Next, where it is indicated, like its indication is pseudomaxima peritonei and other carcinoma stage. HIPEC require the specialized things like this is the specialized HIPEC machine what has been used and specialized fluid. In our setup, we use the Baxter peritoneal dialyzed fluid with 1.5% dextrose, and they use the mitomycin as a cytotoxic drug. So, coming to my patient details, our patient is 52-year female patient having the repeated surgery due to the pseudomaxima peritonei posted for the HIPEC. This patient is SA3. Previously, pre-anesthetic checkup was done and written consent was taken. My patient was within normal BMI, positive finding with ascites and anemia, with other investigations and normal, and she was not having any comorbidities. Our surgeons planned with a large midline supine position incision from sternum to symphysis pubis. They did the cytoreduction of the tumors. Then they introduced the HIPEC for 1 hour with a hyperthermic solution 42 degrees centigrade to 44 degrees centigrade. Then they planned for closure of abdomen. That was their job. But coming to our job, for anesthesia point of view, this is our redo major laparotomy procedure that already the tumor causing the physiological changes over the body. Next, the cytoreduction effect, the hypothermic body physiological changes. Then we should remind that cytotoxic drugs adverse effect. As we know, hyperthermia will cause these effects like the large fluid shift, tachycardia, cardiac output increase, and peripheral vascular resistance decreases. And we use the mitomycin as a cytotoxic drug. For us, it is important as side effects is pneumotoxic, that is pneumonitis. We require the large dose of antibiotics to prevent the pneumonitis, and myelosuppression, which is a delayed response of the drug, so patient need to be followed up. Specific concern for HIPEC. As a team leader, as a anesthesia at the head end, we have to be very careful. As HIPEC produce the aerosol, the scavenging system of the machine is very, very useful for there, and scavenging system should work. And strict no to the pregnant staff, breastfeeding and pregnancy planning staff. And we should use whoever is coming contact with the HIPEC solution, they should use a arm length gloves to prevent the contact of the skin. And for all, we have to remember spillage of the drugs should be avoided, and whatever things we come in contact with the cytotoxic drug solution, that should be discarded as a labeled cytotoxic drug before sending it to re-sterilization or discharge. Next, it's always a anesthetic management for any case. We know this is a team approach, so here our HIPEC also stand as a team approach. And next, coming to how we tailor our case, this is we planned for a general anesthesia with controlled ventilation and pain management with a multimodal analgesia. As a female patient, we put a cupped 7 mm orally placed ET tube with controlled ventilation. Multimodal analgesia, we plan intrathecal morphine with local anesthetic, ultrasound guided regional blocks like subcostal tap, conventional tap with supraumbilicus rectus, and we use the intravenous infusion with dexmedetomidine throughout the intraoperative procedure. And in addition to it, we use intravenous infusion of ketamine in analgesic doses. Next, coming to monitoring, as a ASA grade standard monitoring, you use all the monitoring, but specifically we have taken the extra care for the temperature monitoring. As we prepare for patient for monitoring is rectal temperature and nasal temperature to monitor the core temperature, and skin for the peripheral temperature monitoring, because in HIPEC we have to very cautious about temperature monitoring. Coming to the anesthesia management, we induce and intubation and maintenance of the patient as per the standard drugs with standard dose. We have used no specific method was any different. So maintenance is with oxygen, air, and sevoflurane with intravenous atracurium infusion, and we use the vasopressor and proton pump to prevent the DBT, ultrasound guided placement of right IJV, large bore cannula, and left radial lateral cannulation. Core temperature is already placed. We use these things to maintain our temperature. Hemotherm was very good, handy for us. Coming to the anesthesia concern, that they did the cytoreduction and redo surgery. Large fluid shift and unseen blood loss and protein loss was expected. So with hyperthermia, coagulation, alteration also expected. We did multiple ABG and lab reports with electrolytes and lab report of PT, APT, INR multiple times during intraoperative. Our specific fluid was used terofondin and tabilite to in view of dyselectrolytemia. Coming to main part is temperature maintenance. Before introducing HIPEC, they told around 36-degree body temperature we have to maintain. So after the intubating the patient, we started the hemotherm in higher range 70 minutes before of putting the HIPEC. We start to increasing the temperature by the one fluid warmer and ambient temperature and a hemotherm to reach the 36-degree core temperature. Then they introduce the HIPEC. We maintain throughout the 1 hour of HIPEC 36.5 degrees centigrade peritoneally. In HIPEC machine, in the input limb, they have the thermistor to monitor the core temperature. So they are very helpful for us also. In later phase of HIPEC, before 20 minutes, they told when we will be out for HIPEC, you have to maintain the 33 degrees centigrade. So by placing the ice pack over axilla and thigh and cold fluid, we reached up to that. But cooling was more sooner than the temperature maintaining. So this table I am seeing how it is taken, the warming the patient, it has taken longer time, but cooling was less, and mine urination was more than 700 ml per hour. Next slide, I am showing the ABG and other lab reports in things. When I actually on table extubation was planned, but at the end of the plan surgery procedure, we have the PA 7.25 and lactate is 3.3. So postpone the for extubation planned for elective ventilation. In between, we have maintained the insulin level as we saw in this glucose has increased. And next, coming to post-op journey by her, we shifted with tube for elective ventilation with the vasopressor support and planned in ICU 300 ml per hour fluid with albumin and POD first next day in 12 blown patient was extubated, noradrenaline stopped. In day 4, rice tube removed and solid oral solid was started. He was quite good ambulatory. And day 5 surgical drain removed, Foley's catheter removed day 6 and day 8 patient was discharged happily from the hospital. And just to fill up, I think in this study, what we know for HIPEC and hypothermia temperature variation and dyselectrolytemia, maybe intraoperative neuromuscular monitoring and dexfluran and non-invasive cardiac output monitoring may be each on table extubation. And we gave the hypothermia time, the anti-seizure prophylaxis, but whatever review literature I have seen, they have not mentioned about that, sir. So where we stand about that, and this also will be helpful. And during coagulopathy, as we know, as a point of care, TEG will be helpful. That was not available in our setup. And I think more cases to be reported for HIPEC to have a standardized protocol so that institutional variation won't be there. And this is my references. Thank you. Thanks to ISA, thanks to Judge and our beloved patient surgical teams and Apollo anesthesia team. Thank you, sir. Thank you.
Thank you, Dr. Kadambini. I just want to ask you that as an anesthesiologist, what is the main concern you faced? Because it is a long surgery and post-operative mechanical ventilation required and everything. But what is the main concern you faced?
Main concern is to balance the temperature variation, madam. It is with a large incision, patient will be start lessing the temperature, so warming the patient. Again in HIPEC, you have to maintain, they will come out from HIPEC, you have to little bit cool the patient, and cooling is much more easier. And for us, I thought cooling, we planned for 20 minutes over, we reached the 33 degree, but within 5 minutes we reached. So our temperature was going down. So rewarming was more challenging for me. So that extubation has taken a long time, we cannot extubate the patient. That is the challenge.
Yes, it is always there that in the cases where we do hypothermia in many situations, rewarming is more difficult than causing hypothermia.
Yes, madam. That also that is the point.
Why, one more question from my side is why there is a coagulopathy you expect?
Madam, already the tumor has been in place, pseudomaxima peritonei, that oncology, pathophysiology which cause coagulopathy. It will cause coagulopathy. So though our lab report shows PTT-PTINR was normal, but still hypothermia and with cytotoxic drugs and tumors, pathophysiology is altered, which can lead to coagulopathy. In which direction it will go, we don't know. But we are lucky. We are lucky with our lab report showing PTT-PTINR 4 times I repeated, it shows it is normal limit.
How many cases you do?
Madam,
this is a case report.
This is my first case and it is Odisha's first case also, madam. I know in South and you people in your side are doing frequently, but it is our first experience. And
Okay,
in
this
case
is
report I studied, their bleeding tendency is much more. And some studies show they are bound to use the heparin intraoperatively. So where to go, I don't know. So I plan I should avoid the epidural and I should go by my lab report.
Okay. Lipika can.
Yeah. Now I just want to ask you, like you have really managed very well and doing a very great job. I just want to make you aware about the fact that in these kind of patients who are very moribundly ill, are you going for a prehabilitation? Like you know the terminology, prehabilitation and what all it includes. Can you please answer?
Yes, madam. Rehabilitation means actually before the operation, surgeons can plan with the anesthesia team. It should be oncological team approach. We should avoid the malnourished patient. General condition of patient should be really improved with the means a higher range of albumin sites and patient general condition and hemoglobin. All things will be normalized, and that we can avoid the ascitic fluid. All these things you have to be taken care. So
yeah,
that
the indicators are like there are 3 factors.
yes.
You must be knowing them. So actually, if we follow that very strictly, or give some time to just optimize the patient, then the outcome really becomes very good. Like you know the indicators. What are they? Clinical indicators.
Madam, not ever.
Yeah, you can hear me.
Yes. Yes,
Yeah.
sir. Yes, madam. We
Yeah,
go
the
through
clinical
the
indicators. Yeah.
yes, only the albumin level and BMI and general condition of the patient. Otherwise, that any other things.
Yeah, weight loss more than 5% since past.
Yes, 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 madam. That PK
And
index is there. Yes.
yeah, so basically we can just these two are in our hand, like improving the nutrition, which includes anemia and the albumin. That's
Yes,
okay.
madam.
But
I mentioned.
what about PFT? Do you know like the PFT can also increase the outcome of the patient post-operatively? Why the
Yes, madam.
PFT is important?
Pre-operatively, that's to having the good result of PFT, we have to advise the deep breathing exercise and incentive spirometry as per other laparotomy cases.
Yes, yes, because they have no in these patients if they have the pre-op hypoxia due to diaphragmatic splinting and basal atletic, as we know. So taken care of because that is the main. The oxygen consumption goes very high in onco. So if you can discuss it well with your team, then that can be taken care of, and then it really improves the outcome. Where protocol set in your own institution, and these are easy things. So everybody knows what is to be done.
Okay, madam.
You really did a very good job.
Okay, madam. Thank you. Namaste. Namaste to everybody. Best of luck to the other participants. Thank you, madam. Thank you.
Hello. Hello.
Yeah, we are able to hear you.
Good afternoon, everyone. Today my topic is comparison. I am Dr. Soumya Samal, Professor, Department of.
Please start a slideshow.
Slideshow. It's not coming here, sir.
Ma'am, you see zoom in, zoom out option.
Zoom is there.
Then left button is slideshow button. First one left.
So just give me 1 minute.
Ma'am, you go on bottom right side.
My screen is being shared, na sir? Slideshow.
Your screen is shared. Yes, ma'am. Your screen is shared. Yes, ma'am. Please click on it.
Okay.
Now good. Yes, ma'am. Now is it okay? Please start.
Okay. Okay, good morning. Good afternoon. Today my topic is comparison between intravenous dexmedetomidine and spray as you go technique with 4% ignocaine versus intravenous fentanyl and transtracheal injection of 4% ignocaine for awake nasotracheal intubation with flexible videoscope. It is a single band randomized study. Now coming to the introduction, awake fiber optic bronchoscopy guided intubation is the method of choice in difficult airway which requires effective airway anesthesia to ensure patient comfort and acceptance. As we know, there are various techniques, but airway nerve block is the gold standard technique. But sometimes due to distorted anatomy, massive neck swelling, traumatic injury to head and neck, and local infections, it makes the airway nerve block unacceptable. So this mandates us to think of an alternative airway anesthetic technique. So aim of this study was to assess the quality of airway anesthesia, patient comfort during intubation, and post-operative patient satisfaction. Primary objectives were to assess the endoscopic time, intubating conditions, vocal cord position, cough severity, comfort during intubation, and post-operative patient satisfaction. Secondary objective was to assess adverse reactions like sore throat, hoarseness, unpleasant memory, and to assess the hemodynamic response during laryngoscopy and intubation. It's not good. Now, study design, it is a prospective, single-blinded, randomized study. It was followed as per institutional ethical committee guidelines, and a written informed consent was obtained from each of the patient for the study, and also CTI registration was also done. Place of study was our Department of Anesthesiology, IMS and some hospital. Study period was from 1/9/2019 to 30/1/2021. Sample size, we did a pilot study done on 10 patients. The required sample size was calculated to be 40 patients to demonstrate a 30% difference in post-operative patient satisfaction score with a power of study of 80 and type 1 error of 0.05. To allow for study error, we took 60% and were included in the study. Now coming to the inclusion criteria, we took patients of ASA grade 1 and 2 of both sex posted for surgery under general anesthesia between age of 18 to 60 years. Exclusion criteria were the patients who did not provide consent, who had an allergy to any study group, patients who are hemodynamically unstable, pregnant patient, ASA grade 3 and 4, and with abnormal coagulation profile. Sampling technique were randomly divided equally into group of 30 each by using computer-generated randomization number. Study groups were Group D, patients received intravenous dexmedetomidine 1 microgram per kg over 10 minutes, along with 4% lignocaine spray as you go, and patient F received IV fentanyl 2 mics per kg over 10 minutes, along with transtracheal injection of 4% lignocaine. Now coming to methodology, after describing the study and study protocol to the patient and written informed consent, as a standard monitoring were administered like ECG, pulse oximetry, NIVP in the operation theater based fluid were started. Stabilization was done in all patients with 2% lignocaine 5 ml for 15 minutes. Xylometazoline was administered. Xylometazoline 0.1% nasal drops, 2 drops in each nose were administered. Pre-medications glycopyrrolate 0.004 milligram per kg IV, along with midazolam, ondansetron, and pantoprazole were given. Group D received dexmed 1 gram IV over 10 minutes along with 5 ml of 4% lignocaine through fiber optic videoscope after we entered into the epiglottis. Then group F received fentanyl over 10 minutes along with 5 ml of 4% lignocaine as transtracheal injection. With supine position, fiber optic videoscope was checked for illumination, and pattern nostril was chosen for nasal fiber optic intubation, and other nostril was for oxygen insufflation. After desired sedation level as per AMSIS sedation score equal to 2, the fiber optic videoscope and introduced, and cuff size of 8 and 7 were used. Videoscope was passed through glottic opening after of tracheal rings and carina. The endotracheal tube was railroaded over the videoscope into the trachea and secured with 3-4-5 centimeter above the carina. Position of endotracheal tube was confirmed by chest auscultation, also by capnography, and the tube was secured and cuff inflated. Then general anesthesia with propofol and vecuronium was administered, and established mechanical ventilation was established. Then coming to parameters were endoscopic time, which was the time from the introduction of fiber optic into the nostril till the visualization of the glottis, intubating condition, vocal cord position, cough severity, comfort during intubation, post-operative patient satisfaction, baseline heart rate, mean arterial pressure, pulse oximetry, post-intubation heart rate, mean arterial pressure, pulse oximetry, and to see any adverse effect like laryngoscope, bronchoscope, and desaturation. Now, these are the grading which we have taken from Pooja Mehra et al. Along with some modification of ours. for different indices. Now coming to the statistical analysis, we use 23% of SPSS, and for normality test, we use Shapiro-Wilk test to distribute the numeric into parametric and non-parametric data. Parametric data were compared between two groups using independent t-test, and non-parametric data, for non-parametric data, we used Mann-Whitney U-test. Categorical data was used to, statistically by chi-square test or Fisher exact test. Numerical data were expressed as mean and standard deviation, and categorical data are expressed as numbers and percentage. All analysis were two-tailed, and p-value less than 0.05 was considered statistically significant. Then this is the console for though none of the patient lost to follow-up, all patients were analyzed. Now coming to the result, demographic profile were comparable in both the groups in terms of age, sex, weight, and ASA grading, and also Mallampati grade 1 and 2. Now coming to basal heart rate, there is no difference between the basal heart rate, but in post-intubation heart rate, there is significant difference. Also in post-intubation MAP, but there is no difference in post-intubation SpO2. Now we'll move on to next step. Though endoscopic time was more in group D because we have allowed spray as you go, where we have to wait for 1 minute to local anesthetic to act. Now coming to the results. Now this is the this is cuff score, which is significantly better with group D. Along with comfort during intubation, it is also significantly better with group D. Now post-operative satisfaction was also, intubating conditions were significantly better with group D along with vocal cord position. Post-operative satisfaction was also significantly better with group D. So conclusion, injection dexmedetomidine 1 microgram per kg over 10 minutes intravenously along with spray as you go technique with 4% lignocaine is effective than injection fentanyl 2 mics per kg over 10 minute IV with transtracheal block for away fiber optic videoscopic intubation in terms of intubating conditions, focal cord position, cough severity, comfort during intubation, post-operative patient satisfaction, along with significant attenuation of post-intubation hemodynamic response, though endoscopic time is more. Limitations of my study was it is a single-blind study, and there is chance of observational bias, and also some patients may tolerate better intubation, tolerate better at the same level of sedation. So that is my maybe limitations of our study. Differences. Thank you. Hello. Hello. Hello.
Yeah, you are audible. Dr. Lipika wants to ask first.
Yes, madam, please.
You ask, ma'am. You finish asking again.
Okay, Soumya, it is a nice presentation. And I have few queries.
Yes,
what is your primary outcome?
Primary
And
outcome.
usually when we do study, we should have one primary outcome. From that primary outcome, we should check the sample size calculation.
Yes, madam. Post-operative patient satisfaction score was our primary outcome.
But you have not written that. You have written
yes, madam. I had written.
All timing.
No, I had written post-operative patient score in sample size. First we did
sample size, not in primary outcome. You have written all the
mention. It was written in the last, madam. I'll share the slide.
Yes, that's what. Actually, primary outcomes should be 1, and
yes,
from that sample size calculations should be done.
Yes, madam. We did.
Okay. So whenever next you want to write this paper, you can do that. The primary outcome is the post-operative patient satisfaction, and
yes,
accordingly you. So how you graded that patient satisfaction?
We have graded it here, madam. I'll share the screen along.
Okay. Just you can speak.
It is after 24 hours we asked the patient. So, and we asked it whether how he felt. It was good, fair, good, excellent. Like this we have graded.
Okay. My second question is that how you anesthetize nose and oral cavity?
Yes, madam. Oral cavity, we first did nebulization with 2% lignocaine. And nose, for nose, we have given one vasoconstrictor. Then we have put jelly for bilateral nose. We had put
What
Xylocaine
jelly?
jelly, 2% xylocaine jelly we had put.
Oh, that is for that reason. What I want to tell you that if even transtracheal lignocaine and all, you have given 4%. So have you calculated the dose? Safe
We
dose.
have
What
calculated
is the
safe
safe
dose.
dose?
That is why we didn't use 4% for nebulization, because it was crossing our safe dose, because most of the patients were about 60 kg. That's why we gave 2% lignocaine for nebulization and 4% for because we are giving without adrenaline, because adrenaline may bias the study. So we have calculated 3 milligram per kg body weight maximum dose, like that. It was a bit
And
below.
you kept the dose under 3
It
milligrams.
was, yes, madam, it was under our.
And you have given dexmedetomidine or fentanyl only bolus dose,
Bolus
not
dose.
not infusion.
Not infusion. And most of the patient were very nicely. And we are trying to increase the sample size and include melampathy grade 3 and 4 now also. We have done this with
And
only melampathy grade 1 and 2. So
have you said sedation score?
we will include
White
melampathy grade 3 and 4.
Have you
Yes, sir.
said
I'm
sedation
sedation
score?
score 2. Up to 2.
2 of what? What scoring system?
Ramsey sedation score.
Sedation score.
Sedation
Okay.
2.
Okay.
It should be at
So,
least.
what was your sample size calculation? How many patients you have?
Madam, it was about coming 40, but we took 60, and none of the patients were lost actually. They were, didn't have any problems, so we continued with that. And we are trying to increase the sample size also now, because we'll be including melampathy grade 3, 4, and for that also we are trying.
Okay. Okay, this is a nice study. Now,
Yes,
Lipika can ask.
It's a good study. Yeah, I just want to ask you one thing. Like, when you did this procedure, like you said that increased time is needed in the dexmedetomidine.
Yes, madam. It took more time, because
how much
almost 1 minute, 60 seconds more, because we were after giving spray Azigo, we had to wait to local anesthetic act. Our primary background was to use in patients where we cannot give transtracheal in transtracheal or airway nerve blocks. So we can wait for 1 minute to.
One thing I just want to ask you, like did you see any fall in saturation?
Because it was up to 96, 97. None of them have, because oxygen insufflation was there. Patient was spontaneously breathing. So up to 95, 96, even there was no post-saturation, desaturation was
we're going to do on melampathy 3 and 4. So that's why I just want to ask you, like, that can also add to your difficulty in intubating, even though you are
yes,
taking.
madam. That's why first we completed with this, then we'll go for ethical committee, and again we'll go for melampathy 3 and 4. So it will be.
Yes. And the Cormac Lehan, had you graded also along with this view?
Cormac Lehan, we have not seen. Cormac Lehan, not melampathy, we have graded. Cormac Lehan, we have not gone. Bifroptic, we will.
Cormac Lehan is no. If you correlate later on, like you are going for melampathy, no. So
okay, madam.
You start correlating with Cormac Lehan when you are visualizing just before, no. Then you
okay,
can have
a next time we will do.
hold and the patients, means many things will be like, the position of the cord and the time to increase, time to access the vocal cord, time to intubate. So those events will be focused more, because here anyway we have decided to go for fiber optic. So anyway we are taking the gold standard, what is there for our difficult this.
Yes, madam. Yes,
when you are accessing Cormac Lehan and the movement of because the major problem will be happening that time only. If the patient is well saturated, then it is fine. It's very important that at that point the SATs should be above 96, because
yes,
if due to hypoxia that restlessness comes, it can't be prevented by anything. And
yes,
then transtracheal you have given, but still if the cough and that thing comes, then there will be no margin for the hypoxic effects will immediately be, it will not be a very smooth experience.
Yes,
and I just wanted to tell you, like, it can be very difficult depending on the view of this when you go for Mallampati, along with the Mallampati, the Cormac lane and other views are not correlated. So you be ready for that smoothness also.
Yes,
when
ma'am.
you are
Yes,
doing
ma'am.
this,
Next time
further
we are
study.
planning for
Otherwise, it's a very good study. But my personal viewpoint is with the Dexmed, we were needing higher dose. So
No,
you have
that's why we have not taken any over obese patient. Means actually they were comfortable, madam. Till now, we will
No, it was your comfort or the patient's comfort.
No, patients were also comfortable there at that time.
Yeah, because we were not very comfortable unless we increase the dose. So that's why unless they receive some anxiolytic or something like,
Midazolam was given.
Along with dexmedetomidine.
Yes, madam. Midazolam was given in both the patients.
Actually, we omit that. We give it little later on. Yeah.
Yes, Midas was given.
Okay, good. Very nice.
One more question.
Yes, ma'am.
What is the novelty of your study? What is new? Because so many studies are there in. So,
madam, none of them has compared with so without blocking. Means I wanted to show that Dexmed is whether can be used as a sole agent along with spray as you go technique in this type of case where we cannot give block.
It is used. It is commonly used. Nowadays, it is commonly used. We
But
give
along with nerve block,
dexmedetomidine and spray as you go. This is a very common technique.
Yes, madam.
So,
along with airway nerve blocks, none of them has. Everybody has used airway nerve blocks. I had seen so many papers, but none of them has used as a sole agent without nerve blocks.
No, when this has come that spray as you go, that time the block has been stopped and nebulization followed by some sedation and
So propofol they might have used, not Dexmed, madam. Till now I have not, because I am writing for publications also. So till now I have in discussion I didn't get any type of only with Dexmed. Propofol was also used along with Dexmed. Madam, till now I don't know, madam, but till now what I have got. Not audible, madam. Sorry, madam, not audible.
Yeah. Actually, what I was telling that dexmedetomidine has taken up anesthesia. Everyone is fond of dexmedetomidine and we are using everywhere. So what we also used to do, but what we do, we nebulize with 2% and everywhere we use 2% only. We don't use 4%. Just because of the scare of toxicity. We don't use, but otherwise, nice study. Thank you.
Thank you. Thank you.
Next participant, Dr. Ashok Kumar Bhatmali. Third and last one, Dr. Ashok Kumar Bhatmali.
Good afternoon to all. Am I audible?
Yeah.
Okay. Good afternoon to all. My presentation is a clinical trial evaluation of Sanjeevani. It's a compression only life support or COLS gadget for the community use and resuscitation ecosystem. Since there are few disclosures, the intellectual property right of Sanjeevani is with me and it's protected with Indian Copyright Act. This is the registration number 95039/2020, and I have got the provisional patent and trademark is also there, and prototype grant from the Department of Science and Technology. To avoid prior art issue, the ergonomic design of the complete device will not be disclosed in this public forum. Sanjeevani is a novel audiovisual gadget for high quality chest compression to be used in victim of cardiac arrest, which will replace your palm and help in easing your chest compression rate. So before its CE or FDA certification, it was evaluated during routine code blue training and mock drills at Kalinga Institute of Medical Science. the performance of Code Blue team who are trained on Sanjeevani during actual cardiopulmonary resuscitation was considered as a surrogate indicator of the device performance here. So the device has 3 visual feedback by LED lights for rate, depth and recoil adequacy, and audio feedback like in regional language, good job, low rate and low recoil. So the members of Code Blue team were trained at least once in a week on AMBU mannequin or QCPR along with this electronic component of Sanjeevani. Part of the Code Blue team who are posted in the high dependency area were trained with the feedback device component of Sanjeevani. The component of high quality chest compression like rate, depth and adequacy were immediately remediated during their practice through Sanjeevani on task trainers. On Monday to Wednesday, the particular Sanjeevani group were doing practice on Pulsar CPR Q mobile application, which has a metronome rate of 100 beats per minute. So intracardiac hospital, in-hospital cardiac arrest and Code Blue response data from January 2020 to February 2021 of our hospital was analyzed. Since Sanjeevani train were exclusively cardiac science group where the incidence of in-house cardiac arrest is more and response is quick and team is robust, we consider the performance of resuscitation team as surrogates of the device performance. Once device regulatory is completed, we will come up with resuscitation data of CPR where compression of sternum will be using Sanjeevani instead of hand of the rescuer, and ergonomic utility data can be taken into consideration on subsequent studies. So total number of in-hospital cardiac arrest was 61 from January to February 2021. The resuscitation done by Sanjeevani group was 23, out of which 19 has achieved return of spontaneous circulation within 20 minutes. Out of the rest 38 in-hospital cardiac arrest, only 22 achieved ROSC. Those were not trained on Sanjeevani. So the number of cases where ROSC happened within 20 minute time was considered as sample mean and other cases as outliers. So since the sample size is less and there is no population standard deviation is known till date, so we use T table or percentage comparison. So our outcome is better. We found outcome is better with Sanjeevani and the confidence level is 60 to 70%. So coming to the discussion, despite importance of chest compression in cardiac arrest outcome, they are rarely performed according to guideline recommendation. In various studies of in-house cardiac arrest, chest compression rates were too slow in more than 30% of the time, and 33% of the compression were too shallow, and more than 20% of resuscitation time consists of interruption and no flow time. So this is according to the study mentioned in this blue by Abela, BS and et al. Published in Circulation. And rescuer fatigue contributes to poor quality CPR on long run. So rescuers who provide ventilation and compression should be replaced. This was the recommendation coming after these studies. And audio prompting of chest compression through use of technology as simple as a metronome has been found to improve blood flow during CPR in both animal model and during resuscitation attempt in human, published in Internal Medicine and Academic of Emergency Medicines in 92 and 95. And a meta-analysis by Elson et al. Demonstrate the usefulness of employing high-quality CPR measuring real in-hospital cardiac arrest to evaluate efficiency of training, and this finding was subsequently verified for both in-hospital and out-hospital cardiac arrest in a systematic review by
Not able to hear.
Hello, Dr. Bhandwani. You're not audible.
So
okay.
ROSC is considered, but they are in
There is some technical issues.
inside hospital. Am I audible?
Yeah.
Okay.
Earlier slide you were not audible. So please go to limitation slide.
Okay. Limitations. I am not able to move. Okay. The gadget usefulness is evaluated as a surrogate marker due to regulatory issues. Then the ergonomic component is yet to be evaluated. And here we have considered only the return of spontaneous circulation. But as we know, the reversible 5H and 5T, they affect the outcome too. Those are also to be taken into consideration in the, when the actual device will be used on real patient. Then in-hospital cardiac arrest of cardiac unit is considered, whose data extrapolation may not reflect the actual population. So these are the claims I have made regarding the intellectual property right issue. And
Is it over?
No. I want to show that YouTube video. Yes. That was the electronic component, which has 3 LED and which gives feedback on rate, depth, and adequacy of recoil. So special thanks to the contributors and thank you.
Dr. Ashok, my first question is that what is the indication of calls? Means compression only life support. What is the indication?
Ma'am, that was the indication of COLS is in case of any cardiac arrest, the first responder.
Is it in hospital cardiac arrest or
outside hospital cardiac arrest? Initially,
yes. So you have taken in hospital cardiac arrest cases, huh? In your study, you have taken in hospital cardiac arrest cases? I'm not able to hear. Dr. Lipika, are you able to hear?
Yes, I can hear.
Okay, I'm not able to hear, so I am not able to hear his voice.
1 hour behind the schedule now, so it is spread into the system maybe. So we can just ask questions, he can answer. Maybe he is not able to hear us.
Yeah, my
question. No, he's not connected.
Yeah, he's.
Am I audible? Yeah.
Can we proceed for next?
No, you cannot.
Dr. Ashok, are you audible?
Yes, ma'am.
My question is audible?
Yes, ma'am. Yes.
So what I was saying that calls is mainly for outside bystanders. Yeah.
Yes.
So you have taken the cases from in-hospital cardiac arrest.
In hospital cardiac arrest, we have first initially used it. Subsequently, after that regulatory issues, it will be used on real resuscitation data. Then a sample data from the outside hospital will be used. Because of this, without regulatory.
But the study which you are showing is in hospital.
Yes, in hospital.
But in hospital cardiac arrest, you don't have to intubate and you can just do cardiac compression. Is it ethically?
This is for the quality of chest compression evaluation. Because in normal hands-on, normal
No, but your patients were
hospital
intubated. or
resuscitation,
not
the rate, depth, and recall is not evaluated. Rate, depth, and recall is not evaluated.
Yeah,
So
that is fine.
we want
But
to
was
evaluate
it
that.
being provided by the attendants, the relatives, or by the medical personnel, paramedicals? That is what madam wants to know, I think, no?
Here in this study,
Yes,
in
yes.
this study, it was by the nursing staff, by the junior doctors, and the consultant.
No, but
So my
they are not
question
supposed to be
it
giving
ethically?
calls.
My question is it ethically correct to not intubate and only do calls in hospital cardiac arrest?
No, ma'am. Intubation was there. Intubation was there. The chest compression performance was evaluated. Yes, only chest compression performance was evaluated. And the problem statement for the community is that ambulance cannot reach within 6 minutes. So there has to be something so that there should be quality chest compression.
Yes, that I know. Calls is
For
for
that basis,
hypertension.
for that basis, Department of Science and Technology has allowed this project. It will be kept like a fire safety devices in multiple places. In case of any exigency, the common man will use this instead of their palm, so that there will not be more fatigue and quality of compression will be there.
That we know, but only my concern was it is not ethically.
No, it was a total ACLS protocol was going on.
Only calls in hospital.
No, ma'am.
This
Total
is
ACLS protocol was going on.
But your topic should show that it is only the performance you are checking.
Yes.
It is not like that. In your topic and everything, it was showing the efficacy of calls. Nowhere you have told that patient were intubated and airway maintenance was done.
That was, I have told the limitation in the limitations, the 5H and 5T, which affects the ACLS protocol outcome, it was not considered. Only how the staffs are performing the quality chest compression who were trained on Sanjeevani. That was the...
Dr. Bodmani.
Sir.
Okay, yeah, madam, should we conclude it? Because we have other sessions after this.
Yeah, yeah.
Dr. Lipika, do you have any questions?
Yes,
yes.
Yes, no, I just want to say that all these people who took part in this study, they were all trained
Yes.
by the Sanjeevani, this you mean to say.
Yes.
And as such also the junior doctors, they must be knowing the proper STLS, BLS. So will this be the result of the compression quality?
Yes.
Will be comparable to later on, or it is just a reference to show that this way you can give? That is what you meant, no?
Once the device passes the regulatory issue, we can continue the second phase of the study with the device itself instead of placing the hand.
Okay.
Because that will give the real-time compression data. So our chest compression part is optimized.
Okay. So it can be placed in public places, that way you mean to say?
Yes, ma'am. And then after only government will allow it to keep it like fire safety device in crowded area and other areas, so that ambulance delay will not cause improper or inadequate chest compression.
Yes. A very good attempt. Yeah.
That's why we have, and there is an ecosystem, plan of ecosystem. Yes. So there will be IoT data in this device. Once some incident happen, the nearest ambulance and hospital will be alerted.
Okay. Very good study, very good attempt to include the public in the healthcare, the calls.
Okay.
Thank you. I think we end the session here. Bye-bye.
Okay.
Thank you.
All the
Thank you. Thank you for the judges for a wonderful session.
All the presentations
kindly send your results to me, please, madam.
Yes.
Okay, thank you, judges, and
Thank you, Deba Mahanti, for a wonderful moderation.
Thank you, Rekha. Thank you.
Now I think we will move over to our next free paper presentation. And the moderators, please, are you there?
Yes, ma'am.
Moderators, Chanaki and Arati, are you there? Okay, now we move over to the next session. Our next session is a free paper competition. And we have here our two eminent, well-known people who are judging this session. Dr. Sudesh Kannan, who is the professor of anesthesiology from the Bangalore Medical College and Research Institute. And with him, we have Dr. Sujata Ghosh, associate professor, Institute of Postgraduate Medical Education and Research, Kolkata. Both of them are very experienced teachers, and Sudesh was also the past associate editor of Indian Journal of Anesthesia. Now we can start with our papers. The team is ready. Participants are ready.
Yes, ma'am.
The first speaker is Swati.
Hello, ma'am. Am I audible?
Yes, you are audible.
Okay. A very good afternoon to the honorable judges on the panel. Today I'm going to start my presentation on the paper titled Comparative Study to Evaluate Efficacy of Heparin to Quick Penetrating Solution with Ointment of Heparin in the Prevention of Infusion-Associated Superficial Thrombophlebitis. Thrombophlebitis of intravenous cannulation site is of significant cause of morbidity in hospitalized patient. It can cause pain, inflammation with blockage of infusion site and deep vein thrombosis. Phlebitis is inflammation of the interior wall of the vein, the tunica intima, that affects up to 70% of all patients receiving intravenous therapy. Basic factors leading to phlebitis can be broadly divided into mechanical, chemical, and bacterial. The mechanical factors include the catheter size, material, length, incision site, immobilization, and the dwell time. And the chemical factors includes infusion of the medications or fluids with variable pH or osmolality. Bacterial factors include contaminated IV solution, tubing, catheter, incision site, and lack of asepsis. Grading of infusion phlebitis is done using visual infusion phlebitis scale score. Grade 0 includes IV site appears healthy. Grade 1, any one of the following: slight pain near IV site or slight redness near IV site. Grade 2 is any two of the following, that is pain at the IV site, erythema, or swelling. I have to start my video. Hello, is there any problem?
No, ma'am. Please continue.
No, ma'am, please continue.
Yeah, and grade 3 includes all of the following: pain along path of cannula, erythema, induration. And grade 4 includes all of the following, same as grade 4. In addition, there is only palpable venous cord. And grade 5 is same as grade 4. In addition, there is pyrexia. Studies have shown that topical heparin after IV cannulation prevents or delays infusion-associated phlebitis. We attempted to observe the usefulness of starting application of topical heparin prophylactically prior to IV cannulation, and also the efficacy of heparin solution over heparin ointment. This was an open-label, single-arm, single-center observational study. No literature available now or describing the usefulness of starting application of topical heparin prophylactically prior to IV cannulation. Primary objective: we aim to compare the efficacy of heparin sodium solution with ointment of heparin sodium and benzyl nicotinate to prevent infusion-associated thrombophlebitis when applied on the skin prophylactically before IV cannulation and after cannulation for next 72 hours. Secondary objective: to determine any systemic or local side effects associated with topical application of heparin. Ethical committee approval taken. Consent was taken by the patient or the patient's attendant. Duration of study: 1st October 2022, 28th February 2021. Inclusion criteria: 100 patients of either sex, age 18 to 60 years, admitted in our operating theatre for surgery requiring IV cannulation for more than 72 hours during the study period were included in our study. Exclusion criteria: patients with known hypersensitivity to heparin, coagulation disorder, sepsis, deep vein thrombosis, carcinoma, diabetes mellitus, contraindications to heparin, patient on anticoagulants, and patient not willing to participate in the study. Method of data collection: 100 patients between the age group of 18 to 60 years belonging to ASA status 1 to 3 undergoing surgery requiring intravenous cannula for more than 72 hours were included in the study. The patients were divided into two groups, S and O, of 50 each, randomly using lottery method. In group S, heparin sodium solution was applied, and in group O, ointment of heparin sodium and benzyl nicotinate was applied. Sample size 100. On day 1, patient in OT with good peripheral vein is selected. With thorough aseptic techniques, the prepared area of interest was applied with either 5 to 10 drops of heparin quick penetrating solution or heparin ointment prior to IV cannulation, and it was let to dry for 5 to 10 minutes. Then it was cannulated with 18 gauge cannula on secure. The measurement was made at the same point every time. Every 6 hours, the same site was examined using visual infusion phlebitis scale. Again, either 5 to 10 drops of quick penetrating solution or heparin ointment was applied based on which group the patient belonged to. If thrombophlebitis occurred, the cannula was removed and appropriate treatment was initiated. The statistical software, namely SPSS 22.0 and R environment version 3.22, were used for the analysis of the data on Microsoft Word, and Excel have been used to generate graphs, tables, etc. Descriptive and inferential statistical analysis has been done. P-value less than 0.001 is considered strongly significant. My study population were divided into group S and group O. Majority of them were in the age group of 21 to 30 years, belonging to ASA grade 2, and majority of them were posted for the surgery LSES. And then infusion phlebitis scale scoring on day 1 was a majority of the patients from group S were on grade 0, and from group O were on grade 1. On day 2, majority of the patients from group S were in grade 1, and majority of the patients from group O were in grade 2. And on day 3, majority of the patients from group S were in grade 1, and from group O were from grade 2. This is the same in the tabulation as explained earlier in the graph. Like I'm just stating that 88% from group S belong to grade 0 on day 1, and from group S 84% belong to grade 1, and 54% from group S were lying in grade 1 on day 3. And similarly, in group 0, 62% were in grade 1 on day 1, and 58% were in grade 2 on day 2, and 58% in grade 2 on day 3. Local symptoms and side effects were none. Intravenous cannulation to administer drugs, fluids, blood products, and nutritional solutions is a significant part of hospital-based management. The use of IV cannula is often associated with the development of superficial thrombophlebitis. Topical application of heparin at the site of cannulation is frequently done to prevent thrombophlebitis. The present study assessed the safety and efficacy of prophylactic use of topical heparin in preventing infusion-associated thrombophlebitis when applied over the skin prior to IV cannulation and reapplying the same thrice daily for 72 hours post cannulation. The use of topical heparin solution was far more superior than heparin ointment. The prophylactic use prior to IV cannulation did have a significant impact in preventing the progression of infusion-associated thrombophlebitis. Prophylaxis and therapy with topical heparin solution is much superior to heparin ointment for reducing the incidence of thrombophlebitis associated with infusion. The prophylactic use of topical heparin prior to IV cannulation does have an impact in preventing and delaying the onset and progression of infusion-associated thrombophlebitis. We recommend the use of topical quick penetrating solution prior to IV cannulation over topical heparin ointment. Thank you.
Over to the judges for the questionnaire. Over to the judges for any questions to Dr. Swati.
Sujata ma'am, would you like to ask some questions, ma'am?
You may start. Dr. Shadish, you may start.
Oh, thank you so much, ma'am. Yes, doctor, your presentation was a good presentation, and it was a relatively new topic as well. A simple topic, and but good one. Doctor, there are few things which, how did you manage to avoid the confounding factors? That is, see, you told that so many factors which can influence thrombophlebitis, that is the use of IV fluids, drugs and all. So how did you ensure that both the groups received the similar type of drugs and infusion fluids? Because that can definitely influence the outcome.
I didn't get your question, sir. Like,
See, I just wanted to know if you ensured that the patients in both groups received similar kinds of drugs and similar time of
no,
fluids and all.
no, sir, no, no.
So then obviously your results will be distorted because of, see, in some group you might have used drugs which are causing more thrombophlebitis than in the other group which you have used. I mean, in other group you would have used a drug which caused less thrombophlebitis. Let's say, for example, certain antibiotics have got a more tendency to cause thrombophlebitis when compared to certain things. Likewise, use of chemotherapeutics in some group and non-use of normal drugs in some other group can distort your results. So therefore, the confounding factors were not matched. I think that's what is one observation. Second thing, were the patients in OT or ICU?
OT, sir, OT, and I followed them in the wards.
All received what kind of anesthesia? General anesthesia or spinal?
Spinal, sir, spinal.
All the patients received spinal anesthesia.
Spinal, yes, sir.
Okay.
Majority of my patients were like gynae patients, since the study was during a very short period of time. So I could only on a very small sample size I had used, sir, and most of them were undergoing LSCS. So like all of them were female patients. So comparatively, like I don't think there will be major difference in like the drugs administered in the post-op care for these patients, sir.
Fine, ma'am. You can go ahead, ma'am.
Thank you. Nice paper, nice presentation. I would like to know, why did you give it prior? Because in all cases, there may not be any thrombophlebitis at all. So don't you think that might affect?
It can, ma'am, it can definitely affect, but I wanted to, like, majority of the previous studies which have been done are like after IV cannulation, they have like started administering whatever the drugs they are administering. I wanted to see if I use it prophylactically prior to IV cannulation, will there be an impact in preventing the like progression of the thrombophlebitis, ma'am? And I have seen that it definitely is has an impact in reducing the progression of superficial thrombophlebitis, ma'am. I just wanted to see if it has any impact on it.
Percentage of patients was there who did not have thrombophlebitis from your sample size?
Just a minute. Around on day one, who received quick penetrating heparin solution, 88% were on grade 0, ma'am. No thrombophlebitis were there. But on day 2 and day 3, almost 84% and 54% of the patients were in grade 1 and grade both on grade 1 on day 1 and day 2 and day 3 who were receiving quick penetrating solution, ma'am. But who received heparin ointment on day 1, they were in grade 1, ma'am, and on 58% were in grade 2 on day 2, and 58% were in grade 2 on day 3, ma'am, in people who used ointment.
So in spite of giving it prior, do you think there was a significant effect of you giving prior to the surgery?
Yes, ma'am.
Because in day 2 and day 3, in day 2, a huge lot of patients had thrombophlebitis. Anyway, thank you so much. Nice answering. Good.
Yes, thank you, ma'am. Thank you.
Thank you, sir and ma'am. Next participant is Dr. Arun Dev. Please share your screen. Dr. Arun Dev, are you here?
Yes, ma'am. Sure.
Then there is share screen option on the display, green color button.
Dr. Dev, below your screen there is a share screen option. Click on that, and
there is a green button.
can you read my? Hello.
Your voice is not clear, Arun.
Hello.
Yes, yes.
Hello. Now, are you able to see, sir? Now?
No, there is a. Firstly, open your PPT. Firstly, open your PPT. Then there is a share screen option. Arun, are you able to do?
Yes, yes. Hello. So, am I audible?
You are audible.
Hello, sir. Hello.
Dr. Arun, if you are
Hello, sir.
not able to do, we can go to the next candidate, and you will be ready after some time.
Sir.
When you are ready, just call us.
Sir, can I? No, sir.
Next participant is Priti Priyadarshini R. Are you ready?
Yes, ma'am.
Can we proceed? Because we are already 1.5 hours late.
Yeah, ma'am.
Jadaman, can we proceed?
Hello.
Sir, can you proceed, sir?
Yeah. Please proceed.
Hello. Arun Deva.
Hello. Hello. This is Preeti. Can I start?
Dr. Preeti can start, I think. Arun Dev can present next, I think, because already she has started doing speech sharing.
Okay, sir.
Hello. Sir.
Good afternoon, everyone. I'm Dr. Preeti Priyadarshini, second year postgraduate from Vinayaka Mission Medical College. My topic for poster presentation is anesthesia consideration in rise abdominal pressure. A rise abdominal pressure associated with increased risk of perioperative mortality and morbidity. Increased abdominal pressure leads to vascular compromise and ischemia. Intra-abdominal pressure mainly depends upon volume of intra-abdominal content, which includes visceral volume, tumor, and pathological fluid. Normal intra-abdominal pressure is 5 to 7 millimeter of mercury. Sustained rise in abdominal pressure more than 12 millimeter of mercury is known as abdominal hypertension, and pressure above 25 millimeter of mercury is known as abdominal compartment syndrome. Multi-organ failure occurs if more than 25 millimeter of mercury of abdominal pressure, and death occurs if we fail to intervene. Pathophysiology of increased abdominal pressure in cardiovascular system, venous system compromise occurs, which reduce preload, arterial compression, which reduce arterial compliance and increase afterload. Both this component reduce cardiac output and abdominal perfusion pressure. In respiratory system, it leads to basal collapse and atelectasis, increased BQ mismatch, decreased pulmonary and chest wall compliance. Elevated diaphragm, which also increase pleural pressure and intrathoracic pressure. In renal system, reduced renal blood flow, which leads to renal dysfunction. Intra-abdominal pressure, which increase above normal proximal tubular pressure, that is 15 to 18 millimeter of mercury, which leads to increase in resistance to filtration and decrease urine output. In central nervous system, elevated intracranial pressure due to venous compromise because of intrathoracic pressure elevation. Associated hypercarbia, which leads to cerebral vasodilatation, which leads to additive effect. Intra-abdominal hypertension found to be an independent risk factor for secondary brain injury in brain-injured patient. In gastrointestinal system, decreased gut perfusion and increased venous obstruction leads to bowel wall edema and bowel ischemia, which leads to loss of cellular integrity and translocation of bacteria into systemic circulation, which result in sepsis. Decreased hepatic blood flow leads to liver dysfunction and failure and it also leads to failure of clotting factor and protein synthesis, which increase susceptibility of infection and encephalopathy. Anesthesia consideration Anesthesia consideration in raised abdominal pressure. A rapid sequence induction is recommended. Awake intubation preferred in case of anticipated difficult intubation. Dose reduction should be considered. Compressive atelectasis, which occurs due to ascites. Vasodilatory agent, which potentiate hypotension. Muscle relaxant or increase because of fluid retention and increased volume. And duration of action of muscle relaxant, which are metabolized by the liver, which are prolonged. Example, pecoronium. And patients which are more sensitive to cardiodepressant effect of induction agent in liver dysfunction and altered volume of distribution and hypovolemia. As abdomen is open, the intra-abdominal pressure which reduce immediately, which consequently increase thoracic pressure, which consequently decrease thoracic pressure and improve respiratory compliance, which leads to barotrauma and volitrauma due to overinflation. Sudden decrease in systemic vascular resistance while opening abdomen, which leads to sudden cardiac arrest. So fluid loading, vasopressors are required. Resuscitation drug and equipment should be kept close to the hand. Reperfusion injury may lead to myocardial depression, arrhythmia, and cardiac arrest. Goal-directed fluid therapy is recommended in these patients. Intra-abdominal pressure, which are measured by various methods, it includes direct and indirect method. Direct method involve placement of transducer intraperitoneal and measurement of pressure. Indirect include various methods using ventilator airway pressure, ventilatory pressure, and intravesical pressure measurement, intrauterine, intrarectal. Intravesical pressure measurement is a gold standard in indirect method. And in case of abdominal compartment syndrome, open abdomen is usually considered, which leads to soft tissue injury. Open abdomen dressings are available to prevent soft tissue injury like fat and apthera, etc. A picture shown here is a apthera dressing. Thank you.
Yes, doctor. Ma'am, you want to ask any questions, Sujata ma'am? Sujata ma'am?
What is the novelty of your paper? You have described the causes, you have described the anesthetic considerations, but what message have you tried to convey?
We have to monitor intra-abdominal pressure in case of tense abdomen, and we have to intervene before it progress to abdominal compartment syndrome.
Actually, what new are you trying to convey to us? What new ideas or what new technique? Anything you're trying to convey to us? It's all right. Dr. Shudhish. It's a good presentation.
Okay.
Very nicely said.
Dr. Preeti, why did you select this particular topic regarding raised abdominal pressure? What is the problem? Like, how often do you come across this condition?
In recent days, there are a lot of emergency cases are coming presented with the DCLD, recurrent ascites, refractory ascites.
Okay.
In one of the case, they just closed because of a draining ascitic fluid. Usually shunt procedures are done in DCLD, but they had closed since it's draining continuously. In that case, we thought of open abdomen dressing, what is the importance of intra-abdominal pressure. So we plan to just describe about that. Initially, when intra-abdominal pressure rise, medical management is the first thing surgeons used to do. And next, last stage, they come for a surgery. Thus, we want to describe what are the anesthesia implications.
Do you routinely practice measurement of intra-abdominal pressure? If so, how do you do that?
We are not routinely doing so. Since in that case they planned for suture closure, so we thought of open abdomen dressing and pressure in. We were talking about that, so just giving to that.
To your kind information, actually, if you see many of the surgical emergencies that land up in our surgical OT, emergency OT, such as intestinal obstruction, then perforations, intestinal perforation or ileal perforation or gastric perforation. Many times, if they are not treated, they land up in intra-abdominal hypertension. What is the problem with intra-abdominal hypertension?
It leads to ischemia and vascular compromise, leads to multi-organ failure.
Okay.
Finally, patient will land up in sepsis and increased mortality were reported.
Okay, right.
Thank you, sir.
Right.
Thank you, ma'am.
We invite our next speaker, Dr. Vidyapati Pradhan.
Put it on slideshow. Hello.
Start, Dr. Vidyapati. We start.
You stop sharing your PPT. Yes. Okay. Arundev?
Who is going to present? Arundev or Vidyapati?
Hello. Hello, ma'am. Arun, ma'am.
So you're going to present before Vidyapati, I believe.
Yes, ma'am. Actually, I was the candidate before due to some net connection issue. It was cancelled, ma'am.
All right. Please go ahead.
Okay, proceed.
Good afternoon, judges. I am Dr. Arundev from Department of Anesthesia, Vinayaga Mission Medical College and Hospital, Karakal. My paper topic is comparison of hemodynamic changes following anesthesia induction and procedural LMA insertion with propofol versus ethomidate, a prospective randomized double-blinded study. Aim of the study is to evaluate the hemodynamic changes in patients who are induced with propofol, ethomidate, and to assess the ease of insertion of procedural laryngeal mask airway. Introduction. LMA is a simple supralaryngeal device which is used to establish and maintain airway. Despite the common use of LMA, there are no optimal methods of induction of anesthesia that can guarantee a proper insertion. The purpose of this study is to compare methods of induction of anesthesia with propofol versus ethomidate in hemodynamic stability after LMA insertion in elective surgeries. Materials and methods. It's a double-blind randomized clinical trial, 80 patients aged between 18 to 70 years, ASA class 1 and 2, scheduled to undergo elective surgeries, were studied in 2 equal groups. The study was conducted in Department of Anesthesia, Vinayaga Mission Medical College, Karakal, after obtaining ethical committee approval. Patients were randomly divided into 2 groups. Inclusion criteria, patients with ASA class 1 or 2. Exclusion criteria, existence of a considerable pathology in the larynx or pharynx, mouth opening less than 2.5 centimeter, patient with bronchial asthma, cardiovascular diseases, Mallampati score 3 to 5. Prior anesthesia induction, all patients received 6 ml per kg of normal saline, 0.9%. Patients received fentanyl 2 mics per kg IV, midazolam 0.025 mg per kg IV, and lignocaine 1 mg per kilogram IV. Later Group P received propofol 2.5 mg per kg IV. Group E received ethomidate 0.3 mg per kg IV. Prior to induction and 30 seconds after induction, hemodynamic variables were recorded. Later, 60 seconds after loss of consciousness, which was confirmed by inability to reply to verbal commands and loss of eyelash reflex, LMA was inserted. Proper placement of LMA was approved by chest expansion and capnography. Following successful LMA insertion, anesthesia was maintained by isoflurane, MAC of 1 to 1.5 and an equal mixture of oxygen and nitrous oxide. In two groups, blood pressure, heart rate values were recorded. The obtained data were compared and presented as mean plus or minus standard deviation, frequency and percentage. Categorical variables were evaluated using contingency tables and chi-square or Fisher exact test. To compare the quantitative variables, repeated measures analysis was also done. Observation. Induction of anesthesia with etomidate 0.3 mg per kg provided more hemodynamic stability than propofol 2 mg per kg in patients receiving GA for short surgeries. Changes in heart rate were comparable in both the groups, but fall in mean arterial pressure was significantly high in propofol group. Ease of insertion of proxial laryngeal mask airway was better in propofol group, which was also associated with fewer adverse events when compared to etomidate group. This is the hemodynamic variables obtained. In both the groups, mean plus or minus standard deviation of baseline and post-LMA insertion heart rate values were calculated. They are expressed as beats per minute. In group P, baseline and post-LMA insertion values were 91.02 and 85.87 compared to 88.92 and 88.42 in group P respectively. P value obtained using unpaired student t-test, it was found to be statistically not significant. Mean arterial pressure, they are expressed as millimeter mercury, and p-value was obtained using unpaired student t-test. In group P, baseline and post-LMA insertion values were 94.55 and 79.17, while it was 90.95 and 88.25 respectively in group E. P-value was found to be statistically highly significant in group P, but it was not significant in etomidate group, which is the most important finding of the study. Comparison of this is a graph obtained for a mean arterial pressure and the ease of insertion of LMA. Distribution of study groups according to ease of insertion of proxial is shown in table 8. In group P, insertion of LMA was excellent in 34 patients, satisfactory in 6 patients, whereas in group E, it was 26 and 14 respectively. The data was compared and p-value calculated using chi-square test was found to be statistically significant. Result, induction of anesthesia with etomidate provided more hemodynamic stability than propofol. Ease of insertion of proxial laryngeal air mask was better in propofol. Thank you.
Hello.
Yes, sir.
Dr. Arun, what made you do this study? Like, what's the specialty of this study?
Sir, in short surgeries and all, instead of going for a ET tube insertion, we can easily use with the.
Okay, but no, see, it's not about LMA. It's about comparison of hemodynamics between two groups, isn't it? You are getting confused between LMA insertion versus hemodynamics, because in the title you say that it is a comparison of hemodynamics, but when it comes to the aims and objectives, you are talking about ease of insertion. So, I mean, that is actually
sir, ease of insertion was my secondary objective, sir.
But what is
primary objective was hemodynamic stability, and secondary objective was ease of insertion of LMA.
Okay, what was the primary outcome measure what you used? How did you calculate the sample size?
Patients were randomly divided, sir.
Sample
all
size.
electives.
I'm talking about
80 total sample size of 80 was taken, sir.
How did you arrive at that number? What parameters did you observe?
Sir,
or what parameters you took?
the patient with ASA 1 and 2 were selected, and age between 18 to 70. That was my inclusion criteria, sir. A patient without having any cardiac issues, mouth opening, adequate mouth opening. This type of patients were selected for the study.
There are serious limitations of your study. Age is 70 years. I mean, from 18 to 70 years is a broad age group, and you know that after 50 years, the patient's general condition itself is so confusing that they can have a profound influence on the outcome measures. Like their vascular reactivity, everything is altered, so they can have different kind of response to drugs. So your results cannot be really actually extrapolated that way. I mean, you are not. It cannot be. What do you say? Comparable. Whether there was uniformly distributed or what, we have to check. Okay, ma'am, you can go ahead.
Yes, I would like to know what are the limitations of etomidate? Using etomidate as a routine drug, do we really do it? What are the limitations? What are the problems with etomidate? Or complications or side effects of etomidate? Okay. Thank you so much, Dr. Arun.
Thank you.
Next participant is Vidyapati Pradhan. Vidyapati. Vidyapati Pradhan, are you ready? Please share your screen. Are you present, Vidyapati Pradhan?
ଗପି ଚାଲିଲାନି ସେଥିପାଇଁ ସେ ଟିକେ ଚିଡି ଗଲା ବୁଝିଲା ତାକୁ କିଛି ଅପରଚ୍ୟୁନିଟି ମିଳିଲା କିଛି ବ୍ୟସ୍ତ ନା କିଛି ବ୍ୟସ୍ତ ନା ସଲ୍ଭ ହେଇଗଲା
Good afternoon, ma'am.
Can you please share your screen?
Yes.
Vidyapati Pradhan, can you please share your screen?
Ma'am, how to share my screen? I'm not getting the share screen. Awesome.
Just open your PPT.
Yes, sir. I opened the PPT.
see the green
Then
there is a green
share screen
the bottom
button.
share screen go to that
In the middle,
Yes,
there is a screen share button. Just go there.
Yes, ma'am.
Just go there.
But it is coming at Microsoft OneDrive, Google Drive, Box, Photo, Document, Web URL.
see listen
Yes,
you
I got
leave
it, ma'am.
you leave to the other okay
Okay, just open PPT. Yes, play.
Okay.
Yes, please start, sir.
Thank you. Good afternoon, my respected teachers. Today, my topic of presentation is comparative study of epidural versus combined spiral epidural anesthesia. Background: general anesthesia dominated during the 19th century, but the drawbacks were cost, morbidity, and mortality. Now, most of the lower abdomen and lower limb surgeries are performed under neuroaxial anesthesia, such as subarachnoid block, epidural anesthesia, or combination of both. Disadvantage of spinal anesthesia is precipitous hypotension, single shot nature, difficulty in controlling the level, and disadvantage of epidural anesthesia is missed segment, incomplete motor block, and systemic toxicity and slower onset of action. These led to the development of combined spinal epidural anesthesia, which involve subarachnoid blockade and epidural catheter placement during the same procedure, supposed to combine the best feature of spinal and epidural blockade, avoiding their respective disadvantages. Aim of the study was to compare between combined spinal epidural anesthesia and epidural anesthesia alone in terms of onset, duration, efficacy, surgical analgesia, muscle relaxation, and hemodynamic response. Methodology: after institutional ethical approval and written informed consent, this quasi-experimental study parallel design was conducted between November 2018 to October 2020 in the Department of Anesthesiology, Binsar Bhulla. Total of 60% who underwent lower abdominal and lower limb surgery of duration less than 4 hours in Department of Surgery, Gynecology, Orthopedic were divided into Group C and Group B with 30% each. Inclusion criteria: ASA grade 1 and 2, age 20 to 60 years of both sexes, surgery up to 4 hours. Exclusion criteria: infection at the site of injection, spinal abnormality, neurological disorder, and coagulation disorder. After proper aseptic measure, epidural catheter was placed by loss of resistance technique after test dose of 3 ml of lignocaine 2% and adrenaline 1:2 lakh. Then Group B received epidural anesthesia with 15 ml of 0.5% bupivacaine injected into the epidural space via the epidural catheter, while Group C received combined spinal epidural anesthesia with 2 ml of 0.5% bupivacaine heavy injected intrathecally by 25 gauge coinque needle in a separate space, and the patient was immediately made supine. Then, after the highest level of sensory block is achieved, 1.5 to 2 ml of bupivacaine 0.5% for every unblocked segment was injected till the desired block height was achieved. Demographic and anthropometric variables are recorded: age in year, sex as male and female, height in centimeter, and weight in kilogram. Onset in minutes from completion of anesthesia procedure till the loss of sensation to pin prick on maximum block height. Duration of analgesia: onset of analgesia till 2 segment regression time. Then quality of surgical anesthesia: excellent for no supplementary drug required, good for one analgesic required, fair for more than one analgesic required, and poor for general anesthesia required. Degree of motor blockade was assessed by modified Gomez scale: 0 for no paralysis, 1 for inability to raise the extended knee, 2 for inability to flex the knee, and 3 for inability to flex the ankle joint. Then initial loading dose of the drug required to achieve the initial maximum block height was calculated, recorded, and maintenance dose required from 2 points regression till the completion of surgery given by the epidural catheter was also recorded. Then the addition of two doses gives the total dose. Total drugs required to complete the surgery was also recorded. Hemodynamic parameter, pulse rate, mean arterial pressure, and arterial oxygen saturation was recorded. That was collected in preform data sheet, recorded in Microsoft Excel, and analyzed in SPSS version 23 using independent t-test for qualitative, quantitative, and chi-square test for nominal data wherever applicable. P-value less than 0.05 was taken statistically significant. The observation was both the group contained 30 patients with male and female sex ratio similar in both the groups. Age, height, weight, and duration of surgery were also similar in both the groups. Then the loading dose required to achieve the maximum block height in group C was 35 milligram as compared to 94 milligram in group E, means only epidural group. Then maintenance drug required to complete the surgery in group C each was more than group E, that is 75 milligram in group C and 48 milligram in group E. But when he come to the total amount of drug, in group C combined spinal, the amount of drug was 110 milligram, while in group E it was 142 milligram. The sensory onset time in group C was very early, 8.9 minutes, while group E it was 20.9 minutes. Duration duration of analgesia was 79 minutes in group C and 108 minutes in group E. The duration may be longer due to higher drug dose in group E. Excellent quality of analgesia was observed in 17% of group C out of 30, while only 5% out of 30 in group E. Motor blockade of modified Gomez 3 was observed in all the 30% of group C, while only 60% of group E. Fall in pulse rate and fall in BP was similar in both the groups. This is the chart. And in conclusion, in CSE there was faster onset of action, superior quality of analgesia, better motor blockade, and less dose of local anesthetic required to reach the same sensory level. The hemodynamic response was similar in both the groups. The total amount of bupivacaine required to complete the surgery with same duration was lesser in CSE. Thank you.
Hello.
Yes, sir.
How did you achieve the sample size of 30 in your study?
Sir, according to the I took I calculated the sample size by taking the previous studies, sir.
No, that's what parameter.
Sample size estimation by formula.
Yeah, that's what
sir,
parameter.
I took sir, here I took the parameter quality of surgical anesthesia and onset time.
How did you
for quality of surgical?
Yeah, in your methodology.
Sir, for quality of surgical anesthesia, and there was 29 sample size, and for quality time of onset it was 17. So I took 30%, sir.
Okay, fine. But how did you see? Now the thing is, it's an open label study. Like one patient receiving combined spinal epidural and one patient receiving spinal. Obviously, there is always a possibility of bias being introduced because the person, I mean, the person who assesses the patient will obviously know that this patient has received spinal. So invariably, you will know that this patient will have better muscle blockade.
Yes,
better.
Sir. To eliminate that bias, sir, I went through the random number integer from a table, and according to that, we randomly selected the patients.
No, that is for the sake of randomization. But how did you evaluation bias? How did you omit, or how did you avoid the assessment bias? Parameters like assessment of parameter bias. How did you, yeah.
Sir, assessment of parameter is done by separate observer, and recording was done by separate. Recording was done by me. So it was Sir, the drugs were injected by, and the procedure is done by some other person, and observation are done by other person, and I compiled only the data, sir.
Okay, fine. Ma'am, you can take one. Ma'am, unmute yourself. Ma'am, you unmute yourself. You're still mute, yeah.
Sorry.
No problem.
How did you take up this? It is still unmute.
No, ma'am. No.
Am I
Now you're-
audible?
Yeah, yes, ma'am.
Yes, ma'am. Now you are audible, ma'am.
Thank you. And how
Thank
did
you,
you
ma'am.
choose this topic? Because the two kinds of procedures are different, surgeries are different, but what made you compare these two? Why did you take up this topic? Comparing epidural with CAC. Because the cases where you give CAC are not the cases where you give epidural. Vidyapati are you there?
Where is the speaker? The judge is asking question. Where is the speaker? Where is Vidyapati Pradhan? I think Vidyapati Pradhan is the speaker.
He is visible.
Madam, then I think we should proceed. Otherwise, we are losing our time.
Yes.
Okay.
Okay, ma'am. Our next speaker is Dr. Issa Banerjee. Dr. Issa, are you ready?
Yes, ma'am.
Kindly share your screen.
Yes, ma'am. Ma'am, is it visible?
Please make it full screen.
Yes, ma'am. Ma'am, is it visible?
Yes.
Good afternoon, ma'am. Good afternoon, sir. I am Dr. Isha Banerjee from IMS and Some Hospital, presenting before you the anesthetic considerations in pregnant women with antiphospholipid antibody syndrome posted for elective cesarean section, a case series. Introduction. Antiphospholipid antibody syndrome is an acquired autoimmune hypercoagulable disorder caused by the presence of antiphospholipid antibodies. It is characterized by thrombotic episodes in arteries, veins, and many pregnancy-related complications. The focus of management remains adequate anticoagulation and prevention of thrombosis and its associated complications. Here, we report a case series conducted on 3 cases of primary Aplar syndrome in pregnancy in our institute, and we are reporting this because of its rarity and complexity of management in such cases. Methodology. The choice of anesthesia for pregnant ladies with Aplar syndrome remains at the discretion of the anesthesiologist and the coagulation profile. All 3 participants were planned for neuraxial technique, considering their normal coagulation profile and platelet counts. They were all given single-shot atraumatic spinal anesthesia with 25 gauge Quincke's needle, achieving a level of sensory blockade up to T6. Their perioperative course remained uneventful. Here is a tabular format of the 3 patients that we encountered, their age group being 32, 30, and 28. The period of gestation for the current pregnancy was above 37 weeks, and all the 3 patients had a minimum of 2 previous pregnancy losses. The 3rd patient had a BMI of 40.1 kg per meter square and hence was morbidly obese. The patient 1 had type 2 diabetes mellitus for the last 2 years and who was being treated with insulin for the last 1 year, and her blood sugar profile was within normal limits. However, none of the patients gave any history of any thromboembolic events in the recent past. Their hemoglobin levels were more than 10, The platelet count did not show any thrombocytopenia, and APLA antibody levels were more than 12 unit per ml, which is according to our institute guidelines of the cutoff value. The PTINR and APTT values were also within the acceptable ranges. All three patients were being given antiplatelet of aspirin 75 mg, which was stopped 5 days prior to being posted for elective cesarean section. Patient 1 and patient 3 were receiving enoxaparin 60 mg subcutaneously, and which were stopped 12 hours prior to being posted, and patient 2 was receiving nadroparin 3 ml, which contained each ml containing 95,000 units of nadroparin, which was stopped 24 hours prior to the surgery. They were given a single attempt of spinal anesthesia with a 25 gauge Pinky's needle at L3, L4 intervertebral space of 2.2 ml of 0.5% heavy bupivacaine, achieving a sensory blockage of T6. The intraoperative course remained uneventful, with a total maximum blood loss having been 800 ml. The postoperative course for all the three patients also remained uneventful. Discussion. Antiphospholipid antibody syndrome is an autoimmune disorder with variable symptomatology. The obstetric complications are hallmark of antiphospholipid syndrome, where recurrent miscarriages, early delivery, oligohydramnios, prematurity, intrauterine growth restriction, fetal distress, fetal and neonatal thrombosis, preeclampsia or eclampsia, HELLP syndrome, arterial or venous thrombosis, and placental insufficiency are the most severe APS-related complications in a pregnant woman. Obstetric care is based on a combined medical obstetric, high-risk management, and the associated complications and management of associated complications between aspirin and heparin. The presence of high levels of anticardiolipin antibodies are strongly associated with an increased risk of thrombosis. The choice of anesthesia is the decision of the anesthesiologist, depending on the coagulation profile, and whether to proceed with neuraxial block or general anesthesia remains a challenging decision to make. Most of the prior studies preferred the use of general anesthesia, considering the risks associated with bleeding in such anticoagulated patients with potential thrombocytopenia over the use of neuraxial techniques. However, we proceeded with single-shot atraumatic spinal anesthesia using a 25-gauge Pinky's needle in all our patients because all were having no abnormality in their coagulation profile with a normal platelet count. The intraoperative course for all patients remained uneventful, averaging the blood loss of around 800 ml for all three cases, and postoperatively, the patient did not show any signs of excessive bleeding or thrombotic episodes in the post-op period. The choice of general anesthesia was kept at bay, considering the risks associated with handling of the airway in obstetric population. So, to conclude, antiphospholipid antibody syndrome requires a multidisciplinary approach during pregnancy. Discontinuation of anticoagulants is a double-edged sword, requiring adequate deliberation on the part of the anesthetic
Hello.
I think you have to inform them that he is not audible, Sudesh.
Yes, ma'am.
Yes, please tell them, otherwise they are just going on. And the time is also running.
Yeah. I was trying to communicate to them, but they are not able to listen, I think.
Is she visible?
Lot of internet issues.
Ma'am, you can proceed, ma'am. Sujata, ma'am, you have any questions? Hello.
Can we proceed?
Sujata, ma'am, any questions? Any questions from your side?
You can go ahead.
Yeah.
I can't see her.
Yeah, I know. Even I'm not able to see her.
Yes, that's why I'm hesitating.
No, is it
So
a new paper or a continuation?
No, new paper. Dr. Isha, can you hear
I
us?
think we can go over to the next person.
Yeah.
No, she's visible now.
Yeah.
Dr. Isha is visible now. I think we can continue.
Please unmute Dr. Isha. You were not able to hear the last part of your slides. Anyways,
Okay, sir.
why are you? Hello, ma'am.
Hello.
Got the general idea, so we can continue with the questions now.
Yeah.
Okay.
There is only one question from my side. Like, why did you think about spinal in this case? I mean, what is the problem anticipated with regards to spinal in earlier studies?
Sir, in earlier studies, we had seen they have preferred the use of general anesthesia. Even as we know that in obstetric population with airway edema, there is present and there is friability.
The question is very simple. What made you think about, I mean, with the previous articles, when they used general anesthesia, they would have had some sort of explanation for that or some sort of substantiation for that. So what was your opinion regarding that?
Sir, we considered spinal anesthesia because there was no particular contraindication to giving spinal anesthesia, sir. The coagulation profile did not show any abnormalities. The platelet count did not show any abnormalities. They did not have any previous history of thromboembolic events. So we preferred the use of spinal anesthesia as we did not want to handle the airway in such obstetric patients. On top of that, we had the third patient who was morbidly obese, which would make our airway handling a bit more difficult a choice.
Okay. Okay. Fine. Ma'am, you can go ahead. Because of paucity of time.
Please tell me. Yes. We have, tell me about two important phospholipid syndromes and how will you tackle it? You have not tackled it, but how do you tackle the most important one? Just tell me about the most important.
Ma'am, your question got cut a bit. Can you please repeat, ma'am?
Okay. What is the most important consideration and how do you tackle it?
Ma'am, the most important anesthetic consideration in such patient will be the thromboembolic event which can occur. Intraoperatively, the bleeding incidence and postoperatively, the thromboembolic event. If we give anesthesia, the postoperatively, the ambulation is Ma'am, immediately post-op, after 6 hours, subcutaneous heparin, low molecular weight heparin is started off along with aspirin. And early ambulation is being given to, is advised for such patients so that any event of thromboembolism can be ruled out. And ma'am, intraoperatively bleeding chances are there, which can be tackled with intraoperative coagulation, like we can give tranix. Yes, ma'am, we can give tranexamic acid for such patients.
Only tranexamic acid will do or anything else?
No, ma'am, we can use vitamin K and we can use platelet concentrates.
Okay, thank you.
Yes, ma'am.
Thank you, Isha.
Thank
Nice
you, ma'am. Thank you, ma'am.
Our next speaker is Dr. Priyanshu Kaushik. Dr. Priyanshu Kaushik.
Hello, ma'am. Hello.
Yes, you are audible, Priyanshu.
Yes, please start.
One second. Good afternoon, everyone. My name is Priyanshu Kaushik, and I am from IMS and Sam Hospital, Bhubaneswar. Today, I am going to discuss about a comparative study of effect of chordal dexmedetomidine versus morphine added to ropivacaine in a pediatric infraumbilical surgery. One of the most commonly used regional anesthetic technique in pediatric surgery is the chordal block. Due to its short duration of action, different additives have been used to prolong its effect. The objective is to compare the duration of post-operative analgesia of caudal dexmedetomidine versus morphine in combination with ropivacaine in pediatric patients undergoing infra-umbilical surgeries. Okay, my next slide is not coming. Okay. Hypothesis. So previous studies have proven the efficacy of both caudal morphine and dexmedetomidine, a new alpha-2 agonist, in prolonging the duration of post-op analgesia individually. In this study, we hypothesized that both these drugs are comparable in efficacy when given in a single dose caudal analgesia in pediatric patients. Methodology: a total of 40 pediatric patients of age 1 to 5 years of both sex, ASA 1 and 2, scheduled for infra-umbilical surgeries were enrolled into equal groups. Group A, who received dexmedetomidine at the dose of 1 mg per kg with ropivacaine, whereas Group B received morphine in a dose of 10 mg per kg with ropivacaine. Randomization is done by computer-generated random numbers which were enclosed in envelopes. The inclusion criteria were the age of 1 to 5, both sex, ASC 1 and 2, and surgical procedure included on the infra-umbilical surgeries. Exclusion criteria included history of any mental retardation or delayed developmental milestone which may interfere with the pain intensity assessment, known or suspected case of coagulopathy, any congenital anomaly in the sacrum, any infection at the injection site, and known or suspected allergy to any of the studied drugs. Pain score was assessed by pediatric observation 10-point scale, the FLEX pain score, that is the face, leg, activity, cry, and consolidity. And the duration of post-operative analgesia was defined by the time elapsed between the drug injection in caudal space and FLEX score equal to or more than 4. The assessment is done immediately post-operatively, that is the 0 hour, the second, the 4 hours, 6, 8, 12, and 24 hours. Data analysis done by the SPSS 19.0. The p-value here of less than 0.5 is considered statistically significant. Sample size, we have calculated the sample size because as per previous study where the power of the study was 80%. Patient characteristics and duration of analgesia were compared using unpaired t-test. Here is a demographic table of both the groups comparing age, gender, body weight, duration of surgery, and we can see there's no statistically different data. The surgery of the types of surgery which we included are herniatomy, orchidopexy, circumcision, urethroplasty, and open appendicectomy. In the graph, we can see it's a comparison between perioperative and postoperative, the mean heart rate and the mean arterial blood pressure. And in the preoperative, we can see the heart rate is around 100, whereas it is slightly decreased in the postoperative period in both the groups. Incidence of complication in the PACO after recovering revealed that 5% of the patient in both group has post-op nausea vomiting, whereas 10 and 5% develop hypotension and bradycardia in group A, whereas there is no such effect in group B. There is incidence of 5% patient developing itching in group B, but there is no statistically significant difference in patient with respiratory depression in both the group. The duration of analgesia as indicated by FLEX score was found significantly longer in group B as compared to group A, which was statistically significant. Discussion. The caudal epidural analgesia is a widely used technique providing regional anesthesia in children undergoing infra-umbilical and lower limb surgeries. To prolong its duration of analgesia, numerous additives are under study. Dexmedetomidine, a highly selective alpha-2 agonist, has been found to be efficacious in prolonging the duration of analgesia when given in epidural space as compared to most of the traditional additives. Among opioids, morphine has been proven to effectively prolong the duration of caudal analgesia. In our study, the use of 1 mg per kg body weight of dexmedetomidine did not prolong the duration of caudal analgesia as significantly as morphine in the dose of 10 mg per kg, contrasting similar study in Hassam et al., which might be due to higher dose of dexmedetomidine, that is 2 mg per kg, which they have used in their study. The result of our study supported Vetar et al., who compared single dose of morphine 25 mg per kg, clonidine 2 mg per kg, and hydromorphone 10 mg per kg with ropivacaine, and Chartin et al., who compared the use of fentanyl 2 mg per kg and morphine 15 to 20 mg per kg, that morphine provided a longer duration of analgesia and sedation. Conclusion. Result of this study showed that that the addition of morphine to ropivacaine for a single dose caudal analgesia produced longer postoperative analgesia with lesser side effect and better hemodynamic stability in children undergoing lower abdominal surgery as compared to dexmedetomidine, contrasting many prior studies. However, further studies are still required to consolidate the efficacy of various doses of dexmedetomidine used along with local anesthetic agent for single dose caudal epidural analgesia. These are my references. Thank you so much.
Okay, Dr. Priyanshu, already there are these two drugs are two different groups of drugs. Why did you decide to select these two groups of drugs? You already know that one drug is quite long acting when compared to dexmedetomidine. So what is the reason behind that? Why do you select this study?
No, actually, there are some previous studies. Yes, sir. So there are some previous studies which show that dexmedetomidine is better than morphine in increasing the duration. But with morphine, there were some side effects also. So we used a low dose of morphine, that is 10 mg per kg we have used, along with dexmedetomidine to see the efficacy.
So what was the reason to come down on 10 micro? What was the reason to come down on 10 micrograms of morphine? Why not 20 like other studies?
Because some I have given a reference because of in the previous studies that they have shown that there were high incidence of respiratory depression in the post-operative and pruritus. There are chances of pruritus, but we wanted to avoid those, so that's why we thought of going for a low dose of morphine and see the efficacy.
Okay, fine. Thank you, ma'am. You can.
What are the problems of morphine? Did you which you got in your study? Did you find any problem with morphine?
Not much, ma'am, but one only out of 40 patients, like only one patient who complained of itching, and there was chances of nausea and vomiting was also present in some patient, but other than no respiratory depression or such kind, nothing happens.
How do you tackle respiratory depression in morphine?
By giving ma'am oxygen post-operative by nasal.
If suppose the child respiratory depression, what do you give? What is the antidote you give?
Pardon, ma'am.
What drug do you give for respiratory depression with opioids or morphine, as in your case? Am I audible?
Ma'am. Yes, ma'am. Yes, ma'am.
Have you understood the question?
Naloxone, ma'am.
What do you use?
Yeah. Yes, ma'am. Yes, ma'am. I have understood, ma'am. I'm sorry, ma'am. I don't know.
Okay, it's all right. Naloxone.
Oh, naloxone. I said okay.
Yes. Thank you.
Thank you.
Thank you, ma'am.
Next speaker is Abhishek Biswal.
Thank you.
Next speaker, Abhishek Biswal. Abhishek Biswal. Ma'am.
Abhishek is not here. Can you proceed next?
Yes, next is Bastina Zenofia M.
Yes, ma'am.
Yes. Please.
Shall I start, ma'am?
Start.
Good afternoon, everyone. I'm Dr. Bastina Genofia from Vinayaka Mission Medical College, second year postgraduate. My poster is on successful anesthetic management of patient with very low ejection fraction. Introduction. Very low ejection fraction has a very high risk of developing dangerous arrhythmia and cardiac failure. Surgery stresses the cardiovascular system in perioperative period, which results in morbidity and mortality in cardiac patients. We report a case of successful anesthetic management of below-knee amputation in coronary artery disease patient on anticoagulants with ultrasound-guided popliteal sciatic and femoral nerve block. Case report. A 65-year-old male was taken for emergency below-knee amputation of right leg under ASA 4. Patient is diabetic, hypertensive, known case of coronary artery disease. Patient underwent CABG 11 years back. Patient was on anticoagulant drugs. Patient had low hemoglobin, normal prothrombin time, INR, and other blood investigations. Echo showed ejection fraction of 32%, severe LV dysfunction, global hyperkinesia of left ventricle, aortic valve sclerosis with calcification, posterior mitral annular calcification, dilated left atrium. Baseline BP is 80/60 millimeters of mercury. Patient was shifted to operation theater, monitors were connected, 18 gauge IV line secured in right hand. Patient kept in supine position, isotonic crystalline fluid started. Under aseptic precaution, ultrasound guided, femoral nerve block and popliteal sciatic nerve block given with bupivacaine 0.25%. Patient received 0.03 mg per kg of intravenous midazolam and oxygen was supplied by face mask throughout the procedure. Surgery started after adequate sensory and motor blockade was achieved. Intraoperatively, vitals were monitored, patient was stable and procedure was uneventful. Post-operatively, pain was managed with paracetamol IV infusion. Conclusion, thus the patient with a coronary artery disease and very low ejection fraction posted for below-knee amputation was managed with ultrasound-guided femoral nerve and popliteal sciatic nerve block without any complication. Discussion. The goal of anesthetic management in very low ejection fraction patient include avoidance of drug-induced myocardial depression, arrhythmias, and maintaining adequate cardiac output. Neuraxial blocks can be catastrophic due to instability of hemodynamic parameters and coagulopathy. Anticoagulation imposes restrictions to classical regional anesthetic techniques. With good knowledge of ultrasonography anatomy and technique, we could avoid risk of vascular damages. This is the ultrasonography image of my patient. The first image is the image of the popliteal block, in which the popliteal block is given in lateral approach. The patient is made to lie supine, resting foot on elevated footrest, and asked to flex knee while one stabilizes the foot and the ankle. The transducer is placed in the transverse position on popliteal crease. And then the two nerve roots, tibial nerve root medially and common peroneal nerve laterally is identified. And it is traced, the transducer is traced cephalad to identify the point of joining as a sciatic nerve over here. And the popliteal artery is identified by using the color Doppler. And the 22 gauge insulated needle is inserted into the nerve sheath at the point of branching. And then first 2 ml of local anesthetic is given. After seeing the spread of the drug, the remaining 15 ml is given. And in the femoral block, the patient is kept in supine position and the transducer is placed over the femoral crease. The femoral artery is identified and color Doppler is made to differentiate the femoral artery. Medial to it is femoral vein and lateral to it is femoral nerve. The needle is inserted into the fascia iliaca, and then below that a drug is deposited. And after adequate motor blockade and sensory blockade, the surgery was proceeded. And these are my references. Thank you.
Dr. Sudesh,
Yes, ma'am.
please ask.
Doctor, what were your anesthetic concerns in this patient? What were the botherations?
The patient is having a very low ejection fraction, and also the patient was on anticoagulants. though the PT-INR value are normal, there is a risk of bleeding the diathesis, and also the hemodynamically the patient was unstable before the surgery itself. So if we go for a neuraxial blockade, there will be hypotension, and also general anesthesia agents like induction agents will cause a systemic arterial pressure reduction by 20 to 30%. So to avoid these, we opted for block, popliteal and femoral block.
No, where do you exactly block the popliteal nerve or the sciatic nerve in the popliteal region? What's the ideal blockade?
Yes, we first placed the probe over the popliteal crease, where we found the common peroneal and tibial nerve. So we traced it above cephal head, where the two nerves meted to form the sciatic nerve. Exactly at the point of separation, we inserted the needle into the O-class fascia, that is nerve sheath, and then we deposited the drug, sir.
Okay, ma'am, you can proceed.
Yes, nice presentation, Bastina.
Thank you, ma'am.
But there is always a chance that the block might fail. So what drugs did you keep on your table to manage a low ejection fraction? What drugs specifically for this patient? This patient has a very low blood pressure. I believe you didn't start with 80/60, isn't it? You resuscitated the patient.
Resuscitated with IV fluids, and then only we started, ma'am.
All right, but what drugs? What are the drugs that you have?
Etomidate was kept.
Okay, and any other things? What happens? What happens if the person has a low ejection fraction? What are the cardiac defects?
There is a risk of patient going for cardiac failure. And then intraoperative ischemic attack is also a risk.
That is what I want to ask. That is what I'm asking you. What
Yes,
are the drugs that you keep for?
Beta blockers, ma'am. Esmolol.
Anything else? What happens if you have a heart failure? What drug? Okay. Thank you. Thank you so much, Bastina.
Thank you.
Thank you. We can move on.
Our next is Dr. Vadadi Ravitej.
Yeah, hello. Am I audible, ma'am?
Yes, you are audible. Please share your screen.
Just is my screen visible, ma'am?
Yes.
Your screen is not showing.
Is my screen sharing, ma'am?
No, not yet.
Sir, please stop sharing and share again.
Just
Just open your PPT, then share the screen.
now?
No.
Just open your PPT, then share the screen.
No, sir?
No.
Just Is it visible, sir?
No. There's a screen share button, green button.
Yeah, I have done that.
Now is it coming, sir?
No.
Can we move on to the next presenter till his issue is sorted out?
Yeah, proceed.
Yes. Next speaker is Sikta Suman.
Yes, ma'am. Am I audible?
Yes, audible.
That's the one.
Yes.
Is my screen visible?
Yes, you are. Please make it full screen.
It's on your camera.
Sure, sure. Am I visible?
Yes, you're visible. Now start.
Yes, ma'am. Please start.
Good afternoon, judges. I am Dr. Sikta Suman, second year PG resident from Department of Anesthesiology, SCB Medical College, Cuttack. Today, I'm presenting a paper on comparison of clinical signs with levels of procalcitonin and CRP for de-escalation of antibiotics. In our practice, whenever a patient is admitted to ICU, broad-spectrum antibiotics covering a wide range of pathogens is recommended based on local resistance characteristics. A recent study states that 30 to 60% of antibiotics prescribed are unnecessary, inappropriate, and inadequate. Epidemiological studies clearly show that there is a direct relationship between the antibiotic consumption and emergence and spread of resistant strains in hospitals and intensive care units. Several strategies in ICU consisting of withholding antibiotics, reducing the duration of antibiotics by effective source control, individualization of treatment, shorter turnaround of diagnostic tests, etc., to reduce the antibiotic consumption. Patients who undergo de-escalation therapy are those who have identified a pathogen sensitive to a more narrow spectrum of antibiotic, have absent persistent neutropenia, and absent severe immunodeficiency. The de-escalation therapy promotes the therapeutic compliance, reduces cost, and appears to be quite correct theoretically. Treatment response in ICU depends on accuracy of clinical examination, correlation of microbiological eradication with clinical responses, immune response, underlying disease, and other infectious and non-infectious complications. Many biomarkers like procalcitonin and CRP assess decisions related to duration of antibiotic therapy. The sepsis biomarkers like procalcitonin and CRP are being tested at the time of admission, followed by their levels after 72 hours and the 7th day. They are supposed to provide additional information beyond the clinical evaluation and shorten the duration of diagnosis and treatment decision. The demographic data, reason of hospitalization, initial procalcitonin and CRP levels were recorded at the time of admission of the patients. The acute physiology and chronic health evaluation too, and the sequential organ failure assessment scores when monitored at the time of admission and discharge of the patient. The mode of discharge like death and survival were also noted. Patients above 18 years of age with sepsis or septic shock were taken for the study, and those with prolonged hospitalization like more than 3 months, prolonged infections like endocarditis or osteomyelitis, and those who are already receiving a broad spectrum antibiotic for more than 2 weeks were excluded from the study. The required biological samples like the blood, urine, or tracheal aspirate were collected as soon as possible, like within 45 minutes of the patient's admission and before the initiation of broad spectrum antibiotics. The among the culture positive patients, we can see the reproduction in culture was seen in 73% of the patients, and from which 24% had already the characteristics of septic shock. The blood cultures were positive in 33% of the patients, which was followed by tracheal aspirate cultures, which is 27.4%. Urine cultures were positive in 14.1%, and the rest were combined culture positivity. Here we can see out of the 73% positive patient, 40 were male and 33 were female. And out of this, 25% died and 48 people survived. In culture negative patients, 15 were male, 12 were female, and 8% died and 19 survived. The data, we used SPSS software for analysis of data. The comparison of categorical variables were done with Pearson chi-square test and Fisher exact test, where we used the exact results and the column ratios were compared with each other, expressed according to the corrected p-values, and values less than 0.05 were considered as significant. The quantitative variables were shown as mean plus minus standard deviation and median values, and the categorical variables were shown as number and percentage. In the patients with culture positive results who were evaluated for de-escalation, there was no significant difference in terms of gender, age, ICU clinical scores, or lab parameters. However, the duration of stay in ICU with de-escalation was found to be significantly lesser than the other group. But when the evaluation was made within the de-escalation group, as we can see, the duration of stay was more in those with culture positive results. When procalcitonin and CRP levels were examined, there was no statistically significant difference. Here we can see that the application of de-escalation to patients with either an elevated biomarker or with culture reproduction, it definitely decreases the length of stay in the intensive care unit. Procalcitonin and CRP changes may be used as a guide in discontinuation of broad spectrum antibiotics, especially in culture negative patients. However, other laboratory parameters should also be used along with these biomarkers. The cause of sepsis, however, is not included in this de-escalation study. So we need more extensive studies to analyze the survival outcomes and length of stay. Thank you.
Well presented, Dr. Sikta. Actually, when you were discussing about the methodology, your study is not very clear regarding, are you trying to find the change in the trends of CRP and procalcitonin as a method for de-escalation, or
yes,
you are going to find the trends or the magnitude of change to decide whether you have to de-escalate the antibiotic or not, isn't it? That's what
yes, sir.
I mean to understand from your study. Okay, so in that case, there are so many factors which can affect the values of CRP as well as procalcitonin, such as presence of renal failure, hypoalbuminemia, etc. So how did you cover up for this confounding factors? Because many times the values can be falsely elevated, or sometimes the values can be falsely low also.
Yes, sir. In that case, sir, we didn't use those patients who had chronic renal failure, and we mostly tried to avoid, sir.
Yeah, that's right. So that kind of inclusion exclusion details you are not you never explained in methodology. And how did you come to the how did you arrive at the sample size also? It's not very clear in your methodology section.
Yes, sir.
And allocation concealment and bias covering is not very clear. A bias such as now you've told some percentage of patients had culture positive, but few of them were culture negative. So how did you decide about antibiotic de-escalation or escalation in this group of patients? What clinical parameters did you assess?
So we looked for the levels of procalcitonin, we look for the levels of CRP, we look for the levels of our total leukocyte counts.
Okay. So that was a guide for your Again, TLC, total leukocyte count, is also not always suggestive of infection, isn't it?
Yes, sir.
So sometimes it might be elevated due to so many other causes like steroid therapy or presence of stress or anything
Yes,
like
sir,
that.
sure.
So dehydration, everything can influence. So
Yes.
I think you should have made the study, like the inclusion, you should have analyzed the results data in a little better way. Probably you could have done a regression analysis, keeping all these things in mind, and you would have tried to find out whether this regression analysis would come out with the magnitude of change in the procalcitonin as one of the indicate or independent risk factors for detecting detecting the decrease in infection or increase in infection.
Yes, sir.
Okay. And you should also compare your studies with other studies. Many of the authors forget to discuss about the discussion part of the studies. I've at least noted around 3 to 4 authors have never discussed about, except 2 studies, all other studies, they never discussed about discussion part. That is, they have not compared their studies with other studies. And all. So I think you need to actually go through the proper method of paper presentation and prepare slides before presenting. Okay, ma'am. Ma'am, you
And
can.
Shita, procalcitonin is a costly test,
Yes,
isn't it?
Yes, ma'am.
So how do you justify the use of procalcitonin for all the patients just to de-escalate the antibiotic regimes?
Ma'am, actually, this study was conducted in our setup in our SCB Medical College, Cuttack, and in our college itself, it's done for free, ma'am.
I understand, but from your results, people are going to interpolate, isn't it?
Yes, ma'am.
How do you do it? Somebody is paying, your hospital is paying for it.
Yes, ma'am.
So how do you justify the cost effectivity?
Ma'am, instead of procalcitonin, we can use CRP levels also.
So but you feel that that is better, is it?
Yes, ma'am. Yes, ma'am.
From your study, we cannot conclude completely which is better. Okay.
Yes, ma'am. Yes, ma'am.
Okay. Thank you so much.
Thank you, ma'am.
Ma'am, now we call upon.
Sure, absolutely.
Badari Ravitesh.
Yes, Ravitesh is there. I think he's ready.
Your screen is not shared again. Yes, shared.
Yes, it is. It is.
Now we can see.
Am I audible, ma'am?
Yes.
Yes. Please make it full screen.
Yes, ma'am.
Start.
Yeah. Good afternoon, everybody. I am Dr. V. Ravitesh from IMS and Some Hospital. Today, my topic is regarding comparative efficacy of postoperative pain relief between ultrasound-guided TAP block and ilioinguinal and iliohypogastric nerve block for patients undergoing open inguinal hernia repair under spinal anesthesia. The aim and the background is open inguinal hernia surgery is a very most commonly performed surgery across the world, having an incidence of 11 to 200 per 10,000 persons. The surgery is mainly associated with postoperative pain and distress. So adequate analgesia is required to decrease stress response and also provides which also provides early mobility and rehabilitation. And these ultrasound guided blocks like transverse abdominis pain block or ilioinguinal and iliohypogastric block provides good analgesia, and as it is given by ultrasound, they have a high success rate. And the aim of the study is to compare the postoperative analgesic efficacy of both the TAP block and the ilioinguinal and iliohypogastric nerve block using the ultrasound. And coming to the materials and methods, the study type is after the ethical committee approval, and I have taken the consent from the patients. This is a prospective randomized controlled clinical study. And the sample size which randomly allocated into 3 different groups: ultrasound guided ilioinguinal and the inclusion criteria. Adults of age group have taken between 18 to 60 years, and whose ASA physical status grading is 1 and 2, and patients who are undergoing elective primary unilateral open inguinal hernia repair. And the exclusion criteria are patients who refused for the consent of who refused for the study, and patients who are having BMI greater than 40 kgs per meter square, and ASA grade 3 and 4 patients are poorly regulated systemic diseases, patients having poorly regulated systemic diseases, and if there is any local infection at the site of the block, or patients having any hypersensitivity reaction or allergic reactions to local anesthetic drugs, and patients who are already once underwent inguinal hernia repair and being posted for the second time, or being posted at the same time for the bilateral repair. And cases, I have excluded cases in which the block has been failed actually. Coming to the in the preoperative room, I have kept the patients nil per oral for 8 hours for solids and 2 hours for liquids, and I have secured them with an IV line with help of 18 gauge cannula, and started crystalloids with 80 ml per hour, and they are monitored for heart rate, BP, and oxygen saturation. The level of sensory and motor blockade are assessed. Coming to the after every patient is given spinal neuraxial block. After that, depending upon that, we will be giving either tab block or the ilioinguinal block. In the tab block, as you can see in the picture, the 3 abdominal muscles are seen, and after that, the local anesthesia is given between internal oblique and transverse abdominis muscle with the help of 0.2% ropivacaine. 20 ml is injected between them. And coming to the ilioinguinal and iliohypogastric block, after giving the spinal anesthesia, with the help of the ultrasound, we have identified the ilioinguinal nerve and the iliohypogastric nerve, and we have given 20 ml of ropivacaine, 0.2%. And the patients are monitored for pain using visual analog scale, and if any side effects like vomiting, nausea, etc. are observed, and they are noted. And for statistical analysis, for a statistical power of 90%, a confidence interval of 95%, necessary sample size was calculated. Data analysis was done by SPSS software, and parametric data were expressed as a mean and standard deviation, and the quantitative variables were assessed with one-way ANOVA. The qualitative data compared using chi-square test. These are the results. Regarding the ASA grade, p-value is 0.37, and the VAS score is generally morely observed during the patients complain pain between 4 to 8 hours, and the rescue analgesia given in group I is comparatively less when compared with group T. These are the results. All the enrolled patients completed the study. No statistical significant difference in demographics and ASA physical status scores. And the first pain declaration time was significantly higher in study groups when compared with the controlled group. And there was an increase in pain declaration time or first time for first rescue analgesia in patients receiving ilioinguinal or iliohypogastric block. And additional analgesic requirements are significantly low in patients of study groups than the control group. The conclusion is my conclusion is that we found the study groups receiving tab block or ilioinguinal block are better when compared with spinal anesthesia, and ultrasound guided ilioinguinal or iliohypogastric nerve block provides more effective post-operative analgesia and reduces additional analgesic requirements. These are some of the other studies. Evelyn et al. Has conducted a study based on landmark anatomy, and concluded he found that tab block provided superior analgesia, and Stav et al. Found that ilioinguinal and iliohypogastric nerve block was more effective in preventing post-op pain than tab block. And Wang et al. Showed ultrasound guided ilioinguinal nerve block and tab block provided comparable pain management and reduction. These are my references. Thank you.
Doctor, when you're presenting a study, there should be some sort of uniformity. Usually the discussion part should always come before conclusion. Once you tell conclusion, there's nothing more to be added upon. Okay. And even in the methodology also, you should follow a uniformity. Like it should be like your study should have institution, then inclusion, exclusion criteria, then that study technique, then followed by the parameters observed, the primary and secondary parameters, followed by sample size estimation, followed by statistical analysis. Okay, so that particular pattern should be followed everywhere. It is not only for you, for all the people who are presenting the papers today. You were talking about you excluded patients in whom the block failed, isn't it? So how do you know whether the patient failed? How do you know that the block failed in the patient?
We have seen when ultrasound we have given the drug. After that we have checked again, sir. Then sometimes the drug has been misplaced to some extent. Then such kind of patients we have excluded, sir.
That it has to be clear in your methodology. Okay.
Okay.
Ma'am, it's over to you.
You are not audible.
What probe did you use? Which kind of a probe did you use for your tab block?
Ma'am, I have used the linear probe, ma'am.
Okay. Okay. Thank you.
Thank you.
Next speaker is Sneha Sisa Das.
Can we proceed?
Next speaker, Sneha Sisa Das. Are you present? Sneha Sisa Das.
Sneha is not here.
Next, Ashok Ji. Dr. Ashok Ji.
Yes, ma'am, I'm there. Hello?
Yes.
Share your screen. Ashok ji, share your screen.
Oh, sir, one second, sir.
Ashok ji, I am audible.
Yes, sir. Please share your screen.
Yeah, sure, sir.
Yes.
Start.
Please start, sir. Start quickly.
Today my topic is control study of intravenous paracetamol and dexmedetomidine. This is intravenous diclofenac and dexmedetomidine on intraoperative hemodynamic changes and postoperative analgesia for patient undergoing laparoscopic cholecystectomy cases. So, what is the aim of the study? The aim of the study is the pain. Pain is the major concern which will happen after lap cholecystectomy. There are many other multimodal aspects for the pain. One of the examples is CO2 inflation will cause a pain, and surgical manipulation during and bile leakage and diaphragmatic irritation. This all causes the pain. Hemodynamic changes also happen during post-inflation due to CO2 inflation. So to overcome that, we want to find a better analgesic combination. So we have compared between paracetamol and diclofenac with dexmedetomidine as a common in both groups. So to find out any synergistic activities present. And we are conducting the studies a double-blinded study. Hypothesis that paracetamol and dexmedetomidine provide a better analgesia, and that's our hypothesis. The study was conducted in IMS Some Hospital, and over the period of from July 2020 to from January, and we connected 90 ASM grade 1 and grade 2 patients for included and divided into two groups, and randomization was done by computer generated numbers and allocation by sealed envelope methods. To overcome the double blinding method, the patient and anesthetist who are observing the parameters and will be studying the drugs about the side are blinded, sir. The inclusion criteria includes the patient A is a grade 1, grade 2 patient, and the lab polysystemic cases which are only procedure under 1 or 2 hours, sir. And the exclusion criteria will be as a grade 3 and grade 4 patient, and Mallampati 3 and 4 patients are excluded, and patient have any side effects of the drugs previously known are excluded from the studies. So the group A patient will be receiving IV PCM and 1 gram and dexmedetomidine, and group B patient will be receiving IV diclofenac 75 mg and dexmedetomidine, sir. The patients are was prepared preoperatively, and they were explained about VAS score before day of surgery, sir. And both drugs are given 15 minutes prior to the induction. To overcome the bias, the patient both drugs are diluted in 100 ml NS saline, and they are infused for 15 minutes prior to the induction, sir. The dexmedetomidine was started with the infusion rate of 1 mg per kg over 10 minutes of bolus, then continued till up to 15 minutes prior to the closure at the rate of 0.3 to 0.7 mg per kg.
So intraoperatively, the parameters we are going to monitor are we're going to monitor the patient's SpO2, pulse rate, and mean arterial pressure, and systolic blood pressure, and diastolic blood pressure. So these are measured at the interval between before induction and post induction, and after insufflation, and 5, 10, 15, and 35 minutes, and up to 6 hours of the interval. Post-op, we are going to monitor for any presence of any side effects and vitals and monitoring, and the VAS score and sedation scores are monitored. These scores are monitored after extubation from 15 minutes, 30 minutes, and 45 minutes, and 1, 2, 3, and 4 are respectively, sir. In post-operatively, since the patient are explained about the VAS score day before, and we are asked the patient what is according to Michelin and log score. The patient complains of pain score greater than 4. The rescue anesthesia tramadol 100 mg is given, sir. At the end of the 6th hour, the total amount of anesthesia used is calculated. So statistics. Standard computer programs has been used, and we have found that the total study samples would be 90 from previous studies which are conducted. On completion of the study, the data are tabulated and the mean standard deviation and mean are calculated. The parameter data are analyzed using t-test, while the non-parametric data were analyzed using Wilcoxon signed rank test and a Mann-Whitney test. Qualitative data were analyzed using Psychos or Fisher's extract test. So the following observations we have obtained from our study. The first observation is the sex and the age of the patient doesn't play any significant role. So the p-value seems to be very insignificant. Following that, the pulse, the mean pulse rate measured during different intervals shows significant changes during post-inflammation period and 10 minutes and 15 minutes, and post-operatively till post-op extubation also, the patient have showed a drastic reduction in the pulse rate between the two groups. Group A, the patient who receiving paracetamol dexam showing better having lesser pulse rate than compared to Group B patients. The another change we have noted in the patient is a mean arterial pressure. Mean arterial pressure is shown to be reduced more during the time of post-inflammation and the time of extubation. And systolic blood pressure seems to be shown no significant variations noted between the two groups, and they seem to be remain p-values insignificant. The mean diastolic blood pressure difference is reduced after inflation, and 10 minutes, 15 minutes, the systolic blood pressure value remain to be continuously reduced toward the observations. The pain score is comparatively less in the Group A patient compared to Group B. And the patient started to the maximum pain score difference is noted around after 2 hours of surgery. Also, patient complained less pain compared to Group B patients. So the result, the post-op pain score is reduced in Group A patients. The intra-op diastolic blood pressure, mean arterial pressure, VAS score, and opioid usage is less during 6 hours during post-op in the Group A patients. The mean diastolic blood pressure and mean arterial pressure and VAS score are significantly less compared in a Group A compared to Group B, and both the systolic blood pressure and saturation level remains same. There is no significant difference. The conclusion of a study: this study concluded that PCM dexmedetomidine infusion has provided better analgesia for prolonged duration with minimal side effect and lesser uses of tramadol needed, sir, in this patient. So these are my references, and thank you, sir.
Okay, Dr. Ashok.
Yes,
Why do you feel that PCT and dexmed combination is better than diclofenac? And because analgesic diclofenac is supposed to be better.
Hello.
Yeah.
Hello. Sir.
Yeah, tell me, Dr. Ashok. Can you hear me? Hello. Dr. Ashok, are you audible? Are you able to hear us? Hello. Dr. Ashok, please unmute yourself.
Yes, sir. Unmuted, sir.
Okay.
Both PCM and dexmedetomidine. Both PCM and dexmedetomidine both act most centrally, sir. So we feel that PCM and dexmedetomidine combination act better compared to diclofenac, sir. And there is a few studies which have shown that ASA grade 1 patient who are receiving paracetamol has been shown that there is a little bit hypotension can be developed in that patient, sir. So using that study as a support, we are coming to hypothesis that PCM dexmedetomidine is a better combination.
Sorry, I didn't get you. Which patient got hypotension? Sorry, I not able to.
Sir, they conducted one study, sir, in the ASA grade 1 patient who are receiving PCM. They shown to be have lesser hypo. They're able to develop hypotension, sir. Paracetamol induced hypotension they mentioned, sir.
Paracetamol induced hypotension.
Sir.
Yeah, paracetamol induced hypotension. I mean, okay. Fine. Okay, ma'am, you can proceed.
Yes. When you're using diclofenac, what are the patients that you avoid?
We avoided any patient with asthmatic history or any kind of previous history to any renal failure patients. We are totally avoiding diclofenac patients, ma'am. And any like liver
Also,
failure.
if the patient has renal disease.
Yes, ma'am.
Okay, thank you.
Thank you, ma'am.
Dr. Snehasi Das, next speaker. Dr. Snehasi Das, not present. Then Dr. Ramya Varda. Dr. Ramya Varda.
Are you there, Dr. Ramya Varda?
Yes, ma'am. Yes, ma'am.
Please share your screen.
Please share your screen and start.
Yes, sir. Hello. Ma'am, can you see?
Yes, you're visible. Please make it full screen.
Please, ma'am, take a full screen and start a slide.
Ma'am, I am Dr. Snehasis.
Ma'am?
Sir, please wait
Yes,
after this topic, then you will start.
Okay. Thank you, sir. Okay.
Hello, ma'am. Can I start?
Yeah.
Please do.
Please.
Good afternoon, ma'am. I'm Dr. Ramya from IMS in some hospital. Today's paper is about a comparative study of efficacy of dexamethasone in prolonging the duration of postoperative analgesia in ultrasound-guided transversus abdominal plane block with 0.25% bupivacaine versus 0.5% ropivacaine in abdominal surgery. The background of the study is transverse abdominal plane block is a regional analgesic technique to enable pain-free post-operative period after abdominal surgery, especially parietal wall, which plays a key role in pain. Infiltration of local anesthesia over the transverse abdominis muscle causes sensory blockade of abdominal wall, skin, and muscles. We evaluated the efficacy of dexamethasone and prolongation of duration of post-op analgesia in ultrasound-guided tab block using 0.25% bupivacaine plus dexamethasone named as Group B and 0.5% ropivacaine plus dexamethasone named as Group R in abdominal surgeries in hospitals. The methodology is being 80 adult patients were posted for elective abdominal surgery were included and randomly divided into two groups of 40 each using computer-generated table of randomization and picked up basing upon computer sealed envelopes, opaque envelopes. And after induction of anesthesia, tap lock, unilateral or bilateral, basing upon the incision of the surgery, was performed using 8 mg dexamethasone with 15 ml of 0.5% ropivacaine or 0.25% bupivacaine each side by ultrasound guidance. Each patient was assessed intraoperatively for hemodynamic parameters like heart rate, systolic blood pressure, diastolic blood pressure, mean arterial pressure, and SpO2 at 0, 5, 10, 20 minutes. Post-op also, patients were assessed for pain with VAS score at 0, 30 minutes, 4 hours, 8 hours, 12, and 24 hours. All patients were made clear about pain scoring on the verbal analog score, where 0 being no pain and 10 being the worst possible pain. And a VAS score of 3, rescue analgesia was given without even demand also. The data was then analyzed statistically using unpaid t-test for continuous data and chi-square test for categorical data. A p-value of less than 0.05 was considered to be statistically significant. All statistical analysis was performed using SPSS statistics for MAC version 26. The technique of tab block being an ultrasound-guided approach for tab block was clearly used as described by Hebert et al. And in his study, he mentioned the technique of using a linear ultrasound probe of 6 to 12 megahertz was used to visualize the anterolateral abdominal wall where all the three muscle layers were distinctly visible. Then after identification of these three muscle layers, we have to go through the transverse abdominis plane, that is between the internal oblique muscle and the transverse abdominis muscle. The probe was moved posterolaterally to lie across the mid-axillary line, just superior to the iliac crest. That is nothing but a triangle of Petit. A 23 gauge needle was then introduced anteriorly and advanced in an in-plane approach, and a local anesthetic is being deposited over the plane. Briefly, a sonoanatomy has been given where we can show how it's triangle of Petit, and sonographically also where we deposit our here in the plane, TAM plane, between the transverse abdominis muscle and the internal oblique. The results of this, both the groups B and R were comparable with regard to age, gender, and physical status grading. The ordinal data including weight, age, heart rate, systolic blood pressure, diastolic blood pressure, and VAS score, whereas categorical data is age group, age status, and type of surgery. The mean duration of analgesia in ropivacaine group R and group B was 13.87 plus or minus 4.13 hours and 10.9 plus or minus 3.81 hours respectively, which was found to be statistically significant and comparable. The power of the study lies to be 90% and an alpha error of 5%. My results on basing on table 1, which is group comparison for age of the patients and gender distribution, has not much of significance, but they have a group of significance in comparison for time of analgesia. The discussion is based on the equipotency ratio of 1.3:1 to 1.5:1 between ropivacaine and bupivacaine respectively for epidural anesthesia. We chose to compare 0.25% bupivacaine with 0.5% of ropivacaine. This is a randomized, double-blinded comparative clinical study, was designed to compare ropin and bupivacaine with respect to their analgesic efficacy as well as role of dexamethasone in prolonging the duration of analgesia. Since I chose dexamethasone because the role of adjuvants like dexamethasone were poorly described and exact mechanisms still seem to be unknown. And why I chose ropin, because ropin was introduced into clinical practice as early as 1993, but has been patented in India in 2009. So we decided to study this drug with the most commonly conveniently used long-acting bupivacaine. The significance of tab block in our general anesthesia patient going is the projection system of limbic system or hypothalamus towards the cerebral cortex may be suppressed under general anesthesia, but the harmful surgical stimulation might still exist because the sympathetic nerve adrenal medulla axis still responds under stimulation and cannot block the reflection of central nervous system. So tab block can effectively compensate for the insufficiencies of general anesthesia, thereby prevents the sudden surge of blood catecholamines during skin incision, and which plays an important role in maintaining a stable intra-op hemodynamics. And role of dexamethasone in peripheral nerve blocks. It's a potent synthetic corticosteroid with approximately 7 times the anti-inflammatory potency of prednisolone and a very little mineralocorticoid activity. Half-life is approximately 36 to 54 hours. It seems to be augmenting the analgesia by reduction in pro-inflammatory interleukins and TNF-alpha, neuropeptides, and bradykinin release at the tissue level. Thus, it limits the local edema and tissue destruction, which generates a pain stimulus. It also causes potassium channel permeability modulation, thereby changing in lipid membrane equilibrium and the subsequent alteration in nervous impulse generation, limiting nociception locally at the nerve fiber. It's also its ability to downregulate prostaglandin synthesis contributes to analgesia peripherally and at the spinal cord level by limiting sensitization of the nociceptive and inflammatory pathways. My conclusion being that the tab block significantly reduces the pain as it decreased post-operative rescue analgesia requirement, also showed high efficacy upon maintaining intraoperative hemodynamics. 0.5% ropin with dexamethasone had longer duration of analgesia than 0.25% bupivacaine with dexamethasone. There were no complications owing to a tab block or drug given, and post-operative stay of patient was pain-free, enabling for early mobilization. Hence, post-op complications like DVT, distress, abdominal straining could be avoided. So thus it could be concluded that ropivacaine with dexamethasone can be used as a safer alternative for bupivacaine with dexamethasone routinely for tab block for abdominal surgeries. My references being these, and thank you so much.
Dr. Ramya?
Yes, sir.
Did you study the mobilization? Did you study the incidence of DVT and all in this study?
Sir, there was a parallel study been going on as one of our postgraduates been doing it about DVT in lower limb surgeries or anything like a post-surgical. And
the question is very clear.
not in my current study, I haven't studied, sir.
So you should not conclude that, okay? Because what you have not
okay.
studied, you should not conclude. What you have studied only should come in your conclusion. Whatever is your primary aim, only that much you should be restricted to your conclusion.
Okay, sir.
That is
Okay, sir.
the second thing. It's already proven that when you use ropivacaine, you should use it slightly at a higher dose and compared to lower dose of bupivacaine. Now, what is the rationale behind it? Scientific reason behind it?
Sir, can you repeat the question again, sir?
What is the scientific rationale behind the dosage difference between ropivacaine and bupivacaine?
Sir, like in my study, I took 0.25 comparing 0.5 basing on the equipotency ratio, sir.
No, that's what. What is the reason behind it? I mean, if there is any scientific reason behind it for that?
Sir, it's like when you compare two drugs, we have to compare first of like equipotency ratio is something.
No, I can understand that part. My question is, what is the scientific rationale, or why that difference should exist? Because both of them are long acting. Both of them are molecules, isn't it? Both are similar molecules. Both of them are long acting. But why the difference on duration of duration?
Ropivacaine is less lipophilic, sir. So less the mode.
Okay, fine, no problem. Yeah, ma'am, you can.
Is there any problem with the motor block?
Yes, ma'am. My neighbors was giving tab block after giving anesthesia, general anesthesia. So motor block didn't actually bother us much. Although ropin says that motor block will not be there because ropin is less lipophilic and it cannot penetrate the large myelinated fibers. But after the surgery, even if it is having a motor block or not, we were more worried about sensory. How is he feeling painful or not? That's what.
Okay. Thank you very much.
Thank you, ma'am. Thank you so much.
Okay, our next speaker is Dr. Snehasis Das.
Yes, ma'am. Yes, ma'am.
Yes, you can share the screen.
Yes, ma'am. Yes, ma'am. Are you able to see?
Can we start?
Hello.
Yes.
Hello. Am I audible?
Yeah,
Yes,
you're audible. Please go ahead with the presentation.
Okay, sir.
Open your slides. No, you just
Good afternoon. Good afternoon, respected juries. I am
just open your slide.
Yes. Good afternoon. Hello.
Yeah. Go ahead, Dr. Snehasis.
Yes, sir. I already shared my screen.
No, but where is you open your PowerPoint slides. Where is your PowerPoint slide?
Hello.
Yeah. No.
Now, fine, sir.
Yeah. Okay. You can go ahead.
Okay, thank you, sir. Good afternoon, respected juries. I am Dr. Snehasis. Today presenting a paper on effect of neostigmine and atropine to the management of postural puncture headache, and any breach of the dura may result in the PDPS that may be diagnostic or therapeutic LP, myelography or spinal anesthesia. It is thought to result from meningeal traction or cerebral vasodilation. The dramatic response to neostigmine in the patient with PDPS due to the central effect of neostigmine, which can pass through the choroid plexus also, and the action of atropine on CSF secretion and cerebral vascular tone are the primary pathophysiological changes associated with PDPS. And the aim of my study was to know the effect of addition of neostigmine and atropine to the management of PDPH, and also to determine the difference in the VAS primary outcome and the secondary outcome, including the neck stiffness and nausea and vomiting in the neostigmine atropine group and also in the control group. And in this trial, we include 50 parturients between 20 to 40 years of age with ASA grade 2 and diagnosed with PDPH following intrathecal spinal anesthesia for elective cesarean section delivery. And we excluded patient with VAS score less than 5 and a history of chronic headache, cluster headache, migraine, convulsions, preeclampsia, eclampsia, and gestational diabetes. And intrathecal spinal anesthesia was performed after giving an intravenous fluid with 10 ml per kg of Ringer's lactate, and the block were performed in the sitting position using 2.5 ml of hyperbaric bupivacaine and at L3, L4 or L4, L5 interspace using a 25 gauge Quincke's needle. Patients were divided into two groups as group N and group P. And to the group N, we gave neostigmine 20 microgram per kg slow IV and atropine 10 microgram per kg in 20 ml of 0.9% NS, that is given over 5 minutes every 8 hours. And to the group P, that is placebo group, we gave 20 ml of 0.9% NS IV every 8 hours. The intervention was continued until achieving a VAS score less than equal to 3 or a maximum of 72 hours. And both groups received the conservative management like nursing in the supine position, hydration with continuous infusion of 2 ml per kg per hour RL or DNS or NS solution, and 1 gram paracetamol plus 135 mg caffeine every 6 hours. Participants were asked to report the severity of their headache at 0, 6, 12, 24, 36, 48 and 72 hours. And the presence of neck stiffness, diarrhea, muscle cramp, bronchospasm, urinary bladder hyperactivity, nausea and vomiting, abdominal cramp, and muscle twitches were recorded throughout the study period as yes or no. And the participant age, weight, height, BMI, and the time interval between dural puncture and the occurrence of PDPH were also recorded. And the result were expressed as mean plus or minus standard deviation, median with interquartile range, and number and percentage of participants as appropriate. And the categorical data like neck stiffness and nausea and vomiting were evaluated by Fischer-Exer test. And patient age, weight, height, and BMI and onset of headache were compared by the independent student t-test. P-value less than 0.5 were considered significant. And out of 1843 patients, 54% reported a VAS score more than equal to 5, and 4% were excluded due to the history of migraine and preeclampsia. Then patients were divided into two groups as group N and group P. And to the group N, we gave the neostigmine atropine, and to the group P, that is the placebo group, we gave 0.9% NS. And what we saw was the median difference for VAS between the N and P group was derived from 0 to 72 hours, and there was a significant reduction of VAS in the N group than in the P group. Also, all patients in the N group achieve a VAS less than or equal to 3 after 2 doses. As shown in this table, the secondary outcome like neck stiffness, nausea and vomiting in both groups till 72 hours was derived. And what we got was there were no difference in the incidence after 72 hours. As shown in this table, the incidence of treatment associated side effect like abdominal cramp was in 6 participants, and muscle twitch was in 5 participants, and urinary bladder hyperactivity was in 3 participants in the N group, that is the neostigmine atropine group, versus 0 in the placebo group. But incidence of diarrhea, muscle cramp and bronchospasm was nearly same in both the group. This is what we already discussed. And visual analog score is a measure of pain intensity. It is a continuation scale comprised of a horizontal called horizontal visual analog score or a vertical called vertical visual analog score, usually 10 cm or 100 mm in length. And neostigmine is significantly lower the VAS score and shorten the duration of the PDPH. And the treatment associated side effects were more frequent in the neostigmine atropine group. And side effects associated with neostigmine atropine were primarily due to cholinergic effect of neostigmine. And this is the mechanism of action of neostigmine and atropine. Neostigmine on acting on the cerebrospinal ganglia causes the cerebral vasoconstriction and increases the CSF level. Also crosses the blood CSF barrier and causes the increase the acetylcholine level. Atropine also causes cerebral vasoconstriction and increases the CSF. And so we can say that neostigmine and atropine decreases the incidence of PDPH, and atropine minimizes the cholinergic side effect of neostigmine. Dilution decreases the clinically significant side effect associated with either neostigmine or atropine. Thus, neostigmine can be added to the armamentarium for treatment of PDPH. Thank you.
Well presented, Dr. Snehal. It's an interesting topic, not regularly practiced. How did you arrive at the sample size of this number? Like what parameter did you consider for calculation of sample size apart from power and alpha error?
Sir, actually, I took help of my statistical.
That is correct, but you should give them details, no? Only then he can calculate sample size for you. So, what details did you give apart from power and alpha error? Whether you calculated sample size based on any particular parameter in the study?
Sir, actually, from my very beginning, we did a lot of cases in that emergency department of gynec ward, gynec OT, and from this I followed, and also some of my friends also followed these patients, and we took help of gynec PGs also.
No. Yeah, I'm not asking who followed up the cases, but the thing was, how did you ensure that the sample size was selected? What parameter did you consider? Okay, fine. How did you ensure that there was no bias of treatment while recording the observations? How did you ensure that there was no observational bias in your study?
Sorry, sir. Hello.
How did you ensure that there was no observational bias in your study? Like the person who observed was not aware of the treatment groups. How did you ensure that he was not aware of the treatment groups?
Sir, we gave to all patients after if in the neostigmine atropine group, when the patient achieved VAS score less than 5, then also we continued the test group patient with NS, and every 6 hourly, every 8 hourly we gave NS also to the test group also, neostigmine atropine group patient also after achieving a VAS score less than 5. We continue the treatment. We stop neostigmine atropine, but continue the treatment as NS only, like placebo group.
Okay, fine. Ma'am, you can proceed.
Yes, what are the newer ways that you can manage PDPH? What are the recent advances?
Ma'am, cosintropine was there, and that is the newer advance that is a synthetic ACTH, and due to its mineralocorticoid action, it increased the CSF
Any
retention.
other things? Any other blocks?
And also sumatriptan, gabapentin, and
those are not the recent ones. Recent any blocks you know of?
blocks? No, ma'am. Fibrin glue, dextran 40, etc.
Okay, thank you so much.
Thank you.
I think Dr. Sneha Singh was our last speaker. So thank you, Dr. Sudesh sir and Dr. Sujata ma'am.
Thank you so much.
So much. Thank
and
you.
giving so much information. Thank you, sir and madam. Thank you.
Thank you. Thank you very much.
I thank the ISA Odisha for giving me this opportunity. Thank you, Rekha ma'am, also for considering me for this job. Thank you so much, ma'am. Thank you so much.
Thank you, sir.
Thank you, Rekha ma'am, for inviting us. And it was an honor to be a part of this conference. Lovely conference. Thank you so much.
Thank you, sir. Over to the next session.
Very good afternoon. Myself, Dr. Sunita Misra, and our Associate Professor, Dr. Sunita Misra. I'm on behalf of Account 49 Account Web Conference. I'm welcoming all to the free paper session. Ma'am, kindly introduce our esteemed judges to the hall.
Hi, that is not my picture. Thank you. I am Dr. Vijayalakshmi. Okay, that's okay. No issue. Are we ready to start the next session?
Yes, ma'am.
Suman Chatterjee is there, no?
Yeah, madam, let's forget about the introductions and let's start. We are already late. Let's start the session at the earliest.
Yes, sir, please.
You're not audible.
Ma'am, you are not audible.
Welcome, ma'am. Dear Lakshmi, ma'am, Center Anesthesiology, Indira Gandhi Medical College Institute, Pondicherry. Her areas of interest are regional anesthesia, ultrasound applications in anesthesia and ICU, pediatric anesthesia and difficult airway. He is a diplomat from European Society of Regional Anesthesiology and Acute Pain Medicine, ESRA Society. He is GC member of RSACP National. He was previous EC member of ISA Pondicherry. Has research publications in peer-reviewed international journals. And
Dr. Sunita, you are muted. We are not able to hear you.
sorry, ma'am. Sorry, ma'am. And welcome, sir, Professor Suman Chakrabarty, head of the Department of Anesthesiology at Midnapur Medical College. He has around 40 publications. And, sir, your areas of interest are anesthesia and discourse limited scenarios. Now, sir, we will go with the session. I will request the participants to get ready. Our first participant is Siva Murugan. Siva Murugan, are you ready?
Can we start off with the
Shiva
first
is not
presentation?
there. Shiva is not there. Can you proceed next?
Okay, next participant is Snehal Divakar. Snehal Divakar.
Yes, ma'am. Yes, ma'am.
Dr. Sunita, just announce the next person, no, so that they'll be ready with their presentation.
Yes,
so that we'll not waste time quickly.
Yes, ma'am. Snehal Divakar, ready?
Is my screen visible?
No, not now.
No, not yet. We are now seen.
Okay, ma'am. Good afternoon, everyone.
It's full screen.
Yes.
Yeah.
Can you start the timer, please? What is the timing? 7 minutes?
7 minutes.
Yeah, please put the timer.
Okay. Good afternoon, everyone. Myself, Dr. Snehal Thombre, second year postgraduate at IMS in some hospital. I am presenting under guidance of Dr. Sudeep Mohapatra. Title of my study is dexamethasone versus dexmedetomidine as an adjuvant to local anesthetics for post-operative analgesia in scalp block, a prospective comparative study. This is not changing. Yes. So scalp block has been extensively used in the practice of anesthesiology in neurosurgery, primarily described by Pinoske et al. 6 nerves were identified by landmark on each side of the cranium and were infiltrated. Number of studies have been done using dexamethasone and dexmedetomidine as an adjuvant to local anesthetics for nerve blocks. Much literature is available about the same pertaining the supra and infraclavicular brachial plexus blocks. However, we are studying same drugs in scalp block. My aim of my study is to compare duration of analgesia in scalp block with dexamethasone and dexmedetomidine as an adjuvant to local anesthetics for burr hole in evacuation of chronic subdural hematoma. Primary objective of my study is to record and compare NRS score at 6 hours, 12 hours, and 24 hours. Secondary objective is to record vitals at baseline, at incision, and post-operatively. Materials and method. Written informed consent has been taken, after which patients undergoing a burr hole for chronic subdural hematoma from September 2020 to February 2021 were selected. Inclusion criteria was age between 19 to 75 years, ASA grade 1 and 2 patients, GCS more than 13, and unilateral chronic subdural hematoma patients. Exclusion criteria was GCS less than 13 and patients with ASA grade 3 and 4 and bilateral chronic SDH. Selected patients were randomized by computer generated numbers, and they were divided into 2 groups by enclosed envelopes. Into group A, received dexamethasone 0.15 mg per kg, and group B received dexmedetomidine 0.5 mg per kg. Adjuvant to 0.5% bupivacaine 2 mg per kg and 2% lignocaine with adrenaline 5 mg per kg for scalp block. Pre-skin test has been done to check for allergy to local anesthetics. All patients were pre-medicated with glycopyrrolate, midazolam, and fentanyl before giving scalp block. None of the patients required endotracheal intubation. For the procedures, 6 nerves were identified by landmark method and subsequently block was given. Here we can see the 6 nerves with their landmarks. Heart rate, NIBP, and SpO2 was recorded. Oxygen was given by nasal prongs. Chronic SDH was evacuated by a burr hole before puncturing dura. Sterile gauze soaked in 2% lignocaine was kept on dura for 2 minutes. In all the patients, baseline vitals and were recorded at incision, and NRS score at 6, 12, and 24 hours were recorded and compared. Total 20 patients were selected, out of which 5 were excluded as per exclusion criteria, and remaining patients were randomized into group A and B. Out of 15 patients included, 7 were females while 8 were male. Group A had 4 females and 4 male, and group B had 3 females and 4 males. Age distribution, age in the both groups is comparable and there is no statistically significant difference in the age distribution. As we can see in the table, other parameters when compared between the two groups showed no statistically significant difference in terms of preoperative, intraoperative vitals, and both groups were comparable in all terms. As we can see the table, NRS scores collected at 6, 12, and 24 hours of both groups are shown in a trend in line diagram. For group A and B, we can see at 6 hours and 12 hours and 24 hours. The NRS scores collected at 6 hours, 12 hours, and 24 hours showed a statistically significant difference. As we can see, the p-values and the pain score are better in group A as compared to group B. Discussion. Skull block have been used for craniotomies and surgeries of the head for a long time. Many researchers have used skull block as an adjunct to general anesthesia for the postoperative pain relief and have found it useful as a post-op good pain control. Differences in block characteristics between perineural and intravenous dexamethasone were not clinically important. Also, intravenous dexmedetomidine did not affect block characteristics. In double-blind randomized trial by Valupu, the researchers have found that addition of dexmedetomidine to bupivacaine prolonged the pain-free period, and scalp nerve block is a superior technique than scalp infiltration. However, this trial does not compare dexmedetomidine with any other adjuvant. No previous study has compared the two drugs as an adjuvant in scalp block with local anesthetics for duration of nerve block in terms of postoperative pain control. Our study establishes that the addition of dexamethasone to local anesthetics provide better pain control when compared to dexmedetomidine for the same. Other studies have found similar results for intercostal nerve blocks and brachial plexus block. Conclusion: the addition of dexamethasone to local anesthetic for scalp block provides better analgesia when compared to dexmedetomidine. My references are, thank you.
You have administered the blocks prior to giving GA or after? You have given GA for these cases, right?
No, ma'am, we have not given.
Only under blocks.
Only under blocks.
So how did you choose your sample size?
Sir, actually, we have chosen a duration in which like the study is still going on, sir. Like we have chosen a duration, and in that duration, sir, how many patients came and which were in our inclusion and exclusion criteria. Accordingly, we decided the sample.
So this was a sort of a pilot study, isn't it?
Yes, sir. It is a sort of a pilot study.
Another question I want to ask you, that you have concluded that dexamethasone is better than dexmedetomidine. Why
Yes,
so?
sir.
What is the reason you account for this? Why?
Sir, actually, the NRS score, what we have seen at 6 hours, 12 hours, and 24 hours, according to that, the score
why?
for
Why
we have concluded.
I am question why. No, yeah. Why that one drug is superior to the other?
So here I am studying, sir, why one drug is superior to other. So because it is
what is your reason?
Sir, the effect of the block is for longer duration. The NRS score at 12 hours for dexmedetomidine and also for 6 hours and 24 hours was better than dexmedetomidine. Dexamethasone was better than dexmedetomidine.
Okay. And your block was unilateral, no? Unilateral scalp block.
Yes, sir. We have decided for unilateral in chronic subdural hematoma.
Okay. Thank you so much. Thank you.
Yes, sir. Thank you, sir. Yeah.
Next one. Next participant, ma'am. Are you there? Siba Murugan? If he is not there, Arun Kumar Reddy Rachila. Arun Kumar Reddy. Are you there? Reddy.
Are you also not here? Next.
Then Baisakhi Priyadarshini Sahu.
Yes, ma'am. Am I audible? I'm present.
Yes, Baisakhi Priyadarshini will continue.
Yeah.
Ma'am, please share your screen. Now start a slideshow. We'll start your presentation.
Good afternoon, respected judges. Today, I'll be talking on the topic of comparison of intravenous and intramuscular low-dose ketamine to prevent postspinal shivering. Coming to the introduction, shivering is a syndrome involving involuntary oscillatory contractions of skeletal muscles. It is a physiologic response to cold exposure and body's next step in heat preservation after peripheral vasoconstriction. Regional anesthesia produces vasodilatation, which facilitates core to peripheral redistribution of heat, thus triggering vasoconstriction and shivering above block. Perioperative shivering is one of the frequent undesirable side effects, incidence being 40 to 60%. Although shivering may have beneficial thermoregulatory effects, it places body under increased physiological stress, increases oxygen consumption. It increases as well risk of hypoxemia, induces lactic acidosis, increases catecholamine disease. It can be of either type. Thermogenic, which is associated with hypothermia, and the most common type, it correlates with cutaneous vasoconstriction, whereas non-thermogenic, which is associated mainly with pain modulation and surgical stress, it correlates with cutaneous vasodilation and possibly with pain. Ketamine, a phencyclidine derivative and an NMDA antagonist, in low subanesthetic doses regulates temperature in multiple stages and prevents shivering by decreasing core to peripheral distribution of heat. It also has analgesic effects. It is one of the best agent in post-anesthetic shivering and only drug which can be given by all routes in the body. My study was a prospective randomized double-blind controlled trial. Inclusion criteria included ASA category 1, 2, and 3 patients aged 18 to 60 years undergoing infraumbilical surgery under spinal anesthesia after patient's consent and ethical committee approval was taken. Exclusion criteria were ASA category 4 and 5, known case of hypertension, any history of CNS disorder, patients in whom shivering was already present, and sample size of 30 was calculated. Patients were randomly allocated into two groups. Group V, containing 30 number of patients, received ketamine 0.5 milligram per kg by intravenous route, and group M, containing 30 number of patients as well, received 0.5 milligram per kg ketamine by intramuscular route. Spinal anesthesia was performed at the L3, L4 or L4-5 level using 0.5% bupivacaine heavy with 25 gauge Quincke spinal needle in sitting position under standard ASA monitoring. Ambient room temperature was maintained by setting the air conditioner temperature at 25 degrees Celsius. After block was achieved, 0.5 milligram per kg ketamine was given by either route. Grades of shivering and sedation were compared every 5 minutes for the first 30 minutes, then every 15 minutes till 60 minutes post-operatively. Patients who received shivering, experienced shivering even after giving ketamine were subsequently treated with IV tramadol 50 milligram. Coming to grades of shivering were compared as given by Mahajan et al., in which grade 0 meant no shivering, grade 1 represented piloerection or peripheral vasoconstriction only, grade 2 meant muscular activity in one muscle group, grade 3 meant muscular activity in greater than one group but no visible shivering, whereas grade 4 involved the whole body. Grades of sedation were compared as given by Shakya et al., in which grade 1 meant fully awake and oriented, grade 2 was only drowsy, grade 3 being eyes closed, arousable on command, grade 4 being eyes closed, arousable to physical stimuli, grade 5 being eyes closed and unarousable to physical stimuli. Coming to statistical analysis and results, frequency and proportion were used for analysis of categorical variables. Categorical outcomes were compared between study groups using chi-square test. P-value of less than 0.05 was considered statistically significant. Study groups were comparable with respect to age, gender, weight, and duration of surgery. The below table shows the demographic variables which were comparable in both the groups. Coming to incidence of shivering, in group M or the group which received ketamine IM, grade 3 shivering was found in 2 patients, grade 2 shivering was found in 1 patient, and in grade 4 shivering was found only in 1 patient. Whereas in group V, only 1 patient showed grade 3 shivering. P-value shows 0.16, which is greater than 0.05, so it is not significant. Coming to incidence of sedation, in group B, grade 4 sedation was seen in 9 patients, whereas in group M, only 2 patients showed grade 4 sedation, whereas in grade 3 sedation, group V showed 7 number of patients, group M showed 6 number of patients. Total number of patients having sedation in group V was 21 out of 30, whereas in group M, it was 13 out of 30. Coming to delirium, in group B, 57% of patients showed delirium, whereas in group M, only 27% of patients showed delirium. Number of patients experiencing nausea and vomiting were comparable in both groups. That is, nausea was present in 4 patients in group B and in 3 patients in group M. Discussion. Shivering is elicited when preoptic region of hypothalamus is cooled. Postoperative shivering is a phenomenon regulated by temperature or triggered by cytokine release induced by surgical procedures. Spinal anesthesia affects central and peripheral thermoregulation by enlarging the interthreshold range via the increasing the sweating threshold and decreasing the vasoconstriction and shivering thresholds. Results of this prospective randomized double-blind control study revealed that ketamine at dose of 0.5 mg per kg by intravenous route had similar anti-shivering effects as that of ketamine at a dose of 0.5 mg per kg by intramuscular route, but intravenous route of administration showed greater degree of sedation and was associated with more number of patients experiencing delirium. Where innumerable studies proving the efficacy of IV ketamine in prevention of post-spinal shivering has been done, not much has been studied about the intramuscular route. So present study focused on the occurrence and prevention of intraoperative shivering and only investigated single dose ketamine by alternate routes. My conclusion was that ketamine at dose of 0.5 mg per kg IV and similar dose IM had similar effects in prevention of intraoperative shivering, with the only drawback being a slighter delayed onset of action by intramuscular route, but giving the benefit of lesser side effects of higher grade of sedation and associated delirium that is associated with intravenous route. Thank you.
So just start the timer, please. So all the remaining presenters will be assessing your timing also. Stick to your time. Okay. Dr. Baishaki, what is meant by double blinding? How did you do? You said IM and IV, 2 groups. So
Yeah, ma'am. The double blinding means, ma'am, the observer as well as the investigator both do not know about the patient who is getting
observer and investigator.
Yeah, yeah.
Okay. What is triple blinding then? Okay, so we'll leave it there. What is there, you feel there is a difference in the site of action when ketamine is being given IM or IV? Or you feel
Yes,
it is the same?
Yes, of course, ma'am. There is difference as IV has a very rapid onset of action, whereas ketamine takes the duration of 5 to 10 minutes to act.
Site of action, I had asked.
Oh, site of action, ma'am. A site of action is same in both IV as well as IM.
You presented a consort flow chart for your study?
Yeah.
You haven't?
No, ma'am. No.
Simon, any question?
Yeah. You have chosen the same dose of 0.5 mg per kg, both for IM and IV. What is the reason for choosing the same dose in IM compared to IV?
Yeah, my study has actually basically focused on sub-anesthetic doses of ketamine and what is its role in intraoperative shivering. Before previous studies have already proved that IV ketamine at this dose and even lower, like 0.25 mg per kg, has a role.
That's not my question. My question is, why have you particularly chosen this particular dose for IM IV I understand, it's previously been done, but why have you chosen the same dose for IM and IV injections? That I cannot understand. Because IM route, you need to give a little bit more, isn't it? A little bit more should have been the dose to be comparable, and there should have been a sort of dose ranging study compared to the IV route to choose the actual what is the IM route, IM dose which is acceptable, which is causing most of the benefits without minimum side effects. That I think should have been done.
Okay, sir.
And yeah, so that is, I think, because you are doing a study which is comparatively new to you. So
Yes,
I think this is a point which I wanted to highlight this.
Yes, sir. Yeah.
Yeah. Okay.
Thank you, sir.
Okay.
Next one.
Next is Aparimit Pandey. Ma'am, Aparimit Pandey. Are you there? Aparimit Pandey. Next speaker is Surabhi Samant.
Yes, ma'am.
Surabhi Samant.
Yes, ma'am. Wait. One second, ma'am. Am I audible, ma'am?
Yes, yes.
Yes.
You're audible.
Good afternoon, everyone. I'm Dr. Surabhi Samanta. I am from IMS and Some Hospital. I am here to present anesthetic management in patients with SLE posted for laparoscopic cholecystectomy, a case series. My introduction. SLE is an autoimmune disorder where cellular and organ damage is mediated by tissue-binding autoantibodies and immune complexes. It is characterized by dysregulation of pathogenic autoantibodies that leads to multi-system chronic inflammatory processes. The incidence of SLE varies among ethnic groups and by geographic location, sex, and age. The ratio of female to male patients is 9:1. The most prevalent antibody commonly seen is ANA, anti-nuclear antibody. Among it, the most extensive ANA is anti-double-stranded dsDNA. And the other examples of ANA are anti-Rho and anti-La detected during pregnancy have been linked to fetal heart damage, as well anti-Smith antibodies, which is a marker of the kidney disease. Informed consent was taken for all the patients before surgery. According to the American College of Rheumatology criteria for diagnosis of SLE, the criterion being malar rash, discoid rash, photosensitivity, oral ulcers, arthritis, serositis, kidney disorder, neurologic disorders like seizures or psychosis, blood disorder like anemia or lymphopenia or thrombocytopenia, and a positive test for anti-double-stranded DNA, anti-Smith or anti-phospholipid antibodies, or a positive anti-nuclear antibody test. 4 out of these 11 criteria are needed for the formal diagnosis of SLE. Methodology. A thorough pre-anesthetic evaluation with proper systemic evaluation has been done. We present the perioperative management of 3 male patients with a history of SLE posted for laparoscopic cholecystectomy. In our series, choice of anesthetic technique used was general anesthesia. Pre-medications included glycopyrrolate and midazolam were given pre-operatively. Decision was made after taking into account the severity of the disease. All the patients were on immunosuppressants and antiplatelet drugs along with other medications according to additional comorbidities. Now coming to my case series, patient 1, 44-year male patient, associated conditions were hypertension, type 2 diabetes mellitus, and obesity. He was under the following medications: prednisolone 7.5 mg BD, hydroxychloroquine 400 mg OD, telmisartan 40 mg OD, ecosprin 75 OD, and he was on insulin for diabetes. Systemic evaluations, mostly he was under normal range, all systemic evaluations. On echo findings, there was concentric LVH with an ejection fraction of 64%. His RFT was on the higher side, serum creatinine being on 2.2 and a urea of 46. My patient 2, 31-year male patient associated with hypothyroidism. He was on thyroxine 50 mics OD along with prednisolone 5 mg BD, hydroxychloroquine 300 OD, and ecosprin 75 OD. And his TSH count was 3.6 and other blood parameters were under normal range. My third patient, 37-year-old male patient, who had anemia. His hemoglobin was 8.2. Preoperatively, 1 blood was transfused, which after that it came to 9. And on ECG, we had seen sinus tachycardia. The medications where he was on prednisolone, 5 mg OD, hydroxychloroquine, 300 OD, and ecosprin of 75. All the 3 patients were given general anesthesia maintained with isoflurane, intermittent opioids, and muscle relaxant. Cisatracurium was used. For patient 1, we found a difficult intubation. A 7 mm of ET tube was used instead of 8. Intraoperatively, steroid supplementation was done. For all the patients, multimodal analgesia was used. Blood loss and urine output monitoring were done. Furosemide injection and intermittent labetalol injection was used for patient 1. For patient 1 and 2, we had patient 1 and 3, we had uneventful extubation. Delayed extubation was seen in patient 2. For post-operative pain management, we had given subcostal tap block using 0.2% ropivacaine, 20 ml plus dexamethasone of 8 mg for early ambulation and adequate pain management. We come to discussion. Perioperative management of SLE patients must be tailored to individual patients. Difficult airway should be anticipated in all the patients. A smaller size tube and laryngeal mask airway must be available considering the potential laryngeal and the subglottic involvement. Non-erosive arthritis is seen in patients with SLE. Prolonged glucocorticoid use for immunosuppression could cause osteoporosis. Incidence of atlanzoaxial subluxation has been reported. Cardiac complications includes pericarditis, myocarditis, and pericardial effusion. Cardiovascular function tests should be assessed with chest radiography, echocardiography, and electrocardiography. Pulmonary complications included pleuritis, acute pneumonitis, recurrent pneumonia, and ILD. Pulmonary function tests and arterial blood gas should be done if respiratory symptoms are present. Lupus nephritis is a dreaded complication, although it's very common in SLE. Renal function tests should be done. The CNS complications included headache, seizures. It can vary from, it can also lead to demyelinating diseases. Hematological complications include anemia, thrombocytopenia, and leukopenia. Anticardiolipin antibody, lupus anticoagulant, anti-beta-2 glycoprotein, all causing APLA syndrome can be done to rule out any secondary involvement. Monitoring with ASA standard monitors and invasive monitoring to be used in patients with myocarditis or valvular involvement or conduction abnormalities. Renal protective strategies and calculation of urine output, avoidance of nephrotoxic drugs are the goals during anesthesia. Adequate pain management and corticosteroid cover should be given intraoperatively to prevent any adrenal suppression. Every effort should be made to maintain hemodynamic stability as these patients are prone to develop premature and accelerated atherosclerosis, which can lead to myocardial infarction intraoperatively. We come to the conclusion. SLE being an autoimmune disorder which requires a multidisciplinary approach, because of the complexity and the potentially wide-ranging clinical presentations of SLE, anesthetic management of patient is challenging. Careful anesthetic planning and intraoperative monitoring of all affected organs, particularly renal, pulmonary, and cardiovascular functions are required. SLE patients are at a significant higher risk for thrombosis, which is multifactorial, and coagulation profile should be checked before taking up for surgery. With proper understanding of the pathophysiology and the systemic organ involvement with SLE, these patients can be managed successfully. These are my references. Thank you.
In your first case, I wanted to ask what specific precautions you had taken in the patient one. You said there are some elevated renal parameters. Anything little bit different you had done?
Yes, ma'am. So he was not diagnosed before with his urea creatinine when it was done first. He had normal range. So this is after a few months when we did during our PAC, we advised for all the systemic evaluation. Then we found the creatinine to be 2.2. So we asked for a nephrology consultation for the same. Though we were advised to avoid the nephrotoxic drugs and the fluid intake to be limited. And that's all, ma'am. So we had intraoperatively, we managed accordingly. We avoided the nephrotoxic drugs. Diclofenac was avoided for anesthesia, like for pain management, and then urine output monitoring was done. And we had given Lasix to seeing the blood pressure and for the urine output. So it has been done, ma'am, for renal protective strategy.
Multimodal analgesia you used. You said you gave a block and fentanyl. Anything else after that, after tap block?
Ma'am, later post-op, ma'am, we had given tap block for early ambulation. And other than that, ma'am, we had analgesia. We had given, ma'am, paracetamol. 1 gram was given for TDS, and tramadol we had kept on rescue analgesia.
Hello. Don't you think that with steroid coverage, this requirement of analgesics would have been a little bit lesser in this patient?
Okay, sir. So, what analgesics we had used, I'll tell. During induction, we had used opioid, fentanyl was used.
No, did you use a comparatively lesser dose or the similar dose as you use in other cases?
So, like we avoided diclofenac for this first patient since he had a raised urea creatinine. So we managed with into opioids. So we gave a like higher dose opioid, not much, and we gave paracetamol along with it, and tramadol and paracetamol was given at one dose.
Okay. How much time did you follow these patients post-operatively?
Post-operatively, sir, we followed for a few days, 2 to 3 days.
There were no flare-ups in the post-operative period, any of them?
Sir, not much, sir. Like a few patients had like oxygen requirement because they had like difficulty in breathing, they were telling, but not specific, sir. On auscultation findings were nothing as much, sir. ABG was also on the like better side.
On a very short, so apart from what you have read in your books, what did you actually find when you did this case series? What was new to you?
Sir, maybe we'll say about the thorough pre-anesthetic checkup. Maybe we don't do so much of investigations for all like ASA grade 1 patients. For these patients, according to the systemic involvement, thinking that in our head, we went with the investigation pattern. That's all, sir.
Okay. Thank you. Thank you so much. Nice presentation.
Thank you, ma'am.
Hello?
Yes, you are audible.
Hello. Is it audible, ma'am?
Yes, audible. Start presenting, please.
Is my screen visible, ma'am?
Yes. Make it full screen. Yeah.
Good afternoon, judges. Today I'm going to talk about giving a paper on efficacy of buprenorphine 10 microgram per hour transdermal patch for postoperative analgesia in total hip and knee replacement therapy. Coming to introduction, effective postoperative pain relief is of utmost importance for patients. More than 80% of patients experience acute postoperative pain. 75% of these patients report it as severe in nature. Because of early ambulation, patients subjected to total knee and hip replacement need good quality postoperative pain relief. Despite multimodal approach and multiple drugs, opioids are still the mainstay for postoperative pain relief. Buprenorphine, as semi-synthetic thebaine derivative opioid, is 75 to 100 times more potent than morphine with less respiratory depression. Transdermal buprenorphine patch is homogeneously incorporated in a solid polymer matrix. It is applied to the skin. The drug is slowly and continuously released into the systemic circulation. It is non-invasive route. It provides sustained release of buprenorphine at 10 microgram per hour for prolonged period. It provides continuous uninterrupted pain relief. Therefore, is useful for post-operative pain management. Coming to materials and methods, after ethical committee approval and patients' informed written consents were obtained, 60 patients of both sexes, 40 to 70 years of age with ASA grades 1-2 were taken, scheduled for elective total hip and knee replacement surgery. After pre-anesthetic checkups and required investigations were done, selected patients were explained about the visual analog scale before surgery. Buprenorphine patch was applied on a clean, hairless area night before surgery. Tablet pantoprazole 40 mg and ondansetron 8 mg was prescribed. On the day of surgery, vital parameters such as heart rate, NIBP, and saturation oxygen were recorded, and level of sedation was monitored. Combined spinal epidural anesthesia was administered. At the end of surgery, a dose of local anesthetic was given and epidural catheter was removed. After surgery, the degree of pain in the postoperative period was assessed by VAS score at intervals of 4 hours for first 24 hours and then 12 hourly for next 7 days. Injection diclofenac 75 mg was given IM if VAS score was more than 5. Injection ondansetron
8 milligram was given for nausea, vomiting. Saturation oxygen, heart rate, and IBP and urine output were monitored. Patients were observed for any untoward effects. Coming to Ramsey sedation score, it is given as a score of 1 to 6. With a score of 1, patient is anxious and agitated or restless or bored. Score of 2, patients are cooperative, oriented, and tranquil. Score of 3, patient responds to verbal command. Score of 4, patients exhibits brisk response to light tactile stimuli or loud auditory stimulus. Score of 5, patient exhibits sluggish response to light, and score of 6, patient exhibits no response. Visual analog score is given as a score from 0 to 10, with 0 as no pain, 5 moderate pain, and 10 worse pain. In my study, I observed for visual analog score, Ramsey sedation score, saturation oxygen, heart rate, and IBP, need for rescue analgesia, and side effects like nausea, vomiting, and any other. Coming to statistical analysis, statistical analysis was done with the software SPSS 22.0 version. P-value less than 0.05 was considered significant. P-value less than 0.001 was taken as highly significant. Coming to demography, out of 60 number of patients, 42 patients are male and 80 number of patients are female. Regarding type of surgery, 43 number of patients underwent total hip replacement surgery, and 17 number of patients underwent total knee replacement surgery. Coming to statistic age of the patients, taken the minimum age of 40 and maximum age of 80, mean was 60.5 and standard deviation was 17.31. Regarding statistic weight of patients, taking minimum weight of 50 and maximum weight of 90, mean was 71.75 and standard deviation was 12.08. Coming to patients' response to VAS, 21% of patients complain of moderate pain, that is a score of 5 on second day, and around 12 number of patients complain of moderate to severe pain on 20 hours, 24 hours, and second day. This table shows the mean plus minus standard deviation in which the values are more towards the minimum side, and p-value was less than 0.001, that is highly significant at from 4 hours to day 6. Coming to rescue analgesia, mostly maximum number of patients needed rescue analgesia at 20 hours, 24 hours, and second day. Coming to Ramsey sedation score, 16 number of patients complain of anxious, agitated, and restless, that is a score of 1 at 24 hours, and maximum number of patients were have the score of 2, that is they are cooperated, oriented, and tranquil. Regarding side effects like nausea and vomiting, maximum number of patients complain of nausea at 12 hours to second day and third day, and only few number of patients had vomiting. Only 3 patients ages 65 to 70 years experienced respiratory depression, that is saturation oxygen less than 90%, and oxygen supplementation was given and they improved after 4 hours. 20 patients complained of nausea and 4 patients had vomiting. They improved with injection on densitron. In my study, no patients complained of itching or urinary retention. My result, time for first post-operative analgesic or diclofenac requirement was much delayed in both total hip replacement and total knee replacement surgery. And respiratory depression was more in patients more than 60 years of age. My conclusion, a transdermal buprenorphine patch 10 microgram per hour applied night before surgery can be useful post-operative analgesic for total hip replacement and total knee replacement surgeries. These are my references. Thank you.
You have divided THR and TKR in 2 groups, or you have combined both of them?
2 groups, ma'am.
Okay.
So did you do a subgroup analysis of these 2 groups, THR and TKR? Were the pain similar in both the groups?
Yes, yes, sir.
both the in TKR and THR, you
Yes,
know
I
of
was
a okay. Okay. What were similar? The pain and the buprenorphine, this rescue analgesic, they were similar in both the groups. What was your result regarding TKR and THR?
In both the cases, rescue analgesic was needed at around 20 hours and 24 hours.
No, in TKR it was more, or in THR it was more, the rescue analgesic requirement?
In THR it was more.
THR it was more.
Yes,
Okay.
ma'am.
How early did you mobilize the
So,
patients, and was there any pain on mobilization?
Yes, yes, ma'am. Actually, on the second day, mobilization, patients complain more of pain when on limb movement.
This was on post-operative day 1.
Post-operative day 1, yes.
Actually, Doctor, how will you classify your study? In a single thing, how will you say this is my study? This is my type of study. What will you say?
What is the type of study?
It's a descriptive type of study, ma'am. It's not a comparative study.
Okay.
Okay. Next.
Thank you, ma'am. Thank you, sir.
Yes, ma'am. Present, ma'am.
Are you there?
Yes, ma'am. Yes, ma'am.
Okay. Take your time.
Yes,
Yes,
start
ma'am.
presenting, please.
I'm Dr.
Make it full screen, no?
Good afternoon.
Dr. Rubinder, make it full screen, full screen.
Can you hear me, ma'am?
Right side bottom. Bottom right side.
Can you hear me, ma'am?
Yes, yes.
Hello.
Yes, yes.
So, I'm Dr. Rubinder from Shigra Medical College, Amritsar. Here's a study, a pilot study to
Make your
compare the
screen full
post-operative
screen,
anesthesia with
please.
epidural.
Make your screen full screen. We are not able to see clearly.
Please start slideshow.
Start slideshow from beginning. It is there, no?
Yes, ma'am. Yes, ma'am.
Now it's visible.
Please click on from beginning.
Yeah, okay.
Yes, yes.
Now it's good.
It's
Yeah,
okay.
start, please.
Okay. So here's a study, pilot study to compare the post-operative anesthesia with epidural ropivacaine with or without sulfate for oncological studies. So carcinoma breast is the most common occurring malignant worldwide. Post-operative after breast surgery is very debilitating and is associated with severe morbidity and delay in recovery time. So if it's not relieved in immediate post-operative period, then chances of it becoming chronic is very high. Thoracic epidural
It's a connection problem. Something.
entering this activity, which can provide analgesia for breast oncological
I'm not
surgery.
able to see the screen, Dr. Rubinder's screen. Is anyone else able to see?
No, ma'am. No, ma'am. Ma'am, please start sharing.
I think there's an internet problem. Her voice is also coming like cut. Alright.
Can you okay? Is it available now? Is it audible now, ma'am?
Audible, okay.
Yes,
Your screen is
audible,
not
but
seen.
we don't see your screen, ma'am.
Yeah, अभी दिख रहा है.
No, is it visible? ठीक है? Ma'am, is it visible now? I've shared the screen.
Yes, now it is visible.
Yes, please start a slideshow.
Okay. Can I? Okay. So aim of our study. Okay, fine. I'll do it from the- Aim of our study is to compare efficacy of epidural ropivacaine with or without magnesium sulfate for postoperative analgesia for breast cancer surgery. Our study is a prospective, randomized, interventional, double-blind study. It was done after obtaining consent from the patient and approval from the institution. Then we included female patients aged 30 to 70 years, ASA 1-2, giving consent for study. Patients with spinal deformity, local infection, unstable hemodynamics, bleeding, paresthesis, and respiratory, mental retardation, cardiac, renal, thyroid, hepatic, and CNS disorder, they were excluded from study. Allocation of groups. 2 groups of 10 each were allocated using SPSS software 20. These slips, they were put in sealed envelopes taken out by an independent technician who also prepared the drugs according to group allocation. So group R of ropivacaine, and 10 patients were included in them. They obtained 6 ml of 0.75%, make a final volume of 8 ml using saline through epidural route. And group N were given 6 ml of 0.7% ropin with 1 milligram per kg magnesium sulfate through epidural route to make final volume of 8 ml using normal saline. So patient were kept fasting overnight. They were given alprazolam before surgery, and they were reassessed on the day of surgery, and they were explained the numerical rating scale of 100. In the operation theater, standard IV line was connected, and the vitals were monitored. An epidural catheter that was inserted in T4, T6 or T10 to T12 level under all aseptic conditions and had supported and flexed. Then patient was observed for 5 minutes. Then the study drugs, they were injected via epidural catheter and observed for 15 to 20 minutes. Then the hemodynamics, they were noted and treated. Then general anesthesia was induced. Patient were induced with general anesthesia, and maintenance was done using oxygen, nitrous, iso, and VIX. And the hemodynamics, they were noted at induction, intubation, 5 minutes after interval for 30 minutes, and then 15 minutes after. And in the I was shifted to the recovery room. Then the vitals were noted, and in the recovery room, time was noted as 0 hour. And then patient was evaluated for 24 hours. Then pain was graded such in the NRS score of 0 as no pain and 100 as excruciating pain. Then in post-operatively, it was connected to the PCR with ropivacaine 0.1 to 5% at the time at the basal rate of 6 ml per hour with an activated bolus of ml and rocket time of 15 minutes. And then patient
What happened again? I'm not able to see any screen.
Ma'am, I think there is a network issue. Hello?
Yes.
Again, network issue. Can you proceed next if you see?
Yes.
Because we are always
Can you, now it's visible?
No.
Hello?
No, it's not
Hello?
visible.
Not yet.
Now it's visible?
Not yet.
Not yet.
Can I speak? Hello? Now it's visible, sir? I've shared the screen again. Then the side effects were noted. Statistical analysis was done. I'm going to share it again.
Share your screen.
Your screen is not visible.
Yes, ma'am. Trying it.
Some network issue.
Ma'am, please share again.
Yes, ma'am. Yes.
I think, ma'am, some network issue.
I think some network issue is going on. क्या करें? Dr.
Now it's
Simon will tell us to present, sort out her issue and present at the end. We'll continue with the others. What do you say?
Ma'am, is it visible now?
No, ma'am.
Not yet.
Shall we go to the next
Now it's
speaker?
visible, ma'am.
Ma'am, can we proceed next?
Yes, ma'am. Yes, ma'am. Is it visible?
Okay, okay. Thank you. Hello? Can I proceed now?
Yes, yes, proceed.
And then side effects were noted. Then statistical analysis. That was done. The data was compiled, decoded, compared, and statistically analyzed. And using a chi-square test, ANOVA, crosswalk, and a p-value of less than 0.05 was considered significant, and less than 0.01 was 001 was highly significant. So these are the demographics. Age, weight, and height of two groups was comparable. Then this is the pain scores at different time intervals, which was statistically significant at different time intervals. We have seen that patients receiving magnesium, they were having lower pain scores. These are the analysis chart. Red line shows the one getting ropivacaine and M getting magnesium. The duration of analgesia was more with magnesium group and less with ropivacaine group. Total dose of analgesia given was more in the ropivacaine group and less in the magnesium group. Blood pressure, heart rate, respiratory rate, and saturation. That was there was no major difference in both the groups. Then side effects noted. Side effect noted of nausea and vomiting and hypertension was more in the magnesium group than ropivacaine group. Rescue analgesia given was more in the ropivacaine group, but no rescue analgesia was demanded in the magnesium group. Ma'am, these were some studies. We have seen some studies like Kogler et al., Hossam et al., Muhammad and Behruz. They have used magnesium in their studies, and they have also seen that magnesium is having more analgesic action than using bupivacaine or ropivacaine. So in our conclusion, saying that the use of adjunctive magnesium in combination with local anesthetic provides operative analgesia, where local anesthetic unknown and is listed as low pain scores and low reduction of analgesia, significantly lower number of. Thank you. Can you hear me?
Okay. Yeah. Dr. Rubin there. Can you hear me?
Yes, sir. Yes, sir.
Yeah, actually, there was a sort of problem because we cannot view most of your slides and your voice was also crackled somehow.
Okay, sir. Okay.
Actually, one thing I just wanted to ask you was you chose the case of breast surgeries where the surgical procedure is similar in extent and duration. What were the surgical cases?
So these were the breast oncological surgeries. Most of them, like MRM cases, breast BCS cases, those were used. We have done this study. Actually, the thoracic epidural has been used in many surgeries, like thoracotomies and all.
No,
But
no. My question is a little bit different. If the surgery are not the same, the extent and duration of the surgery will be different, and
yes,
you are
sir.
choosing a particular same dose in each and every case, which may not be
Yes.
actually relevant for all the cases, isn't it? So that is my question. You should have chosen a similar surgical procedure. So breast cancer is a broad group of this sort of, there can be various surgeries as you have rightly pointed out. So I think you should have particularly said that MRM, I have chosen MRM or other sort of this sort of things. A particular surgery you should have chosen rather than this all sorts of clubbing it all together.
Okay.
Okay.
So actually,
That
what
I
we
think
have,
is a little
yes,
bit,
sir.
yeah.
Yes. So for that, what we have done
And
is we have given, we have started at 1.5 hour after surgery, 1.5 hour of surgery. We attach the PCA pump.
Okay. Okay.
So their initial dose is also the same. So after also we give the same dose.
Okay.
You
And
didn't use
PCA
any
you also
other
give same.
introp analgesia. You didn't give any other introp analgesia, you mean to say?
No, ma'am. No,
And
ma'am. No.
You started PCA.
Yes, ma'am. Yes, ma'am. No need of diclofenac or paracetamol.
You
nothing.
use T4 to T6 or T10 to T12?
Yes, sir. Yes, ma'am. That was done actually to avoid the lumbar curvature. Actually, that was the thing.
What is the
That's why
dermatome
we have
level
just
you need for breast surgeries to be covered?
thoracic dermatomes.
Tell which dermatomes.
Ma'am, T4, T5 level, T4 to T10 level. We can do it anywhere around.
T3, T2. What about T3 and T2?
Ma'am, we have not, ma'am, that's not some, we have used it.
No, I'm saying what was your aim? The dermatomes which you aimed.
Yes, ma'am. We aimed to cover the breast region for analgesia for the breast region.
Okay, let's move on.
We will go to the
Yes,
next
ma'am.
one.
Yeah.
Thank you. So the next people, whoever for, no, make sure you're in a place where your internet connection is good.
Next speaker is ready. Dr. K.S. Sukras, please start.
Yes, ma'am.
Your voice is also.
Am I audible, ma'am?
Sunida.
Ma'am, I'm Dr. K. Ashokra speaking. Am I audible?
Yes, yes, audible. Make it full screen, please.
Yes, ma'am.
Yes.
I have made it, ma'am.
Yes.
Is it okay, ma'am? Ma'am, can I start?
Yes, start.
Please
Thank
start.
you, sir. Thank you, ma'am. Good afternoon, my respected judges, faculty members, and others who are watching. Today I'm going to present my paper on a randomized triple-blinded clinical study to compare the peribulbar block characteristic of ropivacaine lidocaine and bupivacaine lidocaine combination in cataract surgeries. So peribulbar block, which is the most common regional block given in cataract extraction and intraocular lens implantation because it is safe with very few complications. Effective analgesia and akinesia is easily done, and in our cases, most of the patients are elderly and have multiple coexisting diseases. So regional anesthesia is better than GA. Till now, bupivacaine was mostly used in these operations. So, but as we know, bupivacaine has several case fatality reports which are reported, and there is a necessity for searching for an alternative agent. So our aim is to compare peribulbar block characteristics between a mixture of 0.5% bupivacaine with 2% lidocaine and another mixture of 0.5% ropivacaine with 2% lidocaine. So the sample size was calculated based on a population standard deviation of 1.4 with respect to the duration of the onset of the block. To detect a mean difference in duration of onset of the block of 1.2 minutes between groups, a sample size of 38 patients were required. But we rounded up the 38 to 40 patients and to count so as to counter any possible dropouts in the middle of the study. The total, as we are doing two groups, total 80 patients were selected. From them, written and informed consent was taken. The exclusion criteria we followed were patients with known allergy to the study drugs, patients refusing to local anesthesia, high myopia,
glaucoma, orbital anomaly, ocular infection, mental retardation, uncontrolled hypertension, coagulation abnormalities, patients with axial length of the eyeball more than 26 mm, posterior staphyloma, diabetes, and COPD patients. So basically, our 80 patients were divided into two groups of 40 each. One was named bupivacaine BL and another was named ropivacaine plus lidocaine, so RL. So group BL received 4 milliliter of 0.5% bupivacaine and 4 ml of 2% lidocaine and 100 international units of hyaluronidase. And similarly, group RL received 4 ml of 0.5% bupivacaine and 4 ml of 2% lidocaine and 100 international units of hyaluronidase. The total volume administered was 8 ml. So NPO was done, and pre-medication with alprazolam and ranitidine was done before the night. So here, patient anesthesiologist and data entry operator were blindfolded, and peribulbar block was done. Sensory block and motor block were assessed. For motor block, eyeball movements and eyelid movements were assessed on a 3-point scale. So for a successful block, the total duration of the sensory block was taken by the time between successful block and first request for patient first request by the patient for pain relief. So for surgery, a total ocular movements score 0 and total eyelid movement score 0 was taken. Parameters noted were time taken to attain adequate surgical anesthesia, total volume of supplementary injections, time for rescue analgesia, and total analgesics in first 24 hours. So doing this, the statistical analysis we got is in two groups, bupivacaine, lidocaine, and RL group. We found that both are basically similar, and p-value was more than 0.05. And this is the bar representation of the same diagram, the same table, and the results are the block characteristic we got. The parameters were onset of sensory block, motor block, lead akinesia, supplementary injections taken, time of rescue analgesia, and total analgesia given. Here also, the parameters of two groups are found to be nearly same. This is the bar and whisker representation of the same table, and the time to adequate surgical block was similar in both. And we conclude that 1:1 mixture of ropivacaine 0.5% and lidocaine 2% in a volume of 8 ml with 100 ml 100 international units of hyaluronidase is same and is same effective as 1:1 mixture of bupivacaine and lidocaine in a volume of 8 ml taken with 100 international units of hyaluronidase as regards onset of duration of block, side effects, and hemodynamic changes. Future studies can be designed to test whether a quicker onset of the block can be obtained by employer aiding either a high volume of anesthetic mixture or a dual injection technique at two different quadrants, that is infratemporal and supranasal quadrants. And these are the references that I have taken. Thank you.
Hello.
Yes, sir. Yes, sir.
Yeah. Why did you choose the same dose of ropivacaine as that of bupivacaine? Are they equivalent in dosage?
Yes, sir.
They are equivalent. No, once ropivacaine and bupivacaine are equi-analgesic in the same dosage.
Yes, I mean nearly same. That's all.
Okay. And why was a mixture used? Why not separately only bupivacaine and only ropivacaine?
Sir.
Because if any problem happens, you cannot point out this is because of lignocaine or bupivacaine or ropivacaine separately, isn't it?
Sir.
Okay. Thank you. Madam, you have any questions?
What were the side effects you had seen, Dr. Ashok?
I mean, there was some hemodynamical changes during bupivacaine that we have noted, ma'am.
In which group additional injections were needed?
Ma'am, in those patients in whom there was inadequate analgesia or akinesia of
No, which group needed more additional
bupivacaine,
injections, if at all?
in bupivacaine and lidocaine group. In
Propivacaine. I'm not able to hear.
bupivacaine.
Bupivacaine. Okay.
Yes, ma'am.
And what do you contribute it to? Why do you feel you had more requirement?
And the potency maybe little bit less, or in those patients maybe the delivery of the drug was little bit
Okay. Thank you. Next one.
Thank you.
Our
Thank you.
next presenter is Charan Kisku. Next
ma'am.
presenter is Charan Kisku.
Charan, please share your slide.
Yes, sir. Am I audible, sir?
Yes, you are
Yes,
audible.
Yes.
Should I start, sir?
Full screen.
Your screen is seen. Make it full screen.
Okay.
Yes, start please.
This is visible?
Yes, start. Start the
Yes,
timer, please.
Good evening, respected judges. I am going to present my topic, comparison of early postoperative recovery between laryngeal mass airway and endotracheal tube in laparoscopic cholecystectomy. So, introduction: laparoscopic cholecystectomy is the most minimal invasive surgical technique for benign biliary diseases. Usually, pain, nausea, vomiting, and pulmonary complications increase the mortality and morbidity of the patient during hospital stay. So, duration on a hospital stay can be reduced by the early mobilization. So, after approval from the ethical committee, study was conducted at MKC Medical College, Barampur. 60% posted for laparoscopic cholecystectomy and the GU were selected and included in this study. Informed written consent from them were taken, and patients are divided in two groups: Group L for LM and Group E for ET tube, and randomly comprised of 20% each. So 60% are assessed, and out of 4 are excluded due to difficult airway and short neck and loose teeth, and 56 are taken under randomization, and 28 of which are allocated in LMA and ET tube respectively, and all are followed and analyzed for the study. So in Group L, I studied with second generation LMA, that is double lumen LMA, and was given with respective size according to sex and weight, and appropriate size of ETT tube was given according to the age and sex in Group E. So my duration study is 4 months and carried out from November 2020 to February 2021. And in my inclusion criteria is 20 to 65 years, ASC grade 1 and 2, and both male and female are included. In exclusion criteria, patient of ASC grade 3 and 4, and patient with having chronic smoker and other respiratory diseases and difficult airway and patient refusal. So before the surgery, all patient PSC are done and advised for anxiolytic with aprazolam 0.5 mg, and night before surgery, and with ranitidine 150 mg orally. And before the surgery, before the OT, and all patients are pre-medicated with before 30 minutes with midazolam 0.3 mg per kg, and glycopyrrolate with 0.004 mg per graduate, and butorphanol with 0.03 mg per kg IV. And please oxygenation with 100% oxygen for 3 minutes, and induction with injection propofol 2 mg per kg IV, and intubation LM insertion with injection bacterinium, it is 0.08 mg per kg IV route. And ventilation maintained with control mode with the FiO to 50% and tidal volume 8 ml per kg bed. And anesthesia maintained with oxygen and nitrous at the rate 1:2 and acetone 1:2%. And injection paracetamol 1 gram given IV route through before the induction of Veress needle. And heart rate, system blood pressure, peak air pressure, and these were recorded at 5 time points during our study. First before anesthesia, and second after insertion of airway device, and third initiation of neoperitoneum, and fourth stopping of neoperitoneum, and at the end of surgery. So LMA core pressure was maintained between 30 to 60 centimeter of water, and ET tube core pressure maintained between 20 to 30 centimeter of water with measure with cup manometer, and systolic blood pressure more than 160 treated with nitroglycerin in given dose, and heart rate more than 120 beats per minute treated with Tismolol in given dose, and heart rate less than 50 beats per minute treated with atropine 0.6 mg IV, and reversal done with glycopyrrolate 0.5 mg and neostimulant 2.5 mg with IV route. After shifted to the PSU, postoperative pain was assessed using a numeric scale, that is NS 1 to 10, that is more than 4 was treated with nalbuphine, 0.3 mg per kg, IV and ESS every 10 minutes. Nausea, vomiting, aspiration, coughing, hoarseness, and dyspnea, sore throat was assessed during the first 1 hour postoperative in the recovery room and until post-op day 1. In statistical analysis, all data were tested for normal distribution. 2 groups are examined using chi-square test, independent test, and all data were performed using spaces version 24, and two-sided alpha 0.05 was used for all statistical tests. In my result, there was no case in which placement with the airway device fell within 2 attempts. The use of LM led to improve hemodynamic and respiratory stability and less restricted mucosal clearance and reduced the dose of anesthetic drug in comparison to T2. So more patients in E group experienced coughing during anesthesia experience emergence than in L group. And comparing the E and L group, peak air pressure was higher in the E group after the insertion of devices and after induction of the pneumoperitoneum, but was not significantly different. Before and after pneumoperitoneum, oxygenation and ventilation were optimal in all patients in both groups, and there was no significant difference in patient characteristic and surgical data. This is table showing where peak air pressure after intubation and peak air pressure after pneumoperitoneum is not significant. The mean pain score during the first one postoperative and high pain score until the postoperative day 1 were lower in L group than the in E group. So there is no such difference in dose of rescue analysis in both L and E group. So graph showing there is the pain score is similar in both groups, and the total analysis dose required also almost similar in 2 groups. So post-op outcome data in post-op day 1, day 0 and day 1, the post-op outcome data was lower in L group, that is mainly nausea, vomiting, sore throat, and hoarseness and dyspnea, and both are in day 0 and day 1, lower in L groups. So incidence of high BP and tachycardia was lower in L group in comparison to E group. The frequency of visual nitroglycerin and atropine during surgery was also lower in L group. So the graph showing where the heart rate and systolic BP are more in after the insertion of airway devices with the similar B's between the 2 groups. So satisfactory showed a measure in after 1 hour of surgery to the discharge. There is more satisfactory result in L groups. So discussion second generation LM was effective as an ET to maintaining pulmonary ventilation without disturbance in peak air pressure. From our finding, we believe that the stimulation from VT stimulation for VT to make was hemodynamic variation at the time of starting and at the disconnection of pneumoperitoneum. The primary issue in the LMA during laparoscopic surgery has been gastric distension, pulmonary aspiration, and of gastric content and inadequate ventilation. In our study, peak air pressure is maintained between the 3 and 8 centimeter water. In addition to that, second generation LMA has designed with large volume conduit with gastric access for through which Riles tube was placed during the surgery to prevent aspiration. So there are some limitations in our study. The satisfactory cushion were administered at the time of discharge from the recovery room. We did not measure the rate of carbon dioxide insufflation and the aspiration pneumoperitoneum after surgery. However, the insufflation pressure was maintained within the 12 to 14 mm in same surgical flow. We enrolled patients who were non-cardiovascular compression, otherwise healthy. So we concluded that the frequency of immediate postoperative pain, nausea, sore throat, and hoarseness was lower in patients in whom the second generation LM was inserted compared with ETTM laparoscopic cholecystectomy. So thus using an LM in a multimodal approach may contribute to establishing early postoperative recovery from the laparoscopic cholecystectomy. These are my references, and thank you.
Nice presentation, Dr. Kisku. Can you hear me? Yeah.
Yes, sir.
I just wanted to know, did you compare the ETCO2 values in the 2 groups?
No, ETCO2 value is maintained between 35 to 45 between 2 groups.
No, you didn't actually compare the ETCO2 value in the 2 groups.
No,
And
sir,
another question is, you mentioned, yes, another question was, you mentioned that you did a control ventilation. What control did you use? Volume control or pressure control?
Volume control.
Volume control ventilation. Yes. And did you use the nasogastric tube?
Yes.
In both the groups?
Yes, both the groups.
Nasogastric
tube is in both the groups.
Okay. So what did you find this ease of insertion with this in place? You did it previously or after you put in this devices, aero devices?
Actually, we just tried separately. in which I have tried 2 attempts in LMA groups, and then I switch over to ET tube. But after 2 insertions, if it is successful, then I included in the study.
This LMA you said was Pro-Seal LMA or
No,
classic
this
LMA?
is this second generation double lumen LMA.
Okay,
which
fine.
was we are using in our hospital.
Okay, fine. How do you determine the size of an LMA? You said in one of your slide based
According
on
to
weight
age
and
and
sex.
weight, age and weight.
Huh?
LM is determined according to age and weight. Sorry, sex and weight.
Based on?
Sex and weight of the patient and according to sex.
Okay. And you said hypertension, immediately you had used nitroglycerin. You didn't rule out
Yes,
other
madam.
causes of nitroglycerin and tachycardia. You immediately started off nitroglycerin and esmolol.
Yes, simultaneously I treated with esmolol. If more than heart rate 120, then simultaneously I treated with esmolol.
Thank you. Next one. Okay. Thank you, Dr. Chan.
Our next presenter is Minal M.
Yes, ma'am. Am I audible, ma'am?
Yes, yes. Please start sharing screen.
Is it visible, ma'am?
Yes, yes, visible.
Good evening, sir. Good evening, ma'am. I'm here to present. I am Dr. Meenal from IMS Some Hospital. I am presenting today the study of relationship between mentohyoid distance and Cormack-Lehan grading in airway assessment. About the study, an important aspect of airway management is assessment of patient's airway to predict the likelihood of ease or difficulty with bag and mask ventilation, making difficult laryngoscopy and intubation, enabling the anesthesiologist to prepare for the challenging clinical scenario. Measuring the mentohyoid distance is one of the components in airway examination to predict difficult airway. This is a non-invasive parameter and provides an estimation of submandibular space, which is measured during pre-anesthetic checkup. My aim being, the present study is conducted with the aim of finding the relationship between mentohyoid distance and Cormack-Lehan grading. My primary objective being to study the relationship between the mentohyoid distance and Cormack-Lehan grading in airway assessment, and the secondary objective being to find out the time taken for the laryngoscopy and intubation. Coming to inclusion criteria, age 18 to 60 years for both sexes requiring general anesthesia who are planned for elective surgery and they require endotracheal intubation, and ASA 1 and 2 patients, and refusal by the patient to participate in the study, ASA 3 and 4 patients with any features of difficult airway such as maxillofacial anomalies, restricted neck movements, obesity, and limited mouth opening. Patients with unstable cervical spine and tumor of the larynx were excluded in the study. Coming to methodology, the procedure was carried out after routine pre-anesthesia evaluation and after obtaining the informed consent. All the patients were assessed pre-operatively on the day before surgery, and mentohyoid distance, that is the distance between the body of the hyoid bone and the tip of the chin in the midline with the head in flexion. With the head in extended and measured in centimeters was measured. In the operating room, IV line was secured and standard monitors were attached. The patient was placed in sniffing position. The patients were given pre-oxygenation, pre-medication, and IV induction agents. After confirming bag and mask ventilation, muscle relaxant was given. Laryngoscopy was done after 3 minutes of ventilation. Cormack-Lehan grading and time taken for laryngoscopy noted. The measured mentohyoid distance was correlated with Cormack-Lehan grading. This is the Cormack-Lehan grading. As we know, grade 1 is the entire glottic view we can see. The posterior commissures are seen and the entire length of the vocal cord is seen. And coming to grade 2, posterior commissure is seen and only the part of vocal cord is seen. And 2B, only the posterior commissure is seen. And grade 3, only the epiglottis is seen. And grade 4 is only the root of the tongue is seen. So coming to my observation, sample size was calculated based on the clinical observations by making the mentohyoid distance is more or less around 4 centimeter, keeping 4 different groups, that is Cormack-Lehan grading group 4 groups, and assume standard deviation as 2. The sample size is identified as 25 per group, more or less, where the power of test is 98.6. So in our study, out of 100 patients, 67 were male and 33 were female, in which 12 patients had Cormack-Lehan grading 3 and 33 patients had Cormack-Lehan grade 2 and 45% of the patients had grade 1 and none of the patients had Cormack-Lehan grade 4. And coming to mentohyoid distance, 12 patients had mentohyoid distance of less than 4 centimeter and 87% had between 4 to 6 centimeter and 1% more than 6 centimeters. Coming to statistical inference, assuming null hypothesis, mentohyoid distance is same between the Cormack-Lehan grading. Alternate hypothesis being mentohyoid distance is not same between the Cormack-Lehan grading. So based on t-test, inference is drawn. Since t is less than 0.01, p-value is less than 0.01, we do not accept the null hypothesis, and hence there is a significant difference in mentohyoid distance between Cormack-Lehan grades. So here I'm comparing the Cormack-Lehan 1 and 2, 1 and 3 and 2 and 3 groups. So coming to 1 and 2, the average mentohyoid distance in 1 is 4.82 centimeter and time taken is 11.46 seconds. And coming to Cormack-Lehan 2 average 4.2 centimeter and time taken is 17.18 seconds of p-value less than 0.01. Coming to 1 and 3, 1 with average of mentohyoid distance 4.82 centimeter and time taken for intubation is 11.46 seconds. Cormack-Lehan grading 3 average being 2.79 centimeters and 46.08 seconds time taken for intubation with p-value less than 0.01. Coming to 2 and 3, 2 average is 4.2 and time taken is 17.18 seconds, and 3 average being 2.79 and time taken is 46.08 seconds, p-value less than 0.01 seconds. So this is the graphical representation. As we can see, mentohyoid distance in centimeter is plotted here. The gray color being the Cormack-Lehan grading 3, which is having the mentohyoid distance less compared to 1 and 2. And here, mentohyoid distance and the time taken, average values are plotted. So this is the Cormack-Lehan grading, mentohyoid distance 1 average, 2 and 3 average with time being plotted. We can see here the Cormack-Lehan grading average is 2.79 and the time taken is 46.08 seconds. And this is the pie chart representing Cormack-Lehan grading percentage of 3 being 12%, 1 being 45%, 2 being 33%, and CL grading 4 has none of the patients had CL grading 4. That is, patients with mentohyoid distance less than 4 centimeter had poor CL grading 3 with prolonged time taken for intubation. Discussion and conclusion. Direct laryngoscopy is the gold standard for tracheal intubation. There is no single definition of difficult intubation. Difficult glottic view on direct laryngoscopy is the most common cause of difficult intubation. From our study, we can correlate mentohyoid distance with CL grading. As mentohyoid distance decreases, the mandibular space decreases, making difficult laryngoscopy and prolonged time taken for intubation. Our study concludes that measuring mentohyoid distance during pre-anesthetic checkup plays a major role in predicting difficult airway and can be considered as one of the important predictor in airway assessment. My references are these. Thank you.
So did you analyze for other confounding factors? Maybe other measurements would have caused the CL grading difference, or did you take only this single measurement?
Ma'am, actually there are many predictors, ma'am. In my study, I took only the mentohyoid distance, ma'am.
No, I'm saying after your analysis, did you do a regression analysis to see any other confounding, any other factor is there?
No,
so
ma'am.
You should have taken those measurements and seen. No? How do you say it is only mentohyoid?
Yes, ma'am.
Not done.
Yes, I also agree with madam that there are certain statistical deficiencies in your study, like
Okay.
this correlation, the ROC curve you have not done. This is very important. You had totally missed it. Then also the negative predictive value of this, what you are saying, sensitivity,
Sir,
specificity, all these need to be done, because to come to this conclusion without this particularly the within putting it in the ROC curve, and to do that ROC curve you need this sensitivity, specificity, all these things.
sir,
So
actually, if more than 2 or 3 parameters, if we take, we can do the sensitivity, specificity.
You should have done. See how much time does it take to do all your measurements? It doesn't take much time. You're
No,
anyway
sir,
doing
no.
in your
Yes,
PhD.
ma'am. Yes, ma'am. You're correct, ma'am.
You should have actually taken all the measurements and correlated each one of them.
Yes.
That would have been good. And then you will say which one correlates best with CL grade.
Okay, ma'am. All the parameters like pyrometric.
So if you have already taken in your study, you can do as well now again reanalysis, and then it will be a good one.
Okay, ma'am.
Okay.
But still, if you find something, you have to see the confounding factors also.
Okay, ma'am. Actually, I took only one parameter. That is the. Okay, ma'am.
Yeah.
Thank you, ma'am. Thank you, sir.
Thank you.
So the last presenter of this session is Rahul Ojha.
Yes, ma'am. Present, ma'am. I shall share my screen.
Yes, share please.
Shall I start, ma'am?
Yes, start, please.
A very good afternoon. I am Dr. Rahul Ojha, a second-year postgraduate student, here to present my topic, that is monitoring of the neuromuscular block after administration of vecuronium in patients with diabetes mellitus. Coming to the background of my study, the function of the motor nerve fibers and the nerve endings are impaired in the patients with diabetes. So there may be partial degeneration or segmental demyelination of the nerve fiber that lead to decreased conduction velocity. So it is likely that the stimulating current at which a response might occur and the onset and recovery from the neuromuscular block will differ from that of the non-diabetic group. The study was undertaken to investigate these variables when vecuronium was anesthetized in patients with type 2 diabetes mellitus. Coming to the aim of my study is to monitor the neuromuscular block after administration of vecuronium in patients with diabetes mellitus. Coming to the material and methods, 60 subjects were taken into my study sample, from which 30 patients were divided among the diabetic and non-diabetic group. Which among the 30 patients, they were randomly divided to the post-tetanic count group and the patients for the tail of 4 measurements. And similarly for that of the control group. Now, the age of 18 to 60 years of patients of both sex and the patients with type 2 diabetes mellitus were included in my study. And the patient who refused for the procedure, the patient who are pregnant or in a lactating woman, patient with any psychiatric disorder, patient with a muscular dystrophy or with any history of neuropathy or past history of any decay or HSS syndrome are excluded from my study. Okay, now after the patient arrives to the OT, the pre-medications were given to the patient and the 2 stimulating electrodes were positioned over the ulnar nerve at the wrist, and the 2 recording electrodes were attached to the adductor pollicis muscle. After the induction, the TO of stimuli was applied to the ulnar nerve by an electrical nerve stimulator of neuromuscular transmission module. The 4-to-each stimuli of 0.2 millisecond was applied at a 2 Hz. Then we start searching for the supramaximal current. For this, the stimulating current was increased at a 5 milliampere until there was no response. The stimulating current was automatically increased to 15% of the value to produce a supramaximal current. If the supramaximal current was not found, or if the current was the current was set as 70 milliampere. Once the supramaximal current was established, the electromyography response of the first response was considered as the control value, which is T0, and then the value of T1 was determined after 15 minutes. Following this, the vecuronium was administered to facilitate the tracheal intubation. Following the wake administration, the PTC was measured every 5 minutes in diabetes and control group.
The number of detectable electromagnetic response to a single stimuli, also known as the post-tetanic count, the time from which the administration of the return of the post-tetanic count was compared to that of the control group, and each PTC was measured in every 5 minutes and compared between the two groups. The time for vecuronium to return to the response to be note was measured in every 5 minutes and compared of the control group in every 15 minutes. After the dose of vecuronium, the T1 to T0 response and the T4 to T1 response was recorded in every 15 minutes. Now, coming to the statistical analysis, the patient characteristics was compared by a Kursal-Wallis test and Mann-Whitney U test. The sample size was determined by the power analysis. The stimulating current, the time to return to times of the return of the first post-tetanic count, the return of the Taylor 4 responses were all measured by Mann-Whitney U test, and the T1 to T0 ratio and the T4 to T1 ratio between the diabetes and the control group were compared by the Kursal-Wallis test followed by Mann-Whitney U test. The p-value of less than 0.05 were considered to be statistically significant, and the statistical analysis was performed by the SPSS. Coming to the observations of my study, all these demographic parameters were included. The duration of the diabetes of the patient with supramaximal stimulus, the first post-tetanic count that to appear, and the Taylor 4 responses that has been measured every 15 minutes, the ratio of the T1 to T0 in every 15 minutes, and fourth response to first response to measured in every 15 minutes. Now, coming to the results of my study, the patient characteristics like the sex distribution, age distribution, and the weight distribution did not provide any statistical significance between the control and that of the diabetic group. But coming to the supramaximal stimulus, we can clearly see that the supramaximal, comparing the current, the one among the diabetic group requires a higher current to produce a response than that of the non-diabetic group. Comparing to the PTC, return of the post-tetanic count, and over that of the other for post-tetanic counts over the time, we clearly see that there is no difference among the diabetic and that of the control group, whereas in subsequent counts appeared on the subsequent time, we can clearly see that the control group have a larger count than that of the diabetic group. Coming to the return of the Taylor 4 responses, we see that the response appeared more earlier in that of the control group than compared to that of the Taylor 4 in the diabetic group. But when the comparison was similarly made between the first and the control response, we see that the control response was more in case in the control group, the ratio was more as compared to that of the diabetic group. Now, coming to the T4 to 4th comparison to that of the first response ratio, we see that the 4th response also in the control group was much higher in ratio as compared to that of the diabetic group. Now, these are the things I've discussed. Now, coming to the conclusion of my study, when the neuromuscular block is monitored in diabetic patients, the supramaximal current is more than in case of non-diabetic patient. The onset of the neuromuscular block and the time of recovery of the first post-tetanic count are similar between that of the non-diabetic group receiving vecuronium. However, the time from the administration of vecuronium to the receiving the Taylor 4 response is significantly longer, and the recovery of the T1 to T0 is significantly slower than that of the non-diabetic group. These findings may result because of marked impairment of the post-junctional region nerve endings in the neuromuscular junctions of the diabetic patients. Okay, thank you, ma'am.
Nice presentation, Dr. Rahul.
Thank you, sir.
Yeah,
Actually,
actually,
questions.
yeah. Did you measure this body temperature of the patient?
Yes, sir. The body temperature was normal in the patients. So few patients have the patients have observed in it. The body temperature was normal.
Now, do you? Why I am specifically asking this question?
So
Can you guess?
So the muscle response in patient with hypothermia, that can be a delayed response of the response.
If the patient is sweating or something, is any what sort of this neuromuscular technology did you use? With
Sir,
TOF and
electromyography, sir.
electromyography. And so if there is tremendous sweating, is it going to affect the patient's reading?
Yes, sir. The impedance will be that will be
Yes,
changing the
impedance.
impedance.
Okay. So during the recovery, what sort of TOF did you use as a recovery cutoff? That patient has a total recovery from the neuromuscular block. You have taken a TOF of what?
Sir, the recovery, the TO value more than 0.9, the patient was actually recovering. The 0.7 and 0.8.
Okay. Okay. 0.9, more than 0.9. Okay.
Yes.
Yeah. And just another question: did you do any NCV studies previously before on the patients before conducting the study?
Sir,
Nerve
sorry,
conduction
sir.
velocity study.
No,
Nerve conduction velocity.
No, sir. No, sir. Sorry, sir. We didn't did that.
You didn't do it.
No,
Okay.
no, yes.
Okay.
Can we proceed for next session?
Thank you. Thank you. Thank you.
Thank you. Thank you. Hello. Just to confirm, this session is over, no, ma'am?
Yes.
Yes.
Okay. Thank you so much.
We are
Thank you.
extremely thankful
Putting
to
the slide, madam. It's okay, madam.
We are extremely thankful to Dr. Vijay Lakshmi and Dr. Suman Chatterjee for excellent judging and a good guidance wherever the student fell in short. And
Thank you so much.
Thank you. Sparing such valuable time. Smita, would you like to conclude? Smita?
Yes, madam.
Yes.
Now we have come to the end of this session. So as madam said, we are extremely thankful to both our esteemed judges for conducting the session so well. Thank you once again.
Thank you.
Thank you, everybody.
Well organized and well conducted. Thank you.
Hello. 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 Shall we start the next session?
Yeah, Kalyani, you may start the session.
Yes, start.
We have Dr. Vidya and Dr. Narmada, I think. Narmada is
Am I
there.
visible?
Yes, ma'am, I'm there.
She said she would be here somewhere.
I'm there, ma'am.
Yeah,
I'm there too, yeah.
You're not visible. You're not visible.
Vidya,
Narmada,
am
you
I
are
audible?
Okay, ma'am.
Please come. And the moderator of the session is our associate professor, Dr. Kalyani Bala Naik. She will be moderating this session and will be introducing the judges. Dr. Kalyani, please.
Am I audible and visible?
Yes, very
ma'am.
much.
A very good afternoon to all of you and welcome to this Prasanna Misra poster presentation session. This is PK Misra poster presentation session, and previously there was a poster competition, but that was not named after Dr. PK Misra. Since 2019, it has been named after Dr. PK Misra. As you all know, PK Misra is an eminent anesthesiologist who has worked inside the state and also outside India. And I am extremely thankful on behalf of ISA ODISHA. I am extremely thankful to Dr. Prasanna Misra for his contribution to encourage the research and poster presentation activities of the postgraduate students. Thank you, sir, on behalf of the ISA ODISHA. Next, I'd like to welcome and introduce our judges, Sri Vidya, who is very close to my heart, and Dr. Narmada Padi. She is also very close to us, and both of them have first. I like to introduce Dr. Sri Vidya. She has completed her MD and MBBS from SCB Medical College, and now she is working as senior consultant in Department of Anesthesiology, Tata Main Hospital, Jamshedpur. And our next judge is Dr. Narmada Padi. She has also completed her MD from this SCB Medical College and Hospital, and now she is working at Additional Professor, Department of Anesthesiology and Critical Care, Nizam's Institute of Medical Sciences in Hyderabad. So welcome both of you to this session. And there are 10 posters in this sessions. Out of all the participants will get 3 minutes for presentation and 2 minutes for discussion. I request to all the judges, please stick to the time as we are already lagging behind the time. So our first speaker is, I'll invite the first speaker.
I think first speaker is not ready yet or has not been let in.
Can we proceed next?
Who is the next speaker? It is not coming in my
Shri
screen.
Haripriya Behra. Shri Haripriya Behra.
Yes, ma'am, I am there.
Okay. Okay.
Okay, you start
can share
presenting.
your screen, please. Yeah. And go to.
Ma'am,
Yeah.
my
Go
screen
to,
is visible.
Yes. Yes. You're visible. And go to full screen mode, please. Yes. You can start. Can we have the timer on, please?
It's on, ma'am.
Yeah, I'm not able to see
Good
it.
evening, everyone. Myself, Dr. Srihari Priya Behra from the Department of Anesthesiology and Critical Care, AIMS, Bhubaneswar. My topic is influence of 3% hypertonic saline versus normal saline on the maintenance fluid requirement in adult patients undergoing major abdominal surgeries, a randomized triple-blinded trial. The ideal fluid strategy for maintenance fluid requirement remains a major challenge in abdominal surgery. Here I would like to cite a few articles. According to Silva Jr. et al. From Critical Care, a net gain of 550 ml of intraoperative fluid has been shown to be associated with increased complications like tissue edema and poor wound healing. Whereas according to the RELIEF trial in NEGM, restrictive fluid strategy is associated with AKI and reduced organ perfusion. Therefore, now coming to the question, why hypertonic saline? We all know hypertonic saline is being routinely used for traumatic brain injury patients as it decreases the cerebral edema. Its mechanism being it acts as an osmotic buffer in the intravascular lumen and draws the fluid from extracellular space into the intravascular compartment. So keeping all the above findings in mind, we will hypothesize that administration of hypertonic saline will reduce the intraoperative maintenance fluid requirement by at least 500 ml. My primary objective is to see the difference in the maintenance fluid requirement between the two groups, hypertonic saline and normal saline. And secondary objectives were to see the difference in the post-operative 24 hours fluid requirement, C-reactive protein, TLC count, lactates, serum creatinine, and serum sodium level. Based on previous studies, sample size of 100 was calculated with 50 patients being in both hypertonic and normal saline group. Adult consenting patients ASA 1 and 2 with normal KFT undergoing major abdominal surgeries were randomized to receive the infusions of either HTS or normal saline at the rate of 1 ml per kg per hour. Both HTS and NS were administered through large wide-bore peripheral cannulas or through a central venous catheter if inserted. The intraoperative maintenance fluid were administered to maintain the standard targets of mean arterial pressure of 70 to 110 mmHg, urine output of 0.5 to 1 ml per kg per hour, and central venous pressure wherever monitored at 8 to 10 mmHg. Relevant data were collected by the blinded investigator. Interim analysis of 81 patients are presented here, 39 in the HTS and 42 in the normal saline group. There was no difference in the primary outcome of intraoperative fluid requirement between both the groups. Also, there was no difference in the 24 hours post-operative fluid requirement in both the groups. Post-operative creatinine, lactates, and C-reactive protein were comparable. The only significant finding was difference in the serum sodium level at 12 hours and 24 hours post-operatively, but it was clinically not significant. So I'd like to conclude by saying that administration of 3% hypertonic saline did not reduce the perioperative maintenance fluid requirement in patients undergoing major open abdominal surgery. However, the incidence of adverse events related to the use of hypertonic saline. Here I would like to highlight why we chose this topic is because The ideal fluid regimen should be something which will maintain the perfusion, but at the same time, it will avoid fluid overload. Applying that concept.
Dr. Behra, can I just interrupt you? You've just overshot your time quite a fair bit. Why you chose the study should have been a part of your presentation itself very quickly. So that would have been a very good addition to the study. However, just a quick question. I just wanted to ask, what was the total amount of fluid that you hypertonic saline that you infused, and over how much duration was it?
Ma'am, it was varying from case to case based on it was given at the rate of 1 ml per kg per hour.
What was the maximum amount of hypertonic saline did you infuse?
Ma'am, it has gone till 10 hours total duration in one surgery. It has gone till 10 hours, and it was around 70 ml per hour. So it was 700 ml.
So what is the maximum? Sorry, ma'am. What is the maximum dose of hypertonic saline you can infuse over that period? And what is the maximum speed?
Yes, ma'am. The maximum dose, it should not be exceeding. Whenever we start correction for hypernatremia, the dose should not exceed 12 millimole per day for a patient. And here we were maintaining, doing serial ABGs every 2 hourly and keeping a tap on the serum sodium level. And however, in none of the patient till now, the serum sodium level exceeded 145 milliequivalent.
I think, Narmada, any more questions? Okay. I think.
No, ma'am. Thank you.
Yeah. Yeah.
Okay,
thank you.
Then our next speaker is Abhishek Murugan. Next participant is Abhishek Murugan. Is Abhishek present? Then we
Abhishek, are you there? Abhishek?
I just want to reiterate again, please stick to your 3 minutes. You're all, you might stand a chance of being disqualified because you're going over time.
So next, we will switch to Sweta Mahanti.
Yes.
Next
Switch to
presenter is
next.
Sweta Mahanti. Sweta Mahanti.
Yes, ma'am.
Shweta, can we proceed?
Am I audible, ma'am?
Yes, you are audible. You start your presentation.
Just share your screen. Time start.
Good evening, everyone. I am Dr. Shweta Mohanty, second year PGT. I am going to present on comparison of pericapsular nerve group block with femoral nerve group block in providing analgesia for hip fracture surgeries by a randomized comparative method.
Okay, Sweta, continue presenting.
Yes, ma'am. Hip fracture is a frequent orthopedic emergency in elderly patients, and it is associated with significant morbidity and mortality. Surgical reduction and fixation are the definite treatment in most patients. And to decrease the pain around hip capsule, femoral nerve block has been commonly used, but it causes significant quadriceps weakness and impedes post-operative mobility. Recently, it was studied that the hip joint is supplied mostly by 3 important nerve fibers. One is femoral nerve, which gives its articular branch. Second is obturator, and third is accessory obturator. All these fibers give nociceptive fibers to only the anterior capsule, and the posterior capsule is provided by only the proprioceptive fibers from superior gluteal, inferior gluteal, nerve to quadratus femoris, and sciatic nerve. So the pericapsular nerve group block, which is a sensory block, was developed to block these fibers, obturator, accessory obturator, and femoral nerve. So the objective of our study was to compare pericapsular nerve group block with femoral nerve block in providing analgesia in hip fracture surgeries by single center double-blinded randomized study. So we chose patients who presented with hip fracture and were more than 45 years of age and didn't have any contraindication for regional anesthesia. 60 patients were chosen and they were randomly allocated to receive femoral nerve block with 20 ml of 0.75% ropivacaine, and the other group was chosen to provide pericapsular nerve group block with 20 ml of 0.75% ropivacaine. So how was this femoral nerve group block done?
You have only 11 seconds left.
I think you can skip the description how you did it. You can go to the result directly.
Yes, ma'am. After doing the blocks, it was found that 63% of patients in PENG block showed no pain, while only 30% patients showed no pain. And in the quadriceps strength, there were only 60% of patients who had intact strength in the PENG group, and only FNB group, no patients had any quadriceps strength retained. In the post-op day 1, 90% of patients had intact strength, while only 50% of patients had intact strength. So we can conclude from this that PENG block provides better analgesia than FNB in providing analgesia, and it also has the added advantage of preserving the quadriceps strength. Thank you.
Dr. Shweta Manti, what were the studies that, what were the surgeries that were included in your study?
Ma'am, any fractures which included the head of the femur or the acetabulum, those surgeries, for those fractures, the surgeries were done. The surgeries included were intramedullary nail, total hip arthroplasty, hemiarthroplasty, cannulated screws, and gamma nails.
So how did you address, what is, the incisions are mostly along the lateral side of the thigh, isn't it, in most of the surgeries? So how did you address the cutaneous pain coming from the cutaneous fibers of this lateral side? In your group, which was specifically where you had given PENG block?
For the lateral side, the lateral femoral cutaneous nerve was blocked, and also
in both the groups?
Ma'am, for the lateral, yes, ma'am. It was included for both groups because for the incision side, it had to be covered in the both groups because the lateral femoral cutaneous nerve supplies the lateral side of the thigh. It is not provided by femoral nerve or obturator nerve or any other nerve. So it had to be blocked for the incision part. But for the articular part, the PENG block was more superior to femoral nerve because the articular branches could only be blocked in that group.
So shouldn't your title say a combination of PENG and LFCN and femoral with LFCN? Shouldn't your title say that?
Yes, ma'am. But our objective was to compare PENG and femoral, and this was mostly for comparing the analgesia part.
So Narmada, your questions, please.
No, thank you. Its time is already up. So.
Now,
thank you, Dr. Shweta. Thank you. You can
now
have the
the next speaker is Prithimoy Naik. Next participant is Prithimoy Naik.
Thank you, ma'am. Ma'am, namaskar.
Priti, please start presenting.
After sharing, ma'am.
Share screen option.
You share your screen and then start.
Okay, ma'am. Thank you. Good evening to all. Today my topic of presentation is comparative.
Screen is not visible.
The screen.
Yeah. There's a screen share button.
No, screen is not
Green
visible.
button. There's green button. Middle bottom of this. There's a share screen button. There's a green button. You can see?
Yeah.
Yeah.
Now it is
Can I
visible,
present?
sir.
Very
Yes.
good.
Yes, please.
Very good evening to all. Today my topic of presentation is comparative study of ProSil LMA over standard LMA in pediatric patient, a randomized control study. Coming to introduction, the LMA was introduced in clinical practice in pediatric patient in securing airway in 1980. A ProSil LMA, a new LMA with modified lobal cup and esophageal drainage tube was introduced in 2008 with intention of providing a more securing airway for air management in pediatric patient. Coming to background, the main concern with use of standard LMA in pediatric patient is that its low pressure seal might be inadequate for positive pressure ventilation, so that there is a risk of gas leakage in stomach with subsequent risk of regurgitation. The new ProSil LMA has been shown to form a more effective seal than standard LMA due to higher sealing pressure and to facilitate of gastric tube placement and to reduce incident of regurgitation. Coming to material method, a randomized control trial of crossover varieties was performed after ethical committee clearance and with written parental consent of 30 patients at Shishubhavan SCVMCH, Cuttack. Then inclusion criteria are include age 3 to 4 year, ASA grade 1 and 2, schedule for elective genitourinary surgery. Then coming to exclusion criteria, ASA grade more than 2, risk of aspiration, anticipated airway difficulty, mouth opening less than 1.5 centimeter. Coming to method, the patient who meet the above criteria were shifted to OT. Then all monitor are attached and pre-medication were done with injection glycomidas and fortuin and pre-oxygen for 3 to 5 minutes. After that, induction was done with inhalational sevoflurane. After spontaneous cessation of the lungs ventilation, then ProSil LMA and standard LMA were inserted in random order in each patient. After that, maintain with nitrous and oxygen with 2:1 ratio with intermediate sevoflurane. After that, complete cessation of the anesthesia, then airway leak pressure and maximum tidal volume are recorded in 3 positions. Then coming to statistical analysis was performed by using a pair t-test, Wilkinson test, and chi-square test. Result was considered statistically significant when p-value is less than 0.05. Coming to result from the table number 2, the airway leak pressure and the maximum tidal volume were significantly higher for the ProSil LMA, where p-value is 0.001 in 3 positions. From the table number 1, we can concluded ease of insertion and quality of airway, quality of initial airway were similar for the both device. Air entry in the stomach occur more frequently with standard LMA, where p-value we found is 0.005 and gastric tube placement were possible in all patients. Coming to conclusion, the ProSil LMA are more advantage than standard LMA. The high reliability of gastric tube placement and significantly increase the airway leak pressure might have important implication for the use of this device for positive pressure ventilation in pediatric patient. The unique design of pediatric PLMA seems to be beneficial as indicated by high fast placement success rate and high rate of anatomically correct position. My reference and thank you.
Dr. Preeti, how did you calculate your sample size? You have not mentioned about the sample size.
And sample size concluded by 95% confident interval.
No, from where? How did you do that? What was your power of the study?
And certain formula is there.
And what do you mean by crossover study? You have mentioned there is a crossover study.
Ma'am, crossover study is that we take a same patient and use two different device in same patient.
You did that?
What? Huh?
You did that in your study?
Yes, ma'am.
I didn't see the protocol saying you did both. Okay, thank you. Ma'am, Srividya ma'am, your turn.
Thank you, ma'am.
Just one question. ProSil LMA has been very well established about causing less gastric insufflation and good airway seal. I just wanted to ask, how is your study different from other studies which have compared ProSil and standard LMS?
Ma'am, question again.
Has this study been done previously?
Yes, ma'am.
It has been done previously?
Yes.
So what new did you want to check when you wanted to do this study? Were your results different from that which has been done before? Okay, thank you. Thank you. We can move to the next speaker, Dr. Kalyani.
Next participant is Bhagyalakshmi M.
Yes, ma'am.
Next
Hello.
speaker is Bhagyalakshmi M.
Yes, ma'am. Hello.
Hello. You are audible. Share your screen.
Yes, ma'am. I have already shared.
Yes, your screen is visible.
Yes,
Now
ma'am.
you can start your presentation.
Yes, ma'am. Good evening, everyone. Today, my topic is anesthetic management of a case of Croson syndrome. Croson syndrome is an autosomal dominant genetic disorder primarily characterized by a premature closure of the fibrous joint between certain bones in the skull and distinctive facial abnormalities. A 3-year-old female baby of 10 kg weight was planned for reconstruction of craniosynostosis. She underwent VP shunt on August 2019. She had a history of upper respiratory tract infection since birth. Her mother gave a history of snoring episode with mouth breathing. Craniofacial examination revealed a malformed skull with flat occiput and a prominent forehead with frontal bossing and mild exophthalmos, divergent strabismus, and a compressed nasal bridge, and mild mandibular hypoplasia, maxillary macrogranthia. Airway examination, difficult airway was anticipated, difficulty bag mask ventilation was anticipated, and the Copper scale score was 12, indicates difficult airway. Coming to the anesthetic management, stress was laid on the possibility of the difficult intubation and the need for mechanical ventilation in the PICU postoperatively along with emergency tracheostomy. In pre-anesthetic unit, a 22 gauge IV cannula was secured and IV fluid was started, isolate P 40 ml per hour maintenance. A difficult airway cart was prepared and standard monitors were attached. A 4 centimeter towel was placed under the shoulder for better laryngoscopic view. A pre-medication with injection glycopyrrolate 10 mics per kg IV and patient induced with 100% oxygen and sevoflurane concentration with titrated dose through a Jackson-Rees circuit, maintaining spontaneous ventilation. Check laryngoscopy was done, which revealed the Cormack-Lehen scale score 3. An oral airway was placed which ensured adequate bag mask ventilation, and the plane was deepened with injection fentanyl 2 mics per kg and injection propofol 2 mg per kg, maintaining spontaneous ventilation. Direct laryngoscopy was done with Miller blade size 1 and lubricated uncuffed flexometallic ET tube size number 4 was inserted and fixed at 12 centimeter. Followed by muscle neuromuscular blocking agent injection atracurium 0.5 mg per kg loading dose and 0.1 mg per kg maintenance dose given every 30 minutes, and maintenance of anesthesia was done with sevoflurane 2%. Intermediate dose of fentanyl and muscle relaxant was given. At the end of surgery, sevoflurane was switched off and the patient extubated. Further O2 supplementation was provided and shifted the patient to the recovery room in lateral position. Postoperatively, monitoring was done for 2 hours and thereafter the patient was shifted to the ward. Patient did not have any desaturation postoperatively. Coming to the discussion part, the most challenging aspect in a case of Croson syndrome is airway management during any surgery performed under general anesthesia. Our case had an inspiratory stridor and deviated trachea, which is clearly visible here. You can see the chest X-ray and intercostal retraction and a floppy epiglottis. General anesthesia may increase the severity of respiratory distress with an inability to assess the ventilation and require emergency tracheostomy. In this patient, tracheostomy is also technically difficult and may lead to complication. Therefore, we were prepared for emergency tracheostomy with ENT specialist as a standby. Coming to the conclusion part, to conclude, anesthetic management is very challenging in patient with Croson syndrome, especially when airway management is considered. Very careful planning should be carried out before the procedure, and alternative plan should be in place of an emergency tracheostomy, and proper pre-anesthetic examination and the use of inhalational induction and awake extubation are the key aspect of the successful management of such cases. These are my reference. Thank you. Thank you, ma'am.
Well presented, Dr. Bhagyalakshmi.
Yes, ma'am.
what other alternative technique could you have used? Do you is it possible to do something else instead of doing an awake say intubation with a spontaneous respiration? Would you have
Yes, ma'am.
preferred something else also? Would it be
Yes, ma'am. We
possible?
can. Yes, ma'am. Fiber optic intubation we can give, or else after muscle relaxant also we can do, ma'am. Since it is difficult intubation, difficult in airway anticipated, we preferred spontaneous ventilation, ma'am, for intubation.
So why didn't you choose fiber optic as an option?
Ma'am, actually, it was done by, I mean, airway is not very difficult, ma'am. So we didn't prefer that fibro.
So what was the simple
It's not.
maneuver if you would have failed for this intubation? What is the simple maneuver you would have done? Change in maneuver.
Ma'am?
This was mostly it's a hydrocephalus, right?
Yes, ma'am.
So what is the simple maneuver you would have done if you would have failed for intubation?
Ma'am, Selix maneuver.
Why Selix? What is Selix maneuver?
Ma'am, Selix maneuver, we should give cricoid pressure for children 7.7 Newton.
Okay, thank
and
you.
And LMA also we can prefer, ma'am.
Okay.
Thank you. Now our next participant.
Kavuru Swapna.
Kaburu Sapna.
Yes, ma'am.
Please share your screen.
You are the next participant. Please
Yes,
share
ma'am.
your screen. Please share your screen.
Let me share screen button on the screen. Just share your screen.
Ma'am, shall I start, ma'am?
Yes, you can start
Just
now.
share your screen.
Please share your screen first.
Yeah, ma'am. Share, ma'am.
No,
Screen
your,
share.
There's a green button on the display.
you are visible, but your
Share
screen is
screen.
not visible.
1
Share
minute.
screen. There's a green button. You can see?
Ma'am, now.
Yes, yes.
Yes,
Ma'am, shall
now
I
it is
start, ma'am?
visible.
Now you can start.
You can start now.
Good afternoon, everyone. I am Dr. Kavuru Swapna, pursuing my second year PG in SCB Medical College. Today, my topic of presentation is comparison of the analgesic and anesthetic effects of intrathecal levobupivacaine with intrathecal hyperbaric bupivacaine for electrocaesarean section. Coming into introduction, spinal anesthesia is a safe technique for administering anesthesia for caesarean section due to its rapid onset and effective sensory and the motor blockade. Bupivacaine is available as a racemic mixture of its enantiomers, dextrobupivacaine and the levobupivacaine. The present study is performed to compare the analgesic and anesthetic effects of levobupivacaine and bupivacaine in the subarachnoid block. Coming into materials and methods, total 60 parturients satisfying the inclusion criteria, aged between 20 to 40 years, belonging to ASA class 2, without any uncontrolled comorbid diseases, admitted for the electrocaesarean section are taken into study, were double-blinded, prospectively studied, and randomly divided into two groups. And among those, group L has received 2 ml of the 0.5% isobaric levobupivacaine of 10 milligram, and group B received 2 ml of the 0.5% hyperbaric bupivacaine of 10 milligram intrathecally in the L3-L4 space with the 25 gauge Kincaid needle after free flow of the CSF is obtained in the sitting posture under all available aseptic precautions. Onset of the sensory and the motor blockade, 2-segment regression time, and time taken to regression to bromide grace 0, and hemodynamic parameters like mean arterial blood pressure and the heart rate is noted. Demographic data like age and weight were comparable in both the groups. Unpaired t-test and chi-square test were applied to know the difference between the two groups, and the value of p-value of less than 0.05 was considered statistically significant. We found that early onset of a sensory and the motor blockade and early motor regression to bromage grade 0 and slow 2-segment sensory regression time in group L when compared with the group B. Here I have mentioned in the tabular form of onset of the sensory blockade and onset of motor blockade, 2-segment regression time and time taken for the regression to bromage grade 0 and the corresponding p-values.
Coming into the discussion, spinal anesthesia is preferred in the LSCS due to its rapid due to its less side effects. For cesarean section, adequate sensory and the motor blockade and better hemodynamic stability with minimum adverse effect is necessary. Hypotension and bradycardia, which are the usual complications of the spinal anesthesia, are more serious in the cesarean section because of the aortocaval compression by the gravid uterus. And already on this topic, prior two studies has been done in 2015. One of them is Rashmi Dugal, conducted her study, and she has done study for the comparison of the duration of the motor blockade, and she has found that it is shorter in the group L than in the group B. Means the one who has received levobupivacaine is having the shorter motor block compared with the one who received the bupivacaine. And Ayesha Ghoshal has done her study in 2015. She has taken two groups. One group is BF, who received the 2 ml of the hyperbaric bupivacaine 10 milligram with fentanyl 25 milligram, and group LF received 2 ml of isobaric levobupivacaine and the fentanyl 25 milligram. The total volume of 2.5 ml intrathecally in the elective cesarean section found the similar onset of the sensory blockade and similar onset of the motor blockade, but the hemodynamic stability was better in the group L than compared with the group B. And coming into the conclusion, from the study, I conclude that 10 milligram of the 0.5% levobupivacaine, when given intrathecally in elective cesarean section, had earlier onset of the sensory blockade with the earlier regression of the motor blockade, and they are having the stable hemodynamic parameters and decreased incidence of the adverse effects in the levobupivacaine group than compared with the bupivacaine. So I conclude that 0.5% isobaric levobupivacaine is better alternative to the 0.5% hyperbaric bupivacaine in the elective cesarean session. And these are my references.
Thank you, Dr. Swapna. But what is new in this study? You have told before 2 studies were being done. What is new in your study?
Ma'am, in one of the 2 studies, they have compared only the motor blockade, and another one also they have compared only the motor blockade. They have taken the fentanyl along with it. Here I haven't taken any other additive is not taken. Only I have taken levobupivacaine and bupivacaine, and I have compared the side effects also, ma'am. Onset of the sensory blockade, onset of motor blockade, along with that regression also I have taken into account, ma'am. Prior studies they haven't taken the bromase, they haven't compared with the bromase scale. Now but in my study I have compared with the bromase scale.
And one more thing is, while making poster, probably you would have made a better poster. It's like writing in the journal. The poster looks like it's written in journal. Okay, it's over to Vidya ma'am.
No questions from my side, and the same thing I was going to say. You need to make your presentation a little bit more better, because it was like when you write a paper or you write a thesis, that is how it was. Okay. Otherwise, it was a good study and well answered your questions.
Okay.
So thank you, Swapna. Our second participant, Dr. Abhishek Murugaya, was absent due to some technical problem, but now he is able to join.
Yeah.
Hello.
Wait, can we keep him for last? No. Can we keep him for last?
Okay. We'll keep him for the last.
Yeah.
So okay. So now our next speaker is Niharika Varik. Dr. Niharika Varik.
Just share your screen, Niharika.
Please share your screen, Niharika. Please share your screen.
Hit the green button on the screen. Yeah. Start.
Good evening, everyone. My topic is anesthetic management in ventricular septal defect with pulmonary hypertension posted for emergency surgery. Case report is a 40-day-old male baby with ventricular septal defect and pulmonary hypertension present with the symptoms of acute abdomen with no history of cyanotic spell or respiratory tract infection. On examination, peripheral was cold, patient was drowsy, tachycardia, heart rate was 166 per minute, blood pressure was 90 by 57 mmHg, saturation was 98% with oxygen 2 liter per minute. On systemic examination, patient was tachypneic. On auscultation, bilateral air ventre was present with basal crepitation. Cardiovascular examination was pan-systolic murmur over the left parasternal border. On investigation, hemoglobin was 12.2 gram per dl. Liver function test, renal function test, and coagulation profile was normal. Echocardiography shows 2 mm sub-aortic ventricular septal defect with left to right shunt with peak gradient with peak pressure gradient across it is 79 mmHg with moderate pulmonary hypertension with peak pulmonary artery systolic pressure of 45 mmHg with the left ventricular ejection fraction of 64%. Anesthetic management was patient was taken up for surgery with high risk concern and ICU backup. IV fluids was continued as before at the rate of 8 ml per hour. Care was taken to avoid any kind of bubbles in all the lines. Nasogastric tube was given for gastric decompression. Standard monitoring with ECG and non-invasive blood pressure, pulse oximetry, capnography, temperature, and immunotherapy was done. Pre-medication was done with glycopyrrolate 4 mg per kg and fentanyl 2 mg per kg. Pre-oxygenation was done with 60% oxygen for 3 to 5 minutes with spontaneous respiration. Induction was done with inhalation agent sevoflurane 2% and succinylcholine 1 mg per kg. Oral intubation was done after 30 seconds of minimal low tidal volume intermittent positive pressure ventilation with cricoid pressure using Miller's blade 1 and endotracheal tube size 3 and it is fixed at 9 cm. Maintenance done with air and oxygen at the ratio 1:1. Sevoflurane of maintaining MAC 1.5. Intermittent dose of fentanyl and cisatricin was given. Positive pressure ventilation with PEEP was done for maintaining normal capnia with FiO2 50 to 60%, targeting saturation 90 to 95%. Caudal analgesia was achieved with injection ropivacaine 0.2%, 2.5 ml. And inotropes was given in dobutamine at the rate of 10 mics per kg per hour after establishing the central line in right femoral vein of 3 French and double lumen. On laparotomy, diagnosis was confirmed as colonic atresia and colonoscopy was done. But as the patient was already in respiratory distress and on inotropic support, so patient was shifted to ICU and patient was extubated after 2 days with good respiratory effort and weaning from the inotrop. The main anesthetic goal was avoidance of bubble, optimizing oxygen delivery, ventricular function, decreasing the shunt fraction, and maintaining the SVR and PVR.
Already overshot by a lot, so please go to the discussion and conclusion part.
Our conclusion was though the VSD with portal hypertension require advanced and invasive monitoring, but it is very difficult to do in emergency settings, so it is not practical feasible. So with proper anesthetic plan, we can decrease the morbidity and mortality. So.
Narmada, any questions from your side?
Yeah, what are the factors which will aggravate the hypertensive crisis, pulmonary hypertensive crisis? Indirectly, what are the factors you'll avoid?
Hypoxia, hypocardia, and hypothermia, and sympathetic stimulation, like pain, crying of the patient.
Okay, thank you.
Did you monitor temperature of your patient, and if so?
Yes, we monitor temperature.
How did you take care of the temperature thermoregulation in this patient?
Warming devices were there.
Can we go to the next? I think. Thank you.
Okay. Okay.
Well presented, Niharika.
Next speaker is Minal M. Dr. Minal M.
Hello, ma'am. I'm audible, ma'am.
You are audible. Share your screen.
Ma'am, is it visible, ma'am?
Yeah, it is visible now.
Yeah,
You
good
can start your
afternoon.
presentation.
Yeah, yes, ma'am. Good evening, judges. Today I'm Dr. Meenal from IMS Some Hospital. I'm presenting my poster of anesthetic management of a patient with frontoethmoidal encephalocele. Coming to introduction, encephaloceles, especially in the frontoethmoidal region, are a form of neural tube defect affecting the patients mostly in Southeast Asia than in Western countries where occipital region encephaloceles are common. Encephalocele is defined as protrusion of cranial contents beyond the normal confines of the skull. They may contain meninges, brain matter, and meninges, communicate with ventricles. Frontoethmoidal meningoencephaloceles are common in Southeast Asia, as I mentioned earlier, with the incidence of 1 in 5,000 live births. Encephaloceles can be congenital, acquired, secondary to tumor, hydrocephalus. Its etiology could be ethnic, genetic, or environmental factors or based on paternal age. Coming to case report, 1-year-old male baby of 13 kg presented with complaints of swelling in front of the nose, extending from root of the nose to the nape, which was progressively increasing in size since birth, was posted for meningomyelocele repair. Mother had a history of consanguineous marriage and inadequate intake of folic acid tablet, and she gave a history of baby which had a snoring history. On examination, baby was conscious, active with pulse rate of 123 per minute and saturation at room air at 98%. Coming to airway examination, during pre-anesthetic checkup, difficult bag and mask ventilation was anticipated. Coming to swelling, a 10 cross 10 centimeter smooth, soft, pulsatile, and lobulated swelling extending from the root of the nose to nape was observed. There were doubts on achieving perfect seal with the face mask. Copper scale of 11 was obtained, which predicted difficult bag and mask ventilation. Coming to our anesthetic management, written informed consent was obtained for anesthesia. Stress was laid on the possibility of difficult bag and mask ventilation and intubation and need for mechanical ventilation in the pediatric intensive care unit postoperatively, along with an emergency tracheostomy. After checking adequate status of nil per oral, in the peri-operative room, 24 gauge IV cannula was secured, IV fluid started, and antibiotic prophylaxis was given. In the operating room, a difficult airway cart was prepared and standard monitors were attached. Shoulder roll of 5 cm approximately was placed. Pre-medication with injection glycopyrrolate of 10 mics per kg IV was given. Induction was started with 100% oxygen and sevoflurane by titrated dose. By maintaining spontaneous respiration, check laryngoscopy was done by using Miller Blade 1 and which revealed chlormaclean grade of 3A. Injection fentanyl 2 mics per kg was given. After that, an oropharyngeal airway was placed. After confirming adequate bag and mask ventilation, muscle relaxant of injection atracurium beslate of 0.5 mg per kg was given and endotracheal intubation was done with 3.5 m cuffed tube and fixed at 13 centimeter. Anesthesia was maintained by muscle relaxant atracurium of maintenance dose of 0.1 mg per kg, sevoflurane of 2%, and intermediate dose of fentanyl were given. Intraoperatively, baby was hemodynamically stable. At the end of surgery, sevoflurane was switched off after administration of injection neostigmine 0.6 mg plus injection glycopyrrolate 0.1 mg. Awake extubation was carried out once the extubation criteria had been met. Further oxygen supplementation was provided and baby was shifted to PICU for observation. Coming to discussion, the most challenging aspect in a case of frontoethmoidal encephalocele is an airway management during any surgery performed under general anesthesia, especially bag and mask ventilation. Problems in present case included swelling in front of the nose extending from the root of the nose to the nostrils, making the bag and mask ventilation difficult. Increased ICP, difficult airway due to large occiput, large tongue, small mandibular space, and narrow oral aperture. Coming to conclusion, to conclude my poster, anesthetic management is very challenging in patients with frontoethmoidal encephalocele, especially when airway management is considered. Careful planning should be carried out to the procedure, and alternative plans like tracheostomy, fiber optic intubation should be in place. Key aspects for successful management of such cases are proper preoperative examination, use of inhalational agent, and awake extubation. Thank you, ma'am. I reference.
What was our plan B for the intubation?
Ma'am, if it would have been cannot ventilate, cannot intubate, go for supraglottic airway devices, ma'am. Then then we can go for like fiber optic at last cricothyroidotomy and at last tracheostomy, ma'am. Since fiber optic was not available in our institution, so spontaneous respiration we maintained, and check laryngoscopy was done. Then we planned for intubation, ma'am.
Okay.
Yeah, thank you. I think that's all, and we can move to the next presentation.
Thank you, ma'am. Thank you, ma'am.
Thank you, Minal.
Thank you, ma'am.
Our next participant is Dr. Anurag Parida. Anurag, please share your screen.
Yes, ma'am.
Please share your screen as well. Anurag,
Yes, sir. Yes, sir.
please share your screen.
Please share
Yeah.
your screen.
Is my screen visible?
Yeah, visible.
Now it is visible. You can
Okay.
start your presentation now.
Okay, ma'am. Thank you, ma'am. Good afternoon to everyone. I am Dr. Anurag Parida, second year PGT from Department of Anesthesiology and Critical Care, SV Medical College, Cuttack, and I am going to present a poster on the topic of use of Prosil LMA in patients undergoing elective LSCS under general anesthesia. Coming to the introduction part, anesthesia per cesarean section poses many challenges due to various anatomical and physiological changes in the airway and respiratory system, which are unique to the pregnancy. These changes make these patients vulnerable to desaturation and possible difficult airway. The choice of anesthesia in these patients depends upon the indication of the surgery, maternal status, and degree of urgency. However, general anesthesia is necessary in certain situations. Supraglottic airway devices are emerging methods to secure airway, especially in difficult situations. Among these devices, ProSeal LMA is designed to provide better protection of airway. The use of ProSeal LMA has been reported successfully as a rescue device in these patients without any complications. So here we have used ProSeal LMA in patients undergoing LSCS and compared ETT for airway protection, hemodynamic stability, and complications. Coming to materials and methods, total number of 60 pregnant patients scheduled for elective LSCS under general anesthesia were enrolled in this prospective randomized study. Patients belonging to category of ASA grade 1 and 2 were selected, and the patient having fasting less than 6 hours, known and predicted difficult airway, case of GERD, obesity, hypertensive disorders, and refusal of patients, these patients are excluded from this study. Standard anesthesia protocol was followed, and all patients received aspiration prophylaxis. Airway is maintained by either Prosil LMA or ETT. Coming to the observation part, parameters including difficulty at insertion, adequacy of ventilation, hemodynamic changes at the time of removal of device, and aspiration and regurgitation were noted. And all the p-values of different parameters were calculated and mentioned in this tabular form. Coming to the statistical analysis, the recorded parameters including age, weight, and time of insertion were evaluated by unpaired t-test, and the rest of the parameters were evaluated by using chi-square test, where p-value less than 0.05 is considered significant. From all the above findings indicated that Prosil LMA was easy to insert, having an average insertion time of 20.67 second plus minus 6.835 second, which is comparable insertion time of ETT, which is 18.33 second plus minus 4.971 second, having a p-value of 0.136. Adequate ventilation was achieved with very minimal hemodynamic changes with Prosil LMA as compared to ETT at the time of insertion and removal of the device, having p-value of both of 0.01. The incidence of post-operative sore throat was minimal, with PLMA having p-value less than 0.05 as compared to ETT. There is no incidence of regurgitation and aspiration with the use of PLMA. From all the above results, we can easily say that PLMA is easy to insert with an insertion time comparable to UTT. Adequate ventilation was maintained with minimal hemodynamic changes. No incidence of regurgitation was noted with the use of PLMA, and sore throat incidence was also minimal compared to UTT. All the patients made an uneventful recovery, thereby suggesting that PLMA may be a safe alternative to UTT in obstetric patients. These are my references, and thank you all.
Thank you, Dr. Anurag. Do you routinely use general anesthesia for elective LSDS in your hospital?
No, ma'am. Generally, we don't use routinely as elective LSS or general anesthesia. Normally, spinal anesthesia is the preferred choice for anesthesia for normal elective LSS patient. As a study to be conducted, we prefer we use this general anesthesia as a experimental basis to find out where Rosalind or UTT, which we can use in better way for hemodynamic stability and all the parameters.
So when consent was taken from patients,
yes,
did you explain all alternative methodologies of anesthesia, and did they choose general anesthesia voluntarily?
Yes, ma'am. They were explained everything vigorously, and after explaining everything, we asked them to voluntarily, if you want to participate in this, you can enroll in this, and they have enrolled on their willingly.
Narmada, your questions, please.
Yeah, I would request all the residents to mention about the consent part, consent and ethics approval.
Okay.
That is a very important part of your paper presentation,
yes,
paper or poster, anything.
Yes, ma'am.
Okay, yeah.
Shall we switch on to the next speaker?
Yes.
Hello, thank you, Anurag, for your nice presentation. Our next
and again, the poster was like writing the journal, so the poster would have been made better.
Okay, ma'am.
Thank you,
next
Anurag.
speaker is
Thank you,
Sadasiv.
Dr. Anurag. Our next
Thank you,
speaker
ma'am.
is Dr. Sadasiv
Sadasiv.
Panda. Dr. Sadasiv Panda, please
Yes, ma'am.
share your screen.
Yes, ma'am.
Please share your screen.
I'm doing that. Is it coming?
No.
No.
No, it's not coming.
There's a share screen button on the screen.
I've done
Another
that.
participant is there.
Green color button.
If you want time, we can call you later on. We will allow that participant first, then we can call you.
Okay, ma'am.
Okay.
First open your PPT, then share screen.
I've done that, but not showing actually.
Okay, Vidya, I am calling the Abhishek Murugaya now.
Yeah. Okay. Then he can figure it out meanwhile.
So Abhishek Murugaya, you can, are you present?
Yes, ma'am, I'm there, ma'am. Can you hear me, ma'am?
You can join now. You can join now, and
Yes,
you please share your screen.
Yes, ma'am. Yeah, just a minute. Is it visible, ma'am?
Yes, visible. Just start.
Yeah, it is visible.
Yeah. Good evening, everyone. I am Dr. Abhishek Murugaya from AIMS Bhubaneswar, and I'll be presenting a poster on effect of 5% EMLA cream on post-operative sore throat following general endotracheal anesthesia, which is a randomized placebo-controlled double-blind study. So starting with the background hypothesis, post-op sore throat, cough, and hoarseness of voice is a common, uncomfortable, distressing sequelae after tracheal intubation. And it is a varied incidence of about 30 to 90%. Various methods have been tried to reduce the post, which had varied results. Wherein EMBLA cream, which is a eutetic mixture of local anesthesia, 2.5% of lignocaine plus 2.5% of prilocaine, it's a topical anesthesia which has been successfully used in a bronchoscopy procedure, but it has been never tried for post-op sore throat along with cough and hoarseness of voice. So we hypothesized that a 5% EMLA cream is more effective in reducing the incidence and severity of post-op sore throat as compared to a placebo. So our primary and secondary objectives are to assess the incidence and severity of post-op sore throat after general endotracheal anesthesia for elective surgery, and secondary objective to assess the incidence and severity of post-operative cough and hoarseness after general endotracheal anesthesia for elective surgeries. So after getting ethical committee clearance, patient randomization was done by computer-generated records, allocation concealment done by sealed opaque envelopes, and patients were divided into two groups, Group A and Group B. Group A are patients in control group who will be receiving 2.5 ml of lubricant jelly applied over the cuff of the ET tube, and Group B test group the patient will be receiving 2.5 ml of 5% EMLA cream applied over the cuff of the ET tube. So patients aged between 18 to 65 years of age, ASA 1 and 2 physical classifications, elective surgeries under GA with oral tracheal intubation, duration of about 1 hour to 3 hours are included in the inclusion criteria. And patient who is having a known allergy to local anesthetic, anticipated difficult intubation, difficult airway, use of nasogastric tube or throat pack, head neck surgeries, surgeries in prone position, recent URTI, chronic of COPD, and patient shifted to ICU without extubation are excluded from the study. So with the help of the previous study, considering a reduction in the incidence of post of 20% to be significant, we have recruited 103 participants in each group, which accounted for about 206 participants as sample size. So we have analyzed 172 patients as interim analysis out of 206 patients, and all the baseline demographic details are comparable between both the groups. So coming to the results, our primary objective, this is a bar diagram showing the post-op sore throat over different time points, that is at 0 hour, 2nd hour, 6th hour, and 24th hour following surgery. In all the time points, the incidence of post-op sore throat is less in case of patients who received EMLA cream than compared to the patients who received lubricant jelly. So coming to the severity of severity grading of more than 2 is considered severe post-op sore throat. And here also, incidence is less in case of EMLA as compared to the lubricant jelly. So coming to the secondary outcome results, post-op cough and hoarseness of voice at 0 and 2nd hour are less in case of EMLA as compared to the control group. So with this, we found that EMLA cream reduces the incidence and severity of sore throat and reduces the post-operative cough and hoarseness. There is no any adverse effect observed in our study, and we have compared our study with the previous study which have been done already. So with this, we conclude the application of EMLA cream over the endotracheal tube reduces the incidence and severity of immediate post-operative sore throat as compared to a placebo. These are my references. Thank you.
That's a good presentation, Dr. Murugaya. Just wanted to ask, is your study blinded? And if so, how did you blind it?
Yes, ma'am. So one thing is patient is blinded, and second thing is the person who is intubating will be blinded, ma'am.
What kind of surgeries were included in your study? I'm
yes.
just asking the duration of surgery. Does that affect your, like, the duration of drug and duration of surgery?
Yes, ma'am. Yes,
Does
ma'am.
that interfere?
For the EMLA cream to have action over the mucosa, it has to be shown that minimum 1 hour to be present inside the mucosa. So thinking that, accounting for that, we have taken minimal duration as 1 hour. And if, as such, with surgeries prolonging more than 3 hours, that duration, prolonged duration as such, will have a effect on the post-op sore throat. So we have taken the duration time span as 1 hour to 3 hours of surgery, active surgeries.
Okay, thank you.
I think we can move to the last speaker if he's ready to share.
Sadasip, Dr. Sadasip Pandey, are you ready?
Sadasip, are you ready?
Our last speaker is Dr. Sadasip Pandey. Are you ready now?
Sadasip.
Sadasip, are you present?
Are you ready to share your screen? Sadasip.
Sadasip, are you present?
Sadasip, please unmute yourself first.
Are you ready to share your screen? Sadasip? Hello, Dr. Sadasip? Hello?
Dr. Anurag, please see Sadasip is there or not.
Yes, you're.
Dr. Sadasiv, are you ready?
Can
Hello.
you share your screen, please? You're audible.
Ma'am, she is not.
He's there. He's there.
He is not there, Vidya.
No,
He's there. He
there.
can
I
be
can
he's
see
not
seen.
him in my
here with
screen.
me.
Please share your screen.
Just share
so
your
that's
screen.
it.
You are not audible. I think there is a network issue.
Dr. Anurag, please see whether Sadasiv is available or not. Anurag, are you there?
Yes, ma'am. Yes, ma'am. Ma'am, actually, sir, I am here in Cuttack, but Sadashiv is not here with me.
Okay.
Okay.
Sadasiv, are you able to share your screen now?
Anurag, please give a call to Sadasiv
Yes, ma'am. Yes, ma'am.
because the judges cannot wait for long time, no?
Yes,
I
ma'am.
think
Yes, ma'am.
Sadasiv has started
Yeah,
screen sharing.
Sadasiv started the sharing the video. Sharing the screen.
Hello, ma'am.
Sadasiv, you just shared the screen again.
He is audible, but he is not able to share screen.
Just there is a screen share button on the display.
I'm trying actually, but it's not.
Is your presentation minimized, Dr. Sadashiv? Yes, that's
Now
good.
your
We
screen
can
is
see.
visible.
Yes.
Please start.
Good evening, everyone. Myself, Dr. Sadasiv Panda, second year PG student from the Department of Anesthesiology and Critical Care, AC Medical College. I'm going to present the poster that is effect of dexmedetomidine added to the hyperbaric spinal bupivacaine for infraumbilical procedures. Coming to the background, various adjuncts have been used to prolong the analgesic effect of intrathecal bupivacaine. Dexmedetomidine, an alpha adrenergic receptor, is also used as a neuraxial adjuvant, which provides stable hemodynamic condition, good quality of intraoperative and prolonged postoperative analgesia with minimal side effects. Here we are going to compare two doses of dexmedetomidine, that is 0.05 mg and 0.1 mg, added to the hyperbaric bupivacaine, and going to see how it affects the block characteristics after the spinal anesthesia with respect to the onset and duration of the sensory and motor block. The secondary objectives here are we are going to study is hemodynamic effect, the duration of analgesia, and the occurrence of side effects. Coming to the material and methodology. 60, actually, it was a divide, ma'am. I have taken 60 actually. 60 adult patients scheduled for below umbilical surgery were randomly assigned into 3 groups. All the 3 groups were going to receive 3.5 ml of spinal injector that consists of 3 ml of 0.5% hyperbaric bupivacaine and 0.5 ml volume of containing either 0.05 milligram of dexmedetomidine, that is the group 1, D1, or 0.01 milligram of dexmedetomidine, that is group D2, or normal saline, that is group B. We are going to observe heart rate, arterial blood pressure, onset and regression of sensory and motor block, level of sedation. Also, we are going to assess the time of rescue analgesia, and also we are going to measure the adverse effect, if any. Going to the statistical analysis. Statistical analysis is used where chi-square test, ANOVA took his multiple post-HOC test, and SPSS percent 20. As a result, the mean time taken for the sensory block to reach the T10 dermatome and the motor block to reach Bromage 3 grade was significantly rapid in dexmedetomidine group as compared to the bupivacaine group. It is B versus D1 and B versus D2, where p-value is less than 0.001. And it was faster in D2 group as compared to D1 group. The time taken for the regression of sensory block to S1 dermatome and to the Bromage 0 grade motor block and the time to fast rescue analgesia were also increased significantly by the addition of the dexmedetomidine in a dose-dependent manner. That is B versus D1 and versus D2, and D1 versus D2 where p-value is less than 0.00. BRS square were also significantly lower in the dexmedetomidine group as compared to the bupivacaine group. There are no statistical significant difference in between the Ramsey sedation score, heart rate, blood pressure, and respiratory rate was observed. As a part of conclusion, addition of dexmedetomidine to the hyperbaric bupivacaine intrathecally produce a rapid onset of sensory and motor block, which prolongs the sensory and motor block, and the time to fast rescue analgesia requirement was significantly increase in a dose-dependent manner, together with stable hemodynamic parameters and minimal side effects. Thank you, ma'am.
Very well presented and very well, at least you kept very much up to time. So that is a very good thing here. How did you blind your study?
Ma'am?
Was your study blinded, and how did you blind your study?
Actually, I divided the study participant into 3 parts, 3 groups, and it was
I asked blinding, not randomization.
Actually, it's not a. I have not blinded them.
Okay. It's not a blinded study.
No, it's an observation study.
How did you take the sample size? How did you calculate the sample size?
With 95% confidence intervals and 12.5% of confidence limit, I have 95% of confidence limit and 12.5% confidence interval. I have calculated the size, sample size.
No, but what was your reference study? How did you take? Did you do a pilot or from another study? How did you take the power?
Yes, ma'am. It has been previously one different type of study was previously done like that. I have taken the reference from that one.
Okay, thank you.
Okay, thank you, Sadasi.
Thank you.
Vidya?
Papers are over, Kalyani?
Yes, ma'am. All the papers are over. Now, on
Vidya?
behalf of Vidya,
Yes,
Narmada, please.
Absolutely wonderful session. Thank you, Kalyani Appa. Thank you, Rekha Madam, Niveta Madam, everybody for giving me this opportunity to come and join.
Narmada,
Thank you, ma'am.
Narmada, please come on live.
Yeah, ma'am,
Narmada,
I'm
please.
there.
No, you are
I'm
not
seeing you.
visible.
Please come on live. We want to see you.
You are not visible, Narmada. Please share your video. Start your video.
Ma'am, my video is on.
But you are not visible.
Yeah, you are not
the issue
visible.
in ma'am laptops or phone cameras.
Okay, now in hall A, the valedictory and flag lowering ceremony and the result will be declared. Okay.
How am I going to send the?
You send it to me. Both of you decide, and then you give the mark on the scoring sheet and WhatsApp it to me.
Okay, fine.
Ma'am,
You sign. One of you has to sign at the bottom.
Yeah.
Ma'am, can I get Vidya ma'am's number so that we can discuss?
Yeah, please tell your number or.
Yeah. Narmada.
Vidya, you don't know. Vidya, you don't
in the
know
chat box,
Narmada's number.
Vidya, in the
I
chat
can
box,
pick it
you
up.
give the number.
I'll pick it up from I'll pick it up.
Okay. We are giving. I'm giving Narmada's number to
Yeah, I'll
Vidya.
put it in the Rekha ma'am. I'll put it in the chat box.
Okay, I'm doing
Thank
it
you,
now.
Rekha ma'am, Niveta ma'am, and Kalyani ma'am. And nice to see Vidya ma'am for the first time. I have never met.
But I've heard of you quite
That's
often.
why that's why we arrange in such a way both of you can meet. Okay.
Yeah, I've heard of you quite a lot, Narmada. Yes.
Okay,
You're
let's
one
go
of
to all A.
So this is Dr. Sri Vidya.
Yeah, ma'am, I know. Geeta ma'am always talks about her.
Oh yeah, she's my
Dr. Geeta
batchmate.
is with me.
Yes.
Yeah.
That's my batchmate. Yes.
Yeah.
Okay, please, this you can talk amongst yourself, and then you can just write it on the scoring sheet like this and post it here.
Okay.
Like this.
Okay, ma'am. Okay, thank you.
Ma'am, I can't see. You have to lower the.
Vidya, nice to see you.
So
After
nice
so
to see
many
you,
days.
Kalyanappa.
Nice
So
to see
nice
you.
to see you.
So nice to see you also. And thanks for accepting our request and so nicely judging the session.
It is so.
Thank you,
so
ma'am. Thank you,
nice.
Kalyani ma'am.
Yeah, Narmada, I'm just sending you my number in the chat.
Narmada,
Yes,
but you are not visible.
I don't know. My
Going to meet
camera is
you
on,
very soon.
ma'am.
Narmada, probably we are going to meet you very soon physically also.
Really? Are you calling me?
No, I am not.
Okay, ma'am. Okay, ma'am. I'll talk to you.
Okay.
Thank you.
Yeah, Narmada, I've just posted my number in the chat box.
Yes, I'm taking, ma'am.
Okay. Shall we come to the end of the session now?
Yes, yes.
Yes.
Bye,
Ma'am,
Kalyanipa.
Vidya, call me whenever
Yeah,
you
yeah.
are free.
Yes, absolutely.
Okay. Always missing you a lot. Both
Yes,
you
so
and
do I.
Narmada. Narmada,
Ma'am, we
can
also
you
miss.
remember? Can you remember we are having so many complications in emergency period and we are managing all the cases.
Yes.
All type of
Okay, ma'am. See
complications
you.
we are facing. Okay,
Yes, yes.
Narmada. Okay.
Okay, ma'am. Thank you. Bye.
हाँ वहीं पे वॉइस खोल दो। मैं पूछूं फिर इससे रोहित से रूम बंद करना है मैं बात कर लेता हूँ। मैं क्लोज कर दूँ ना।